Yeah, I just did some extras.
To Augusta, Georgia. Thank you all for being here. I do want to just start off a couple of moments, and we'll hear briefly from the president of Augusta University, who are our gracious hosts today. I'm Mark Newton, chairing the Speaker's Blue Ribbon Committee, Study Committee on Healthcare and Community Healthcare and Access, expanding access to affordable quality healthcare to all of Georgia. That's the goal behind a lot of what we do in the legislature. A lot of the money and a lot of the taxpayer money that we spend every year is based on that, and we're always trying to find ways that we can do it better and stronger. I do want to thank our committee. We like having we do a lot of work in Atlanta for 3 months a year for sure, which involves a lot of us being away from our home district. I'm proud to represent Columbia and Richmond County, City of Augusta in the House of Representatives. I do want to just go over real briefly our members who have come, just so you know, the ones who have come from all over Georgia. I might start, I think the furthest might be Chairman Darlene Taylor from Thomasville. I know on the way is Chairman Powell from Hartwell, Georgia. Chairman Rob Leverett from Elberton, Representative Devin Seabaugh from Marietta, Representative Anissa Jones from Macon, my hometown. Glad to have you participating, and Representative Debbie Buckner from the Columbus area. So I want to thank them all for making the trip over here and the commitment. Chairman Lee Hawkins is on the way nearby from Gainesville, Georgia, chair of our health committee in the House side. So we're certainly glad to have that. The basis for the meeting today is really a couple of things we want to look at. This afternoon, we're going to look at something that's important to all of us if we've ever, us or a family member has needed to call an ambulance and wanted them to be there like yesterday or 5 minutes before we thought about calling them. EMS and governance at the state level, and what are the challenges and what are the opportunities in emergency medical services, kind of the way we expect. We want the police to come, law enforcement when we need them. We want fire to come. We also want our emergency medical services to be available in that rare time, hopefully rare, when us or our family member or a friend needs it. So we're going to talk about that this afternoon. But this morning, we're going to start off the first portion of the meeting looking at something that's fairly important. We hear a lot across the country about health insurance and healthcare coverage, and certainly that is crucial. That is a big part of access to quality, affordable health care, like we talked about, especially making it affordable for families. Certainly, we want to look at that in more depth, and we're going to be dealing with that, I think, at our next meeting, which will be in Macon, Georgia. Still not back to Atlanta yet for our meeting, so we're excited to look over what are the programs for people under the poverty level in Georgia? What are the expanded programs for under the poverty level in Georgia? And then starting at 101% of the poverty level, what are the federal programs? They're sometimes generous federal programs that really don't cost the state anything, but we certainly have a role in making sure those are available. What's the role of our federally qualified health clinics, which also get some taxpayer assistance, along with some of our charitable hospitals that help take care of Georgians, whether uninsured or underinsured, which is a key role of things that we're seeing now with higher deductibles and copays. So that's going to be at an upcoming meeting. But as somebody has said, I can't remember who to quote, but you can have an insurance card, and if you don't have a doctor and a hospital and a nurse, you're not going to get better just looking at your, as much as I love having an Anthem card or Cigna or Aetna or whatever, it is, and it's an important role that we'll be discussing unless you have a physician there to take care of you or your family member, to direct the team and the entire team of nurse practitioners, PAs, physical therapy, nutrition, occupational therapy, all the different parts of that. We want to look today at, in particular, at physician retention and physician recruitment. In particular, how are we retaining in Georgia and recruiting to Georgia the next generation of physicians? We're currently somewhere between 39th and 42nd when it comes to physicians per capita in Georgia. It varies from different specialties. Primary care is a little tougher than that. Others are a little bit better. Certainly some areas are generously supplied, some areas are not. So that is something, what we want to look at is how are we going to retain and then also recruit to Georgia. Georgia since 1990 has grown from 6 million to 11 million people. So along with that and an aging population to boot, we're going to need some healthcare providers. It's anticipated that we may be 8,000 physicians short by 2030. So that's one of the things, the thing we want to spend this morning looking at are what are the programs we have, what are some programs maybe some other states are having. By the way, we have presenters from all across Georgia, and frankly, far beyond that. We have national level speakers who look at different states, programs that may have been tried. I love to learn from mistakes that others have made, so sometimes we want to look at a program and say, well, if we were to do that, we'd want to do it differently. So we look forward to hearing from so many of our strong presenters that we're going to hear from today. So that's our goal for today, is to look how can we strengthen this one particular area of Georgia's healthcare workforce, which is the physician pipeline, if you will. And so a part of that with the state's public medical center, the only academic public medical center in Georgia, and the home of almost 200 in 2028, I believe, a 200-year-old Medical College of Georgia. I'm welcome to introduce President of Augusta University and the Medical College of Georgia, Dr. Russell Keene, if you'll join us up here. And thank you for hosting us today and helping bring us in last night from all across Georgia. And welcome to say a few words to all those watching as well, because when we come across Georgia, a lot depend on our great house media services and the live streaming and even the recording to watch it later.
Well, thank you, Chairman Newton. We're delighted to host you here at Augusta University, and for all of our distinguished guests, welcome to LA, lovely Augusta. We're glad you're here. You are sitting at the birthplace of medical education in the state of Georgia. As Chairman Newton indicated, that in 2028, we will be celebrating 200 years of providing great physicians, great health care, and great translational research to improve lives across our state. And we welcome you here. So Chairman Newton and members of the committee, distinguished guests, thank you all for being here. Chairman Newton, thank you for the opportunity to host today's meeting and for bringing this important conversation to Augusta, where educating Georgia's healthcare workforce is central to our life-changing, life-saving mission. You understand the challenge not only as a policymaker, but as a physician and as a Medical College of Georgia graduate who has spent his career helping people in our community. The Medical College of Georgia at Augusta University, we've been training physicians for almost 200 years, but it's a little different here. We focus on translational research. Our students here aren't just trained in medicine, they practice it both in the laboratory and the bedside of the patient. Today, MCG has one of the nation's largest entering medical school classes with 304 students. That makes us the third largest medical school in the country. That combination of nearly 2 centuries of experience, national scale, and statewide reach gives us both a distinctive capability and a profound responsibility to help meet Georgia's physician workforce needs. I want to thank all of the members of the committee for continuing to invest in Augusta University and the Medical College of Georgia and all that we offer here. Just a short time ago, we cut the ribbon on the Columbia County WellStar Hospital, and we know that that wouldn't have happened without your advocacy and your belief in our mission. So I certainly want to thank the members of the committee, but also our local delegation. We have Representative Rob Leverett, who's serving on the committee with you, Mr. Chairman, but also we've got Representative Gary Richardson and Representative Brian Prince here. Thank you all for your continued advocacy and help of our mission as well. But we're grateful that you're all here, not just simply to study Georgia's physician workforce shortage, but to identify practical solutions. The problem and the issues that we're facing are well documented. Too many Georgians in too many communities have too few physicians, and too many families travel too far and wait too long for the care that they need. But Georgia's not without solutions and answers. We have strong institutions, we have committed partners, and proven programs that are already producing results. But we also understand at Augusta University that no one institution or one entity can solve these problems alone. Our opportunity now is to connect with one another and to connect those solutions. From the first time that a young Georgian imagines becoming a doctor, through medical school and residency, to the day that physician opens up a practice in one of our communities that needs one, we must strengthen every step of that journey. We know the challenge, but more importantly, we know what works. recruit Georgians, train them across Georgia, expand residency opportunities, and support them in practice. Chairman Newton and members of the committee, thank you again for bringing this conversation to Augusta. We look forward to showing you what is already underway and what's working, and that we'll continue to work alongside you and along all of you in this room to make Georgia the best place to live, to work, and to be cared for. Thank you all very much for being here. Welcome to Augusta.
Thank you, President King, and I appreciate y'all's hosting us and your graciousness and certainly the work that the entire team, and I know you lead a large team, and you'd be the first to admit that the team is what makes a difference here at Augusta University and MCG, and thank you for that. Glad to have Representative Billy Mitchell from Stone Mountain, Georgia, with us today. Thank you for being here, and Chairman of our Health Committee, Lee Hawkins from Gainesville, Georgia, and then down on the end, Chairman Butch Parrish of our Rules Committee and our Healthcare Oversight Committee from Swainsboro, Georgia. Thank you for being here and participating with us today. We're going to go and start on our topics, and we're going to start with Kelsey George, Senior Policy Specialist. I mentioned we have people from across Georgia and across the nation. So she's with the National Conference of State Legislatures, a valuable organization that helps us in the time we're not in session, and particularly to meet, to investigate different areas of policy. And thank you for being here. Please proceed.
Chairman, if I may.
Sure, hit your button there. Chairman Mitchell.
Mr. Chairman, if I may, I've had a complete tour of this campus trying to find this location, and I want to say our taxpayer dollars are being used very wisely on this campus.
Well, we do have a growing, I think just the highest enrollment ever in Augusta University and the medical college, along with the medical school, but also the entire university. And there is a decent amount of construction, and I'm glad you're here for the meet, and all you did was miss my intro, so you're good. Anyway, thank you. Kelsey, go ahead.
Thank you, Chairman, and thank you, members of the study committee. Again, my name is Kelsey George, and I'm a Senior Policy Specialist with the National Conference of State Legislatures.
Excuse me, can you pull that microphone down and a little closer if you can?
I'm a little short. We'll do this. I was invited to share nationwide and state trends on physician workforce, as well as state legislative efforts to address recruitment and retention. So the National Conference of State Legislatures, or NCSL, is the bipartisan membership organization for state legislators and legislative staff in all 50 states, DC, and the territories. NCSL staff like myself and my colleague Anissa, who you'll hear from later today, are nonpartisan. We do not advocate for or against any state policies, and my intention today is to provide you with data, research, and a menu of state interventions to consider given the unique needs of your constituents. So I'll begin with an overview of national and state trends and data. Then I'll provide information and state examples from state legislative actions, including data collection and analysis, graduate medical education, financial incentives, mental and physical well-being initiatives, and non-compete clauses. So let's begin first with data. As we just heard, the problem is very clear, and we know that data plays an important role in policymaking. It can inform policy priorities, given the unique workforce needs of your state, and it can provide a baseline to measure interventions against. Now, please note, I'm not going to dive into the sources, methodology, or specific findings for each of these resources, but my hope is to provide you with a plethora of options to explore more. The Health Resources and Services Administration maintains workforce data and projections on many health occupations, including physicians. These maps show the projected surplus, or supply minus demand, and the percent adequacy, supply divided by demand, for all physicians on the left and primary care physicians on the right. The deeper red or orange colors, including those in Georgia, represent a lower value range, suggesting a shortage of physicians. The blue tones represent a higher value range, suggesting a surplus. Now, this is a more specific breakdown for Georgia and its surrounding states. Georgia is projected by HRSA to have about a 67% adequacy rate for both categories, all and primary care physicians, in 2038. This is significantly lower than the national percentage adequacy that HRSA projects at 88% for all and 80% for primary care, and lower than some surrounding states like North Carolina. It is, however, higher than some surrounding states like Alabama and Florida for both, or Tennessee for primary care specifically. So staying with primary care specialty for a moment, this data comes from WWAMI, or a research center at the University of Washington. This slide shows the ratio of primary care physicians per 100,000 residents. The ratio in rural areas, shown in green, is significantly lower than those in urban, blue. This suggests that there's not just a shortage issue widely, but a maldistribution between urban and rural areas. And this is one of the key foci of state efforts to address physician workforce challenges by targeting rural communities that are impacted the most acutely. Now, in a 2025 policy brief, also from WWAMI, there is state-specific data for Georgia and other states, linked and shown in the maps here. The maldistribution challenge remains true. The deeper red or purple colors show more primary care physicians per 100,000, both in family medicine and internal medicine, both of which are generally primary care specialties. Now, this is also true when we look at other physician practice specialties. When we studied the distribution of cardiologists, neurologists, oncologists, and pulmonologists nationwide, and again, we see fewer specialists in rural areas per 100,000 residents. Looking specifically at Georgia again, we also see this in specialties like obstetrics and psychiatry, pictured on this slide and the next. WWAMI provides national comparisons and information on non-physician occupations as well, like midwives for obstetrics, and psychologists, psychiatric nurse practitioners, social workers, and counselors for psychiatrists. And again, we see on both of these that the deeper green means more physicians per 100,000 residents. So when we look specifically at physician retention, or keeping physicians in the workforce, we see, again, a focus on keeping rural providers practicing in rural areas. Data suggests that nearly 60% of physicians leave their first job within 3 years. Family physicians who participate in the National Health Service Corps, a program run by HRSA, are more likely than non-participants to practice in high-need areas, but retention declines over time, especially 3 to 6 years after residency. Adding to this challenge, most physician workforce development programs do not necessarily report retention outcomes. The American Association of Medical Colleges maintains data on medical graduate residency choices and practice after clinical training, as shown in this table. Again, I pulled information specific to Georgia, national averages, and surrounding states.
Can you hold on just a second on that? I want to make sure
Yes.
everybody, we understand this. This is a kind of a key thing that I was looking for, is how are we doing when we've expanded residencies? How are we doing keeping people who finish their residency? Now, there's one group of those who finish medical school in Georgia and then may go around the country to a great residency program, and we want them to come back. I don't know if that wouldn't be included in this, right? This would, this is just the ones who complete residency in Georgia and keep it. And obviously, you look at Florida, Tennessee, South Carolina. I appreciate you doing our region, since the Southeast is both growing, but at the same time has a growing need for physicians. So that's what this is.
Yes, that is specifically residents who complete their clinical training in Georgia, or for the other states in Alabama, and whether they stay in state or they move out of state after completing that medical residency.
Thank you.
So between 2014 and 2024, we see 58.5% of individuals, again, that completed that clinical residency in Georgia still practice in the state. This is higher than the national average at 55.7%, but we see that 41.5% of medical residents who complete their residency in Georgia move out of the state afterwards to practice in other states. Now, this is comparable to surrounding states, which range anywhere from 45.7% retention in Tennessee to 64.5% in Florida. And I want to note here that the variation among states also in part comes from states investing in a variety of strategies that contribute to a higher or lower retention rate for medical residents, which I'll talk a bit more about in a moment. Now, one last data source that I want to note for you all in retention is PRISM, or the Provider Retention and Information System Management. This initiative was started by primary care offices to collect standardized data on health professional retention from incentives like the National Health Service Corps, loan repayment programs, tax credits, and others. 32 states currently report data to PRISM, including Georgia and surrounding states. Research from PRISM data suggests that physicians are more likely than non-participants in these programs to continue practicing in the same area after their service commitment, but administrative support matters. And several factors inform the retention in health professional shortage areas, in particular, like work-life balance. Now, I've included a point of contact here for PRISM data in Georgia. While I wasn't able to pull Georgia-specific data, Tiffany should be able to help you. So now on to the fun part. What are states actually doing? And I'll start first again with data. States are going beyond supply and demand measures to understand who is providing what services, to whom, and where. There are so many data sources that can provide this type of insight. Licensure and relicensure processes present a unique opportunity to gather this information, as do compact authorities and professional associations. In addition, Medicaid agencies and insurance departments may be able to analyze the types or locations of services provided, offering additional insight. One resource that I'll note here is the Cross-Profession Minimum Dataset, which was developed by Veritas Health Solutions and researchers at Indiana University. This provides a framework for states to understand what data elements are consistent across health occupations and how data can be standardized to provide a clear and comprehensive picture of the health workforce. Now, we know that some states, like Utah and several others, are implementing the cross-profession minimum data set to better understand the health workforce in their state, and I'm happy to connect you with the leads on this project for additional information as well. Legislation may also establish the authorizations or the types of data that states must collect via agencies or licensure boards. This includes what data must be collected, either through specific language or broad themes that give agencies or boards flexibility. And some recent examples are included on this slide. Georgia, for example, expanded the behavioral health licensure boards that are required to participate in data collection this year. Now, I believe you'll hear from folks from the Georgia Board of Healthcare Workforce in a moment, but they also have several interactive data dashboards that can provide insight on Georgia-specific practice. A couple are highlighted here on health workforce, loan repayment, and physicians. The second strategy that I'll touch on here is graduate medical education, or GME, or the clinical residency training that physicians must complete in order to be licensed to practice. Historically, Medicare is the largest funder of GME. Research from the Fitzhugh Mullen Institute at George Washington University examined Medicare funding for clinical residencies, and they found that funding mostly goes to hospitals, and only 2% of Medicare GME occurs in rural areas. Updated research by the American Association of Medical Colleges found that in 2020, there were still significant disparities in Medicare payments per clinical resident across states. In part, this is because Medicare sets a resident cap for GME sites, which makes it less flexible to changes in local, regional, and national workforce needs. And GME sites are also only eligible for receiving Medicare funding after they receive accreditation, which requires significant upfront investment that is not supported under Medicare payments. To bolster GME programs, states have become policy laboratories for GME innovation, and we've seen this in 3 areas. The first is Medicaid payments to sustain new and existing GME programs, state appropriations to provide technical assistance or startup funding, and efforts to ensure transparency and accountability, including reporting requirements to ensure that GME dollars are spent to address and result in changes in the workforce shortages. You'll also see a note here on the Rural Health Transformation Program. Many states are establishing new or expanding existing GME training sites under RHTP, And 3 states listed here, Alaska, Indiana, and Wyoming, have enacted legislation specifically addressing GME and RHTP. Under the Rural Health Transformation Program, some states are prioritizing specialties like family medicine, obstetrics, and psychiatry. And many of these include rural residencies, where residents spend 100% of their time at a rural site, or rural rotations, where residents spend a certain amount split between urban and rural settings. Now, the question you're probably wondering is, does it work? And research has found for many years that 2 factors significantly increase physician likelihood of practice in rural or underserved areas. The first is if a physician grew up in a rural or underserved area themselves. The second is if they complete clinical training in a rural or underserved area as part of that residency. Now, several of the studies on this slide suggest that rural training better prepares medical students and residents for the realities of rural practice and the breadth of care that rural physicians tend to provide in remote or non-metro areas. Additionally, research shows that graduates are likely to practice within 100 miles of where they completed their clinical training, in part explaining some of the retention rates across states that facilitate clinical residencies in a variety of specialties and settings. Now, I'm not going to dive into the specifics here on the next couple of slides, but I'm happy to answer any questions you have on them or refer you to subject matter experts in those states as well. The pieces that I'll highlight for the sake of time are that each of these states achieved GME slot increases via legislative action. Some states leverage Medicaid, while others solely focus on state appropriations. Arkansas is a very recent example, and they are still in the development phase following the opening of a new medical school in Northwest Arkansas. Indiana is a particularly interesting example because they've measured the return on investment for every dollar invested by the state in graduate medical education. Missouri is increasing slots exponentially. They are aiming to add more than 360 residency slots in the next decade. And finally, Wisconsin is a long-term example, starting from a report that was released in 2004, which has since resulted in the creation of 300 new GME positions, rural training opportunities statewide, and a strong technical assistance center that serves as a model nationwide. So another very common strategy we see across states is financial incentives. This may include things like loan repayment programs, tax incentives, or other benefits. States often pursue these incentives to encourage providers to practice in rural or underserved areas, often tied to a service commitment. One note that I'll make here is that any workforce initiatives that are included under a state's Rural Health Transformation Program proposal, per CMS guidance, must include a 5-year service commitment. And most states have addressed this requirement in their application narratives for the relevant programs and initiatives. So why financial incentives? Physician pay depends greatly on the specialty and the practice location. Family medicine, a common primary care specialty, is often on the lower range for average pay nationwide, which may incentivize medical students to pursue higher paying specialties that tend to be concentrated in urban areas. I want to note here, however, that in the research that I shared earlier from PRISM, many physicians cited other factors, again, like administrative support and work-life balance, that affected their retention over things like compensation. Most states have a loan repayment program that applies to physicians, and some have expanded these programs to include other health occupations like advanced practice registered nurses, physician assistants, dental professionals, and allied health professionals.
Before you go off of this slide, do you mind,
Yes.
I just see for the Georgia areas, I was just looking at some, it had to do with a private medical school in Georgia, kind of an estimate of costs, and if you added it all up, including $65,000 in tuition and then living, it ended up a little over $400,000 as the cost for 4 years of and I was wondering on these, can you stack those if you go to a rural county? We have like 3 different loan repayment programs. Are they mutually exclusive? If you get 100 from this, well, you may not know, but maybe that's a question I want us to see if we can answer. I don't know how most states do it. Can you, like South Carolina has a couple of them. A lot of states obviously have more than one. I'm kind of curious, and we may have some people even on the committee that know, but somewhere down the line, I would like to hear, since someone could easily be $200,000, $300,000, $400,000 in debt, are there, if the right incentives to get people to go certain areas, do you know if those can typically be stacked or not?
So across the different types of financial incentives, so whether it's loan repayment, tax incentives, or other types of compensation or benefits, to my knowledge, physicians in most states can use several of those different types. I'm not sure of the intricacies of Georgia's loan repayment program or other states, but I'm happy to look into that and follow up. I do know that there are some programs, I can't remember if it's South Carolina or Tennessee, but some of them only apply to physicians in rural areas, and then the other program is intended to look at specialties in urban areas or things like that. So for ones that don't apply for the rural or aren't eligible for the rural program, the other one is more of a catch-all for all physicians, noting that physicians in urban areas also often serve rural residents via telehealth or consultations or other things as well.
I do know, I saw the figure of 159 counties in Georgia that their healthcare shortage, physician shortage in 143 of those counties. So really, there are not that many. Maybe we'll hear later from the Georgia-specific people who may know about Georgia specifically. So thank you.
So again, this slide includes examples of state loan repayment programs in Georgia and surrounding states. One other note that I'll make here is that the dollar amounts, either total or annual, vary greatly, as do the service commitments. And again, PRISM data is a great resource that can provide more insight on the outcomes of each of these programs, as each state pictured here participates, meaning that survey data should be available for participating physicians. One other note here is that the Health Resources and Services Administration maintains a state loan repayment program, which provides grant funding for states and territories to develop loan repayment initiatives themselves. HRSA has distributed over $61 million over 3 years to 42 states, DC, Puerto Rico, Northern Mariana Islands, and Palau, including Georgia, which received about $1.5 million total. Participating clinicians under the state loan repayment program supported by HRSA must work at least 2 years at a qualifying site, which may be a federally qualified health center, rural health clinic, community access hospital, rural emergency hospital, or other, that is located in a primary, dental, or mental health professional shortage area. States that participate in the state loan repayment program with HRSA must provide a dollar-for-dollar match in federal funds. As I mentioned, states may also offer tax incentives, especially for preceptors who oversee clinical training for medical residents. Now, in addition to a shortage of clinical providers, there is a shortage of preceptors nationwide. And many states use this as a way to compensate preceptors for the additional capacity and time it takes to serve in this role, which is often uncompensated and additional responsibility. Georgia was one of the first states to offer a tax deduction for health professionals, which has in more recent years been replaced by an income tax credit. Tax credits are more common across states, especially for preceptors who oversee these clinical training rotations. I'll highlight Alabama and Colorado here, both of which have tailored their tax credits to target rural and underserved areas. The other examples here apply broadly across the entire state. Now, states may also pursue other benefits that aren't necessarily compensation. As a reminder, many employers, like hospitals and health systems, may offer these types of benefits to their employees as well, like housing or childcare. And we've seen an increase in state interest in workforce housing supports for healthcare occupations in particular, including physicians. Several states, Colorado, Montana, Tennessee, have done this legislatively, often for certain types of employees at state-run health centers or residents completing their clinical training. North Carolina's program is administered through the state's AHEC and is a model nationwide. And several states have also proposed this under their Rural Health Transformation Program initiatives, including Georgia, as well as Delaware, Florida, and Hawaii included here. Now again, does it work? Research on financial incentives suggests that it has a positive impact on recruiting and retaining healthcare workers, at least for the required service obligation. However, financial incentives may not be the only factor that attract clinicians to rural settings. Many may already be interested in practicing in rural or underserved areas. going back again to the folks who are, or physicians who come from a rural or underserved area themselves or complete their clinical residency there. And financial incentives do have limitations. While it increases the number of providers temporarily, these programs may not result in long-term retention. Program administrators have voiced concerns over professionals leaving their positions after meeting their service obligations. Oregon specifically studied the impact of their provider incentive programs on recruitment and retention, and they found a very high demand for incentives across provider types, which exceeded the supply of available funds in the state. Now, I'm going to breeze through these options on mental and physical well-being, not because they're not important, but because many are already in place in Georgia. Healthcare workers face unique demands and challenges that contribute to higher depression, suicide, and substance misuse rates compared to the general population. Recent survey data also shows that physician burnout remains high at about 41.9% of physicians reporting a symptom of burnout in 2025. So to retain health professionals, states are investing in mental and physical well-being initiatives. One way we've seen this is states supporting health professionals by only asking for the disclosure of mental health conditions that are current or that actively impair their ability to provide care. States are also providing safe haven reporting options and using supportive language in their licensure processes. So as of May last year, 37 medical boards do not require intrusive mental health questions, including Georgia. Nearly every state also has a physician health program meant to support health professionals who are facing mental or behavioral health needs, and many have expanded the professions that are eligible to receive assistance under these programs beyond physicians. Funding for these programs varies by state, with some states appropriating funding through licensure fees and others requiring participating physicians to cover the costs associated. And incidents of workplace violence have increased for healthcare professionals across the board since 2020. Many states are taking action to address, prevent, and track incidents, as shown on this slide. Finally, I want to touch on non-compete regulations. So non-compete agreements restrict employees from competing with a former employer for a specified period of time and within a certain geographic area after leaving a job. The American Medical Association estimates that non-compete clauses are common in healthcare and affect anywhere between 37% and 45% of physicians nationwide. This map comes from a 2024 analysis by KFF, and state restrictions on non-competes may apply to all workers, as shown in 4 states, healthcare workers, shown in 11 states, or workers under a certain income threshold. Now, there are several state examples of non-compete regulations, including Georgia and surrounding states on this slide. I'll note that all states surrounding Georgia, minus Tennessee, allow non-competes in some form, but many have exempted physicians. 2 I'll note here is that South Carolina has pending legislation that would prohibit non-competes for physicians, and Tennessee enacted legislation this year that bans all non-competes except for physicians whose practice has been bought by their employers.
Excuse me, when you say pending, do you mean it's pending signature of the governor or just as proposed and we don't know if it'll pass yet? In South Carolina, I mean, sorry.
South Carolina is pending, so it is still in the legislature. It has not been passed yet.
Thank you.
There are also several recently enacted bills included on the right from other states. Utah and Virginia include a wide variety of healthcare professionals by definition in the exemption on non-compete agreements, including physicians, PAs, APRNs, social workers, therapists, and dentists. Washington declared non-competes void and unenforceable as of October 2027, and Louisiana voids non-competes for other physicians, but after 5 years. So with that, I want to note again that NCSL, as legislators and legislative staff, is your membership organization, and we are here to serve you. So if there are any questions that I can answer now or any follow-up information that we can provide, we have a plethora of resources on health workforce and EMS, as you'll see this afternoon, available on our website. And if it isn't captured here, I'm more than happy to pull specific information for you.
Well, thank you very much for your presentation, and a lot of work in that, and I hope we're going to get the real I assume these are a lot of hyperlinks that we could, obviously, I
Yes.
love the printed copy, but at the same time, there's a lot of that, especially the research, like the question on whether financial incentives work or not. If I could ask everybody on the committee, if you can move those bags off the table so we can see your green lights and we can tell whether you'd like to ask a question. If Morgan, all our valuable analysts can see those, we'll be able to make sure that those who have a question. Chairman Taylor, did you have a question?
Thank you, Mr. Chairman. I guess one of the points that was glaring to me is the distribution of CMS funds. It seemed to be centered in the Northeast. And what can we do to have that change? Our population is higher than almost everyone in that grouping. And what do we need to be doing to have some of those dollars flow south?
So I will say that there have been, thank you, Chair, and thank you, Chairman. I will say there's been some changes in Medicare funding formulas that have changed that distribution a little bit, but largely Medicare funding for GME is centered on teaching hospitals. And that is the only site largely that Medicare GME funds. And so most of those funds are going to teaching hospitals specifically. As I mentioned, states have leveraged other funding like state appropriations or Medicaid, which provide a bit more flexibility in providing GME funds for other sites like federally qualified health centers or community mental health clinics, rural emergency hospitals, and others that traditionally haven't served as those clinical residency sites. But largely the Medicare formulas are set and require federal changes to make those. So that's why states are looking at the pieces that they have legislative control over, which are Medicaid programs and state appropriations.
All of that said, does that mean it's going to take an act of Congress to redistribute the funds? Thank you.
Yes, ma'am.
If we can move our mics a little closer, I hope everyone can hear better. Representative Mitchell.
Oh, okay.
Go ahead, see if I can pull that closer.
Thank you, Mr. Chairman.
And remember, we are going to have state-specific for Georgia shortly, and I appreciate Kelsey bringing us a national view, but go ahead.
Yeah, Ms. George Kelsey, it's always good to see you. What do you, I'm looking for a policy solution. What do you suspect is causing the dearth in healthcare workers in the state? It seems that we have good incentives, good programs. What do you suspect is a reason for that we can address from a policy perspective?
That is a wonderful question. Thank you so much, Representative Mitchell. My short answer is if we had a silver bullet solution. There we go. Thank you, Representative Mitchell. If we had a silver bullet policy solution, I think we would see a state that has zero shortages in physicians or healthcare workers. And ultimately, that's not necessarily the case in any state. While they overall there may be some states that have a surplus of physicians, they're still experiencing shortages in rural areas as well. And so I would say that it takes multiple different prongs, and obviously Georgia has invested in some of those. The one that I would say has, the clearest outcomes for physicians specifically is that rural residency training, whether that is a 100% rural residency or rural residency tracks. And in part that is because it shows, people who come from a rural area are more familiar with those communities. If they practice their clinical residency training in those areas, they're more likely to build relationships, understand the community, and understand the patients that they're serving in those communities, and the healthcare needs and the expanse of the types of services that rural physicians provide. So having that concrete rural experience has resulted in more folks practicing in rural areas. The other part that I'll note is that, again, there are shortages in healthcare occupations nationwide. Some states are investing in education pipeline programs. Again, Arkansas just established a new medical school. Delaware included one under their Rural Health Transformation Program initiatives. But it only helps if they have clinical residency sites to achieve licensure. And so you can graduate more medical graduates, but if they don't have somewhere to practice within the state, they're less likely to stay there.
Thank you. Thank you. I do know this financial incentives outcomes said research suggests, and it goes, some of this from University of Washington, for example, says not very successful at promoting retention as professionals may leave at positions after meeting service obligations. So some of this research that we can look at kind of evaluates ones where it seems to help. There's one that says it helps those who are already committed to going to rural areas to go, or it assists them. Obviously, it can be part of a multi-part thing, but I do look forward to seeing the research on this. Representative Buckner.
Great information. Thank you for being here today. I'm looking at the state loan repayment program page, and down at the bottom it talks about the Tennessee family medicine residency programs can get funding, but they have to see at least 200 Medicaid patients. While I think that that's wonderful that those patients are being taken care of, I'm just curious to know if we've learned anything from that. Like, is that, is there some kind of cost-benefit ratio to the state that they are being taken care of through these programs? I know it's a benefit to the patients, but is there any kind of drawback or issue for them to be able to sometimes get to that number and it causing problems in their new practices as far as financial viability? I'm just curious, do we know more about how that's working out in Tennessee?
Thank you for your question. I'm not aware of research on that specifically, but I'm happy to look into that more closely and follow up after the meeting today.
Thank you.
Thank you. It will be helpful to get, some of these. We keep a record of the questions that we need answers to.
Yes.
I do know when we hear from Georgia specifically, I'm pretty certain most of our programs, if not all of them, do require Medicaid participation as one of the, if you're going to get a rural assistance or a health loan repayment assistance. I believe all our programs have that, but we'll find out from that, specifically about Georgia, which requires you to accept Medicaid patients. It may not have the minimum number, but your practice has to be open to that, to participate in those. So I don't see any other questions right now. Thank you again for your organization, but also your role in looking at healthcare and focusing on the Southeast and some of the things in particular for our topic today. Thank you for being here and look forward to talking again.
Thank you, Chairman.
Thank you. All right, we are going to move on to Dr. Leanna Greenwood, speaking of the Georgia Board of Healthcare Workforce and getting some more specific Georgia information and questions answered. Thank you for being here with us. Please proceed.
All right, good morning, everyone, and thank you, Chair Newton, and thank you to the committee for allowing me to speak today. I am from the Georgia Board of Healthcare Workforce. My name is Dr. Leanna Greenwood. I have been with the agency since 2019. I started as a data analyst when we were a team of 1, and we are now a team of 4. So our data purview has really expanded over those years as well, and the different kinds of projects that we can glean data from. So today I will be focusing on physician retention and recruitment, and I will talk about those recruitment and retention data points from multiple different data sources. So I'll talk a little bit more about what those data sources are and what they say about physician recruitment and retention in the state. So I'll begin with talking a bit about the mission and vision of the Georgia Board of Healthcare Workforce, and thank you so much to our previous presenter who referenced our agency multiple times throughout her presentation. So we are doing great work specifically in the state of Georgia and with state of Georgia data. So I'll talk about what those data sources are, the challenges and successes that we've had in growing that data repertoire, and also some caveats about the data that you'll see here, just things to keep in mind. And then I will go into the physician recruitment and retention, specifically as it relates to medical school graduates, GME or residency program graduates, and then what does the physician licensure data specific to the state of Georgia say about recruitment and retention. and I will wrap it up with some key takeaways and can answer questions after that. So if you're not familiar, the mission of the Georgia Board of Healthcare Workforce is to identify and address healthcare workforce needs with an emphasis on underserved communities. And the vision is that the Georgia Board of Healthcare Workforce works to see Georgia communities, especially in medically underserved areas, have improved access to needed physicians and other healthcare practitioners, thereby enhancing the health and well-being of Georgia citizens. So to that end, I will discuss physician recruitment and retention today, and a bit about the data repertoire, the sources of the data that we have. So the Georgia Board of Healthcare Workforce runs annual surveys of medical schools and graduate medical education through multiple venues. So the first for medical schools is that we receive match data from each medical school every year. So there are 5, soon to be 6 medical schools in Georgia that have graduates, and we gather that data from the medical schools on where those graduates are going for their residency programs. So that is not self-reported data. We know from the National Resident Matching Program where everybody is matching. We also survey the graduates themselves. So this is self-reported data on where did they go to high school, where did they go to, well, we know where they went to medical school, and then where are they going to residency, what factors influence them to choose one specialty over another, one residency program over another, and those kinds of questions. We also run annual surveys of graduate medical education. So we do an annual survey of the graduates themselves. So again, self-reported data on salary, trying to find a job. Did you consider rural areas? Did you consider loan repayment? What specialty are you graduating from? Are you going into an additional fellowship training, or are you entering clinical practice? So all kinds of topics like that. And then we also do the retention reports on each Georgia GME program that the Georgia Board of Healthcare Workforce funds. So we gather data from each program on all of their residency, or all of their residents and fellows from all specialties, and where are they practicing. So that gives us an overall retention picture of GME programs in the state. And then we also survey the programs themselves about what specialties, how many graduates, what are the challenges and successes that you're experiencing.
Excuse me, real quick, did you say that now the parts you get from the medical schools and where they're going in the match, that's pretty much solid, and we know it for almost 100% probably that are going into a specialty?
Yes, sir.
And where? The second part was that, did you say that's self-reported or voluntary when you ask, all right, now you've finished, maybe you graduated from medical school in Georgia, and now you've gone somewhere. The part on where you're going, the salary, did you consider a rural area, to the health, loan repayment systems, is that a voluntary survey? It's a little less statistically strong.
Yes, so from the match report, so that comes out in March on a set date every year. So between that date in March and the finish date, I believe at the end of May for the medical school graduate survey, they could have had, like, if they didn't match initially, they could have had a match by the time they're completing that survey. So there might be some discrepancy there. But
Post-GME, the post-residency part, how do we get that information?
Yes, so we send out a electronic link, very similar to the medical school graduate survey, to the program, the DIOs and the program coordinators, and they send it to all of their graduates. And so we are able to ask for the total number of graduates and make sure that they are completing, I believe it is 70% of their graduates are completing the survey. So we can monitor that throughout the survey period.
Thank you.
And in addition to the annual surveys, we also have extensive licensure data. So I will be focusing on the physicians. In the underlying points here, I'll be talking about in more detail, but we also do have data from the Composite Medical Board, the Secretary of State, the Board of Nursing, the Board of Dentistry, Board of Pharmacy. So we work with all of the state healthcare licensing boards at this point to gather licensure data and to gather the workforce renewal survey that was passed through HB 1013 that is now online with the licensing boards. So in that workforce renewal survey, we are collecting data on the demographics, practice location, practice setting, type, and the hours worked, what kind of work are they doing, the ages and specialties that they're working with the patient served. So is it mental health or another behavioral health or another specialty, and then retirement plans. So as the workforce renewal survey comes online for more of the healthcare licensees, we will start to build up a very comprehensive picture of all of these topics for those workforces. And I would be remiss if I didn't point you towards our interactive dashboards that the previous presenter also highlighted. So we have interactive dashboards on our website in collaboration with the Georgia Data Analytics Center. So we have Georgia Match and GME dashboard that I'm very proud of. It's very lovely and gives you all of the match data that we have going back a few years, and we'll keep uploading it every year. So you can see where students are matching to Georgia programs, and then if they're not matching to Georgia programs, they're going out of state, what specialties are they matching to, and et cetera. And we also have other dashboards in addition to the licensure dashboards on the left. We have Georgia opioid treatment centers and pain management clinics. So that was in collaboration with the boards of pharmacy and Composite Medical Board. And then we also have a new dashboard as of this year on our Georgia loan repayment program. So also very proud to display other data and other programs that we administer. So as we are talking about physician recruitment and retention, I just want to give you some highlights of the successes and the challenges that we've had. So for one thing, a challenge is that going from a medical school student to a full physician in practice takes many years. So it's a very long process. I'm sure all you know, very intensive schooling, changes in education location from medical school to residency, maybe a fellowship, and then deciding where to practice if you're going into full-time practice. And across these different institutions, there's not really a unique ID number that we can use to track people from, you know, between 7 years of medical school to residency to a full-time physician. So that poses a challenge for us. There are some ID numbers, but they're not used across the institution. So that's a challenge. And if a residency program graduate leaves after training, we only know at this point through self-reported data. So intentions may not match up with exactly where they choose to go. There could be a time lag between when they graduate and then they get a job, and it takes them completely outside of what they had planned to do. In terms of successes, we do have a lot of data. So you'll see some of what we have here, but that is definitely a success to be able to kind of evaluate our recruitment and retention across multiple data points and multiple institutions. And we are working towards having a more detailed view of where a full physician or other healthcare licensee even completed their education, what state, what zip code, what level of education. So we are working towards a more detailed view of that. So more to come. So starting with physician recruitment, what do we know on the medical school level? So both of these visuals are from our Match and GME dashboard. So you can see that in 2026, 34.1% of medical school graduates stayed in Georgia for GME. So that leaves the other 69.3% of postgraduate year one slots to be filled with students from out of state. So I took this information from the National Resident Matching Program that said there are 957 slots, and 294 of those were filled with Georgia medical school graduates. And very interestingly, on our medical school graduate survey, we found that there were an additional 167 students who said that they wanted to stay in Georgia for GME, but they didn't match. So that definitely warrants some additional investigation of what specialties those people are trying to match into, why couldn't they match, why couldn't we keep them? And you can also see the breakdown by Georgia Medical School, what percentage of their graduates are staying in Georgia, and so it varies a little bit, but not too much between school. And then you can see that happily, we have over the past 10 years or so seen an increase from 2015 to 2026 in the number of Georgia Medical School graduates matching into Georgia GME programs. Next, we'll look at recruitment along Georgia medical education. So, or graduate medical education, I'm sorry. So these statistics are taken from our annual survey of graduate medical education graduates. So in 2025, which was the most recent year, we're currently working on 2026, 26% of GME graduates went to high school in Georgia. And 21% of Georgia graduate medical education graduates went to medical school in Georgia. So this means that 75% of Georgia GME graduates came from out of state. So they didn't do medical school or high school here. So that means that we are recruiting a lot of people from out of state. A great proportion of the GME workforce is coming from out of state. And lastly, physician recruitment. What do we know from the physician licensure data? In the 2024 licensure data, 65% of licensees in Georgia completed no education in Georgia. So that is definitely telling us a picture that the physician workforce in Georgia is coming from out of state, or at least they didn't complete any education here. So that is very telling. In terms of retention, I will again go through our different data sources. So we can't really say from the medical school graduate data what the retention rates are there because, like I said, we don't have an ID number. We can't really track them from that point in time. But for the GME graduates, we can say that Georgia-educated graduates, people who did all stages of their education in Georgia, are more likely to stay in Georgia after completion of GME than people who did not do any education in Georgia. So 68% of people who went to all of their education in Georgia plan to stay in Georgia versus 43% who did not complete those educational milestones in Georgia. And over the last 5-year period, this is from our programmatic reports on their retention of graduates, approximately 62% of GME graduates had a practice location in Georgia. And this is using their MPI address, which I realize may have some nuances there, but that is the unique ID that we can use to identify people who did GME and full physician licensure in the state. And lastly, on retention from the physician licensure data. When we did kind of a special request of the Composite Medical Board, so thank you very much to them for pulling this data for us quickly. So we looked at people who went from having a Georgia residency training permit number to a full physician licensure, and so they were kind of using that as a proxy of saying, okay, who from doing GME here went into having a full physician license and assumingly starting to practice here as a full physician. Approximately 50% of the expiring residency permit holders transitioned into full licensees. And when we look at the physician licensure data, 15% of physician licensees in Georgia completed all education in Georgia. So of the entire physician workforce that we have, only 15% are those that we would say are from Georgia, did all of their education in Georgia, intended to practice in Georgia. And an additional 20% completed some education in Georgia. So whether it was from high school, medical school, or GME, we were able to retain an additional 20%. So I know I just threw a lot of data at you, but I do have some key takeaways in terms of retention and recruitment. So along retention, Georgia is losing, like I said, about 160 medical school graduates who wanted to stay during the match. So I would emphasize that this is a point of further research and delving into. And only 35% of Georgia's physician workforce did some education here. In terms of recruitment, I think that's telling us that we are recruiting very heavily from other states for our full physician workforce, and that 65% of physicians practicing Georgia came from out of state. So something is going well in terms of that, but we can't really say in terms of keeping physicians. I think there's still some more work to be done there. So thank you again very much, Chair Newton, and to the committee. I can take any questions that y'all may have at this point.
Well, thank you for your work and your presentation, for your team and the work they're doing, the work we're going to keep asking you to do. That 65% number that completed no education in Georgia, I guess we have to assume we don't get any information when they apply for a new license in Georgia. It would be nice to know how many were moving in mid-practice to Georgia, because I assume it's either quality of life, it's the work-life balance of the job, or possibly a spouse is able to get a job here in Georgia. Certainly the whole state's been growing, but that's an impressive number of physicians that really had no connection, at least educationally, to Georgia. And I'm assuming that there might not be many of those coming for loan repayment, but that might be a bit of information. Chairman Leverett.
Thank you, Mr. Chairman. Thank you for that presentation. Am I interpreting the data correctly in that we seem to be doing a poor job of keeping the Georgia medical school graduates in Georgia? At least I think it's only 30-something%, but we're drawing people from other programs elsewhere into the state at a higher rate?
Yes, sir, that does seem to be the picture that we're seeing from across the data sources.
And another follow-up, Mr. Chairman. And it sounds like, if I understand the data about
Hit your button again.
there we go. If I understand the data about the match, there are Georgia students who want to stay here, but they're not getting picked by the, and is that the residency program that's not picking them?
Or do we not offer the specialty that they wanted?
Yes, sir. So it could be that they tried to apply to programs. I don't have more specifics on that right now. I could look into it, but it could be that there's a shortage of the specialty itself, so they couldn't interview or they couldn't apply to the residency programs themselves, or it could be that they did apply and the residency programs didn't choose them, or it wasn't a mutual match.
Okay, all right, thank you. Thank you, Mr.
Chairman Parrish.
Yeah, thank you. Following up on what you said in one of your earlier statements, there were like 167 graduates who didn't match in Georgia, I think, that wanted to match in Georgia. Do you know why?
I can definitely delve into that a little bit more and respond to the committee on that.
Okay, it sounds like to me, and help me understand this if you would.
Hit his button
We've
again.
done a pretty fair job.
Hit your button again, sorry.
Got it, okay. Help me understand if you would. I think we've done a pretty fair job with having more residency slots, but my question is, do we need to do more now to enhance those slots or to do more work in the specialties and the fellowships and this sort of thing? Can you tell from your data how's the best way for us to go to get that miserable rate up where it ought to be?
That is a great question. I don't know if I have a great answer for you right now. I could definitely look into what the intended specialties are of the people who wanted to match and didn't match. So I can definitely get that back to you. I know that I have heard that for the medical school graduates, they're not going into a fellowship program at this point. So we know that they're going into one of those core specialties. So I know I've definitely heard that internal medicine pediatrics has a shortage of people who wanted to match, but there's not slots available. That's the one that I can think of off the top of my head, but I can definitely look into more on those specialties. And I can look into if there's more specific reasons on why they didn't match to a Georgia program.
I guess my last question, Mr. Chairman, is if we look at, say, MCG, and they have their residency programs and have a great number of programs and all, but maybe if a person graduates from medical school and they know that they want to do some sort of specialty after their residency, if they look at MCG and they have the specialty that they want to do, then are they more likely to attend MCG with the idea that once they finish their residency program, they could move into their specialty, their fellowship at that program there? Is that an incentive or not, or what do you think?
I think I've heard kind of different responses to that. Some people say we have open-ended questions on our survey. So some people have said that, yes, I wanted to match here and it seemed like a sure thing. I did medical school. I can match at the same institution. Something that would need further investigation is from the GME programs themselves. How are they ranking graduates that want to match to their programs? Are they choosing a very diverse, geographically diverse? Are they choosing on scores, test scores, or how are they ranking people? And is Georgia residency or desire to serve Georgia high on that list of priorities when they're matching? So we would definitely need more data on that.
To go into a fellowship, do they go through a match program as well, just like with the residency program?
Yes, I believe there are, but for some specialties and fellowships, there are different matching programs. So the National Resident Matching Program, the main match, includes most specialties, but there's others like urology that has its own match. If they're in a military program, that's its own match, so the data doesn't come to NRMP.
Thank you, great information.
Thank you.
Chairman Taylor.
Thank you, Mr. Chairman. I think we are all concerned about the match. That is just jumping out at everybody. And it is a national match. What would happen, or can a residency program accept students that haven't gone through the match or didn't match? What happens to them? What's the penalty?
Oh, I do not know. I can follow up with you on that. I know that some students do try to do supplemental matches, like I think they call it scramble, or SOAP, like they try to match after the main match, try to find one of those open positions that's still available during that time after the match, in between when we would be collecting the medical school survey. I'm not sure in terms of penalties like towards the programs if they don't have students to match. The Georgia Board of Healthcare Workforce does have criteria on the percent entering a primary care core specialty, but for the most part, all of the medical schools meet that with passing colors every year. So we don't have a penalty against them.
It is curious because, I've had residency programs in our area where the students wanted to come to a certain facility and they didn't get the match and they really didn't understand who writes that criteria and who's in charge of it. It's nice to say national, but at what point and who contributes to that data, and is it an AI selection? How is this done? Does anybody know?
Yes, that's an excellent question, and something that I would like to look more into as a researcher. Kind of doing a survey of our GME programs, how are you matching I know that it is an intensive interview process, so a student may apply to multiple programs, and I believe post-COVID, a lot of those have gone virtual, so they're not having to travel across the country. But that, I think, still is a factor to meet program directors, have your interview face-to-face. Is it a culture match? Does it feel like a match between both parties?
And when you have your survey, what happens if someone, it said mandatory, what happens if someone does not respond to your survey?
We do not have a penalty unless the medical school's overall percentage doesn't meet, I believe it's 70% of their graduates need to complete it. And I believe they all meet that.
Is your data used specifically for licensing? I know one of the things I also hear is new physicians having to wait to get their licenses. Is your data what they go to approve licensing, or how do you fit in that picture?
Yes, so the physician licensure data comes from the Georgia Composite Medical Board, so they're the licensing body for the state. So the data that we have is people whose licenses are approved, they're completed that process, and so they are fully licensed in the state.
Okay, but you're not really tied to the timeline that it takes to get the license. Your data is available to them if they want it.
Yes, correct.
Thank you.
Thank you. Chairman Hawkins.
You know, we started doing the loan repayment for fellows a few years ago. How is that looking? Are these folks, are they staying in Georgia at higher numbers since they're further down the road in their education and practice? You see that?
So for the, we revamped to also allow for fourth-year dentists and medical school graduates to be able to apply to our loan repayment programs as well. I believe those are a bit newer, as you've mentioned, so we don't have a ton of data yet on the actual retention. As long as they are receiving the award, then they would be practicing in a rural or underserved area according to the loan repayment contract. But in terms of the those newer stipulations, we don't have a ton of data on that yet.
Okay, I'd like for y'all to definitely, watch that, because I think the longer the person practices in an area, the more their family becomes entrenched, and as soon as the spouse starts having babies, the anchors are going down in the ground, and they're pretty much more ready to stay. One last question. I know that we are allowing physicians and dentists in contiguous counties living outside our state to get those loan repayment and use those programs in rural areas, less than 50,000. How is that working out? Do you see that although they may live in North Augusta, does that practice survive and stay there after their commitment of loan repayment?
I don't have the data offhand, but it's definitely something that I could look into.
I wish you would, because there's some discussions, looking at that. That would be important to know for us to make some further decisions.
Yes, sir, that is a great point, and I will definitely take that back home with me.
Thank you.
We do have quite a few take-home requests, and then
Yes,
we
sir.
look forward. I'm almost certain we're going to need to see you back at one of our next 2 or 3 meetings just to follow up on these and appreciate the data. We do have, I know a little later in the day, we have the dean of the medical school, which I know Dean Hess certainly keeps up with the graduates from the largest public medical school here, so maybe we'll have some of those answers about who doesn't match and things like that. Representative Jones.
Thank you so much for acknowledging me. I too have a question as it relates to the match and the additional need for more matches in the state of Georgia. I think my concern is ensuring that rural Georgia gets the occupancy that it needs. I'm very familiar with a program that is happening with Morehouse School of Medicine and one of your local hospitals here, where they're trying to nurture more folks being in an area to be able to stay and continue to live and learn and plant roots, as Chairman Hawkins has already stated. How can we improve more collaborations like that between the schools and a hospital so that they can create match programs for those doctors to be able to stay in those rural areas and plant their seeds?
Thank you for that. I think that we do have a lot of great things going on in terms of medical schools increasing their campuses. I believe Philadelphia College of Osteopathic Medicine has opened a new campus that focuses more on rural practice. And I do believe, like the previous presenter said, having that rural clinical experience is a huge predictive factor of keeping a physician there. So I think the things that we can do to increase rural rotations, increase exposure to the kinds of patients, the culture, the community, and getting physicians ingrained within that culture is very important. I personally am not an expert on how we would go about that from a policy perspective, but I do think that increasing that exposure and integrating physicians into the community is a very important thing to do to keep them there.
Additional follow-up, and it'll be my last. How do we use that as a tool for making sure that they occupy rural communities? How could we create specific matches for them to be able to stay in our most underserved communities here in the state? I think that's my concern.
Yes, I think that there is a challenge based on my understanding by specialty. So for a family practice physician, it may be easier to establish a rural practice if you don't have to be within a certain radius to a hospital, or you don't have to, for OBGYN and pediatrics, I think it's a lot harder to establish outside of areas that don't have great exposure to a hospital or are far from hospitals. So that is one challenge that I think varies. I think that one great thing that we are doing is, like I said, opening the loan repayment programs to people who have not yet finished their medical education, so that they can plan and complete the intention to practice in a rural area, whereas for other loan repayment programs, you have to already be there. So I think that can serve as a kind of pushing factor to get those interested parties to go into those areas, knowing that they do have, up to $150,000 of loan repayment waiting for them after they complete their service, or while they're completing their service to those areas. So I think there are things that we can do, and those would kind of be the things off the top of my head that are both challenging and optimistic for the future.
Well, thank you to you and your Director Chip Basine. Thank you for your work, Dr. Greenwood, and I appreciate the fact that we are going to probably be sending you some questions and ask you to look into more data as we can. I know with especially that post-GME, I believe there's close to 51 specialties that train at the Academic Medical Center here at the Medical College of Georgia. And so the numbers start getting small in some of those fellowships and programs, and tracking them can have big swings in percentages. But thank you for your willingness to do the work for this committee and for what you've presented. Thank you for being with us.
Thank you for having me.
We are going to go on now to another, a little different area on the way we fund a GME in Georgia, and frankly, the way other states fund GME. The base of it does come from Medicare, Part A, for the GME, and we noticed that earlier slide where it was concentrated in the Northeast. We noticed very distinctly around New York and surrounding there, that is a lot of the Medicare funding for GME, and the biggest funder, but those were the oldest programs, and so they got in before the moratorium in the late 90s on new GME programs. So we are looking, and we do have a group from Sellers Dorsey firm, and I'm glad to have Tom Wallace, the managing director and a consultant who's helping the state of Georgia, and if you can just introduce yourselves and proceed. Thank you.
Great, and thank you, Chairman and members of the committee. I'm thankful for being here today, and I appreciate the opportunity to speak to you about GME, just a high-level overview of GME overall, and as you mentioned, Chairman, some funding mechanisms of that in Georgia, and then also talk about Florida a little bit. My name is Tom Wallace. I'm a former Medicaid director of the state of Florida. I'm currently with Sellers Dorsey. I've been here for almost 2 years now. I'm a managing director, overseeing the work that we do here in Georgia, Florida as well. With me, I have Brian Groom. He's been with the firm for about 3 years at this point, and he's a director here in Georgia. So Sellers Dorsey, nationally, just to understand what the firm is, who they are we are a national healthcare impact consulting firm that we were started in year 2000. We specialize in Medicaid financing, policy, and strategy. We work with a lot of healthcare providers, both large health safety net systems and some rural community providers as well. And we work with state governments, private sector clients, and we help design reimbursement strategies and navigate the healthcare regulations, what's coming out from the federal government. We focus on Medicare reimbursement financing, like GME payments, delivery and system reform, payments, and policy and managed care strategies. So before I kind of talk about just GME high level, I know the first presenter just mentioned and talked about where kind of Georgia is, like 58% retention rate there, and Florida was around 65%. If you look at nationally, the ranking there, Georgia's ranked 11 out of all the whole nation. That's about 58% is 11th. Florida was at 5. So the delta there is about 5 percentage points there. California, I believe, is #1 in that ranking for retention rates, a little bit over 70%. And really, if you look at it's the larger, higher population states that are higher ranked up in that level there that have large metropolitan populations. I just thought I would just mention that so you can see that, Georgia is ranked 11, so they're not so bad. However, obviously we like to see that get higher. But GME here, so Medicaid GME specifically, is fundamentally a teaching hospital payment program intended to help support the costs associated with training physicians and improve access to care and quality of care for that Medicaid recipient. Medicaid does not have one national GME payment type program. States can design their own programs how they see fit through the Centers of Medicare and Medicaid Services, CMS, has to approve what we call a state plan amendment for that program. So while states have substantial flexibility in designing Medicaid GME payment methodologies, most states rely on concepts that are derived from the Medicare GME policies, including resident counts, teaching hospital status, and inpatient utilization in determining what those payments can look like. Medicaid GME payments are subject to federal payment and financing requirements, including upper payment limits, or UPL payments, which places a ceiling on the aggregate Medicaid payments to a hospital provider. So there's a cap or a limit that hospital payments can be made up to, and that's that upper payment limit. As other Medicaid supplemental payments grow, so available capacity under the applicable payment limits may become more constrained, limiting the opportunities in future GME funding resources. And so when I mentioned other supplemental payments, Georgia, as you guys might be aware, besides GME payments, has other supplemental type funding that goes to hospitals through directed payment programs, et cetera. States must have to here balance the GME funding priorities against other Medicaid payment programs and the federal financing requirements when considering payment changes. Increasing GME payments generally requires identifying available capacity within the federal payment limits and demonstrating compliance with CMS and payment financing rules. So as a result of this, hospitals cannot simply request an increase in GME payments. So they just can't say, I want to have more funding come in for GME. It's because any changes must have to fit within the state's overall Medicaid financing framework and those federally required limits that are set by the federal government. Also, I'll mention here that the first presenter talked about how Medicare is the #1 essentially payer in GME, while Medicaid is the second largest payer in GME funding. And physician workforce shortages make GME an increasingly important policy tool, and GME increases the supply of highly trained physicians, as we know, statewide. So looking at what the GME payments cover, Medicaid GME helps teaching hospitals cover the cost of training residents. There are two types of GME payments. You have a direct GME payment and an indirect payment. Funding can support resident salaries, faculty teaching time, accreditation, equipment. That's mostly fallen under the direct component of GME. And then on the indirect, this is more enhanced training and training costs. So that's the indirect piece.
Can I ask a quick question? That line under on the left, that these are intended to help them offset the costs they already incur training residency rather than prospectively fund new investments. Is that the way it is now? Is that the way, even with a plan amendment, it's only for ones that already exist? Is that right? Because we've been trying to add new residencies or expand residency programs, and I'm just curious, is this not a tool for something different?
No, this is for current residents, right? So this is the funding, this is GME
Current
funding.
residency
It is for current residents. Now, there are programs out there, and I'll talk about that as we go on,
Okay.
kind of like what Florida's doing, and I'll tell you what's happening there.
And what the feds are saying.
Exactly.
Thank you.
Yeah, I'll refer to that. Yep. So Medicaid here, so it's listed, you can see all the stuff that's covered here for direct and indirect. But then Medicaid GME also recognizes that teaching hospitals often have a higher operating cost because they train the residents here. And some states use GME funding to support broader workforce goals in general, such as rural access, and train other types of health professionals, like nurses and some allied health professionals too, but most of the funding is for physicians. Just talking about here how the funding actually works in general. The states go ahead and design the GME program, and it identifies a non-federal funding source. And as I said here, GME is very flexible, and each state's going to look different how they operate their programs on the Medicaid side. The state goes ahead and submits to CMS for approval through a state plan amendment. All right, so that is the mechanism for getting approval from the federal government, so it has to be approved. And once approved, the state claims federal Medicaid matching funds for that, so that's how they draw down that federal share. And you have the teaching hospital and other training providers then receive that payment from the state to support those training programs in residence here. I will mention that on the state funding source, it comes from three main sources. One being state general fund, where you guys here in the legislature would appropriate dollars to fund, which could be used to draw down the federal match. Two other sources. One is an IGT, which is an intergovernmental transfer. So a lot of these public entities and big hospital safety net systems have access to an IGT, so that public source can be used as a matching dollar, and then also provider assessments too. So private entities often rely on a provider assessment as the state match. So looking at national, the next couple slides will be more on the national level here, just overall the landscape. This is a little bit of older data from 2022. The more recent information wasn't quite updated. This is all from the CMS website. They tend to post and have updated information every 4 years out there. That's really accurate for the most part. But Medicaid GME, it's a common tool nationwide, as you can see on this chart here, with 44 states making GME payments. Every participating state funds teaching hospitals and some other supportive community training sites. State structures these GME programs differently, like as I've mentioned, based on workforce and their finance goals. And many states recognize both the direct GME cost with higher operating costs for the teaching hospitals for the IME program. States use a mix of funding sources, as I mentioned previously, and then there is no single model for Medicaid GME, unlike Medicare GME. I thought this would be helpful just for you guys to maybe kind of see, comparing Georgia here to other states in general and the amount of funding that they receive. Again, this is from 2022, but you can kind of give an idea. This is strictly looking at GME supplemental payments, all right? So this is payments that are paid outside of your base hospital rates and outside of managed care. It's just a supplemental payment that's paid to providers, mainly hospitals, for GME. So as you can see on here, Florida's kind of leading the states that you see on this chart here, $761 million total for supplemental GME funding. And Georgia has $53 million, and that is just for the supplemental piece now. So there are some other, and you'll hear from Brian on that, but there are some other GME payments that are through the rates, but the supplemental-wise, it's $53 million. And that ranks 17th nationally for out of all the nations here.
That's kind of a shocking range and a little disappointing.
So, and we can explain that a little bit to you, how that is, because like I said, this is just a supplemental piece, supplemental funding piece. There is another piece that we'll talk a little more into on the IME side, indirect medical education side, that is not paid through a supplemental payment from the state. Rather, it's paid through the rate setting system, and you'll hear from that in a second. And we can get back to that too, if you like. This chart just kind of showing the same type of thing here on the bottom left, top 17 states. Georgia is a 17th. This is explicit GME supplemental payments, where Florida is kind of that outlier there. Overall, $4.9 billion nationally for a supplemental payment. I think overall, when you look at GME total, it's around $7.9 billion. That's including the other type of funding that providers get outside of the supplemental payment funding. There's 32 states that have a payment for supplemental GME going to them. So out of the 32, here's the top 17, how it ranks. Thought that would be just important to you get an idea on how that is there. And so with that, I'm going to go ahead and turn it on over to Brian to talk a little more specifics about Georgia.
Thanks, Tom. Mr. Chairman, members of the committee, thank you for having us. After 11 years in the House Budget and Research Office, I'm much more used to being on that side of things, so it's strange being over here. But
really appreciate you helping us on this side as well. Thanks for being here, Brian.
So I want to talk through Georgia's Medicaid GME program. So the first one being the direct GME program. This was mentioned earlier from the Medicare side, having the caps on program residencies and how much Medicare will pay. Those caps are not part of the Medicaid side, which is part of that additional flexibility. So you can have more residency slots for Medicaid and get paid on those than you can for Medicare.
We might need a little taller microphone if you can pull it a little closer to you.
Yep, sorry. So on Medicaid, Medicare, there's the cap that they impose on GME. Medicaid side doesn't have that. So you can have a program that has more than your Medicare cap for Medicaid. So this slide is looking at what was on that map earlier with the direct payments made in supplemental payments. So this is the direct GME. So Georgia uses the formula that you see above. And this is really pretty standard throughout the country. Georgia hasn't gone beyond what has been generally accepted. We have the formula at $49,000 per FTE. And then there's also some additional bumps for the state wanted to incentivize certain areas. So for instance, family medicine, OBGYN both get the largest bump. And then also pediatrics and specialty pediatrics get a bump, and then general surgery gets an additional bump on top of that 49,000. So that's really the base Medicaid GME payment that we can see from a easy to follow, easy to track because it's based on number of FTEs. When we move on to the indirect side, it's a little bit harder to track because it's part of your rates. So this gets a little more confusing to look at. But the important part of this one is if you're looking at just the funding amount, you're going to get paid based off of your IME adjustment factor, which is based on your number of residents per beds. So that's really the more residents per bed, then you get a higher percentage add-on than if you have fewer. So you can see that's laid out in what we show as number 1 here. And then number 2 is just the entire formula for the base rate payment. So this is a part of that. So just wanting to show the entire layout. And then showing that this isn't a direct payment supplemental. It's built into the rate. So harder to track it and not included in the map that we saw earlier and the data that was presented there. That an estimate on what this is worth is, for Georgia, it's around 110 million. So double what the direct side has. So I think, really that's our Georgia program, pretty standard across the country, nothing that's pushing the limits of CMS. But happy to, I know Tom's going to walk through kind of what Florida has done to show why their numbers are so high compared to Georgia. But happy to take any questions about this later or now if you have any. Tom?
And just to add to your question, Chairman, a little bit earlier too, about Georgia being lower on the other side of the supplemental payment funding. As I mentioned earlier here, as other supplemental payments grow in the state, so Georgia has a lot of other state-directed payment type programs, multiple. As those programs over the years have gotten to the level they're at now, that just puts more funding on that side, essentially, instead of through GME. While other states that might be higher on that chart have more going into GME than they do on these other type of programs. So that's kind of when you look at the total picture, total funding wise, including all that stuff, and that chart would probably look a little bit different. So I just want to point that out there too. And as Brian mentioned here, I'll talk a little bit about Florida GME. Just from my experience in Florida, I thought it just might be helpful here to kind of show you the programs that we currently have in Florida and lay them out a little bit. And so you can kind of see, and as I talk to this, you can kind of see what maybe the limitations will be here in Georgia moving forward on this. But quickly here, there's 2 programs on this page. The very first program was the statewide residency program. Started back in 2013. Before that, there was no GME supplemental payment program for Florida. There was just a cost reimbursement amount that was paid. The per diem rate would have included a GME amount because it was built into the cost of a hospital. We pulled that out and created this GME statewide residency program. It uses general revenue fund to fund it. That's the state share. And it is based on a weighted formula where it looks at most of the formula is based off of the FTE counts that the hospitals have. And then you also have the rest of it's kind of factored into it, looking at the Medicaid payments to that institution. The next program.
Before you go much further on Florida, can you tell me, are these programs we should pay attention to because they may be open for Georgia to apply to, or are they ones that the feds are phasing out? Because I know HR 1 did some changes. So if you could kind of, maybe if you go through them, tell us which ones might be on the menu for Georgia potentially and which ones we might spend a good bit of time and then there could be a different direction federally.
Right, absolutely, Mr. Chairman. Let me go through these real quick, and I'll get right to that point. I have all that information for you. So I'll go a little fast here. The Startup Bonus Program is a second program that came in Florida. This is funded with an IGT, but this is not tied to any kind of utilization or cost here. This is strictly a one-time $100,000 amount going to a hospital who wanted to start up a new residency type program. So we're thinking that let's give this hospital $100,000. You start the program, that new resident slot, and then they would move into the statewide residency program after that phase. High tertiary program funded with IGTs as well. It goes to 9 of the large public statutory teaching hospitals in the state of Florida. A lot of funding, $166 million going to that program. Primary care GME, $150,000 per slot for this program. So again, this is based off of a slot.
This is all, is this Florida spending or is this Medicaid dollar spending?
This here is
Or combination?
Medicaid, all Medicaid.
Oh, this is all Medicaid, okay, sorry.
All Medicaid, and so the state share for the very first program, statewide residency program, was general revenue, general revenue fund, and then the rest of these programs on here, on these 3 here, and the startup bonus are funded by the hospitals themselves. So they put in the IGT to fund it on the state side, right, which draws down the federal Medicaid dollar. Okay, so these are all Medicaid programs. It's not just the state of Florida legislature giving general revenue to fund the program, which could happen, by the way, but they're not doing that, right? And then you have mental health GME too. Again, that's based off of a amount per slot. Citrus is a F2HC, so there were some funding, GME funding going to an F2HC. We have the Slots for Docs program, which you guys may be familiar with or may have heard about that program a little bit. It's a brand new program. It is funded by the legislature with general revenue, and then it draws down the federal match, or should draw down the federal match. However, that's not approved by CMS. I'll talk about that in a little bit here. And then Florida also has, just like Georgia, has a IME program, very similar basic formula, but does have some other components that go into it. But what I wanted here to tell you, to your question here, Chairman, is I walked through 7 different directed GME programs that Florida has. And you remember I showed you a slide, the funding received, the funding received from Florida. And about a year ago, around this time, when Florida had submitted a state plan amendment to the feds, they had noticed and started looking at the dollars and said, you're paying you $700 and something million for a supplemental GME. That's about 1/4 of the nation on GME. And so they started questioning Florida on that. When you look at it, it's actually about 1/6, but CMS was saying 1/4. Now, I wasn't at the agency at the time. This is, what I'm hearing from that there. So about a year ago, these programs are now becoming under scrutiny by CMS. Okay, so they have put on these programs, except for the statewide residency program, they put a sunset date. So of 5 of the 7 programs have a sunset date on them of June 30th of 27. So they're going to be essentially going away. One program is not being approved, and that's the Slots for Docs program. So Florida has to end these
Did Florida
programs.
put the sunset, or did the feds put the
The
sunset?
feds put the sunset on, not Florida. Florida wants it continued. So they are, yeah. So the one program that's not going to be sunsetted here is a statewide residency program. And again, that is a formula based on Medicaid cost and Medicaid utilization. And it's a formula driven. And when you go through that calculation, the average amount per slot's around $29,000. And since 2013 to now, it has seen substantial growth in the number of resident slots that has expanded through the state with that program. And CMS seems to be perfectly fine with that because it's based off of Medicaid costs and utilization. CMS has said that they will no longer fund a per slot amount style program, and that's what these other programs are. They're per slot amount funding. The GME funds need to be tied to, again, Medicaid utilization and costs associated with delivering services to that Medicaid beneficiary. So CMS here has been asking Florida, along with a lot of other states too, so this is just not Florida, but about when they start reviewing their state plan amendments, they're asking them to demonstrate that GME meets the standard of economy and efficiency. So even if the state is under its upper payment limit, which Florida has room under that upper payment limit, that was the previous standard by CMS for demonstrating economy and efficiency, but now they're going way above and beyond that. And right now in Florida, I know this starting this month, and CMS is supposed to be having communications with the agency and trying to work through that sunset date, and the agency is trying to figure out what we can do to try to continue a program, or what can we do to make it look like to the satisfactory of CMS. So they're going through that process right now. I don't have any other information to provide you on that. We can keep you updated as they go through that, but that's what we know. On the Slots for Docs program, I know that was, again, like I said, that was something that had been top of mind maybe for some of you guys or some of your other colleagues too. And that's not going to be approved by CMS. That's not even sunsetted. It was never approved by CMS in Florida. My understanding is that Georgia, DCH, had submitted a state plan amendment to the federal government for a program very similar to this. I think they based it off of Florida here and submitted it to CMS either end of last year or beginning of this year. And the last I've heard on that, there has been no communications with CMS and DCH about the program. So I guess you just have to kind of wait and see where that goes and the communications with CMS and DCH on that, but it's not being approved in Florida. So that's kind of where we are on that process there. But again, nationally, what we are experiencing, whenever a state plan amendment and a state's updating state plan amendment for GME, we are seeing pushback from CMS overall, just in general, to meet this definition of economy and efficiency, and they're really looking at this. We do suspect, well, first of all, as you guys are probably well aware, there's a lot of regulatory requirements coming out of CMS. All right, we had state-directed payment proposed rules that are out there, and comments were received by a lot of the hospitals. There's a lot of program integrity efforts being done right on the federal level too. So a lot of things coming out of that states are grappling with. Community engagement is out there that states are grappling with. Also, provider assessment tax rule, proposed rule has been put out. So all these things have been put out, and what we're hearing is that they will be putting out something more on GME at some point here in the future. We kind of thought it would have happened by now, but it hasn't, probably because they have all these other things that are coming out. It might also be that they might be waiting until after the election coming up in November to see what happens at the Congress level too. But we are here on a national basis that we should expect some more guidance around GME in general. And they could be waiting to see what happens in Florida in the negotiations with CMS before they come out with something. A lot of times you do see whatever Florida tries to do, CMS reacts to a lot of the stuff from what they're trying to push forward. So that was that piece, right? Opportunities, before I quickly mentioned potential opportunities here, I just want to make it clear, I mentioned here again, that Medicaid GME expansion requires both really a policy rationale and financing capacity to make it happen. And it seems like it's going to be pretty hard at this moment here, but we have to kind of really wait and see where it all lands with the federal government. But when we were talking about this, we have slots for docs. So it is out. I know I've already talked about this a little bit, but it's out there with CMS right now from Georgia. And I guess it's just a wait and see what happens with that program. Also, outpatient IME, I mentioned that, you heard Brian talk about the IME formula here, and that's really focused on inpatient is included in that, but outpatient is not. And other states have included outpatient costs within that IME formula. But what we're seeing here nationally, when that gets updated or changed, a state plan amendment gets submitted to CMS, CMS is coming back and questioning it and have asked states to remove that outpatient from that calculation. And then they ended up approving it. All right, so that is something to watch. So I guess it's a potential opportunity where Georgia could try to submit a state plan amendment to include outpatient. But again, what we're seeing is it's not really being approved any longer. And then lastly, Rural Health Transformation Program. You heard the first speaker kind of talk about that a little bit there. So I think if there's an opportunity at that point, we know that Georgia has an initiative to grow highly skilled healthcare workforce in rural Georgia now. And so Georgia has invested in this rural health transformation. This is that program where about $50 billion a year for, it was like a 5-year period, or $50 billion 5-year period time frame that all states have access to this funding. And so Georgia is using some of these funds for physician grants and training and recruitment in rural areas. So they have an effort they're putting into it. And so it's be good to kind of watch that, and there might be some other opportunities within that fund too. And that's who we are. And you got our emails there, so feel free to reach out to us. Happy to work with you guys on any other topics that you want to discuss or any questions you may have.
Well, thank you for that overview. I know we have several members of the Appropriations Committee, including, I think, 5 on the health appropriations. So they're going to be looking at, certainly we want to maximize Georgia's share of the federal tax dollars that Georgians pay. So we certainly want to look at that. Appreciate you guys, Brian and Tom. Thank you for being here.
Absolutely.
And, I think we'll move on there. Thank you, sir.
Okay, great. Appreciate it.
Oh, sorry. I'm sorry. Hang on just a minute. Chairman Hawkins.
Yeah, just a quick question. Going back to page 10 on the IME education, I'm concerned about our fee for service. The feds are matching that on a DRG basis. So we're losing money there on that FMAP. Do you have any idea how much that is per year?
Are you specifically asking about with the FMAP change, what you're losing on?
I'm sorry?
What is it? Am I repeating that again, I guess?
Okay. Right now, the feds are reimbursing our fee for service by using DRG codes. You know, DRG is the diagnostic related group.
Absolutely.
So they take all the service that the hospital may do, but only pay down to this much. How much do you have any idea of how much loss we have there as far as the reduced, I imagine, the FMAP level?
Yeah, so how this works here is, and you're right, it's, Georgia reimburses on a DRG basis, diagnostic related group on the inpatient side.
Right.
And IME has its own calculation, its own formula, and it's paid out on a per discharge amount essentially, right? So when any discharge from the inpatient side, there's an add-on percent there for the IME. And so that's why we don't really have a good figure overall how much you spend on IME here, because it's based on utilization. It'll be based on utilization for the year being paid out. But in terms of like the amounts that, again, the amount here, and with the, you mentioned FMAP, and the FMAP can change too, which could definitely lower the amount that gets paid out to the hospitals.
Yeah, the DRG payment during COVID was really hurting our rural hospitals. They were producing all this health care, but they're only getting paid for a certain amount. And if the patient was there for 2 weeks, they only paid for a week.
Yeah.
And that was a big hit for us.
That will depend on, and I'm not really super familiar with DRGs in Georgia and how that works and the calculations, and the policy adjusters that they may include into that calculation. Pretty familiar with in Florida, but not in Georgia. And I think it just depends on, I hear your point. I think it just depends on how the DCH has set up the DRG formula and program.
Okay, thank you.
Sure.
All right, well, thank you all.
Thank you.
Tom and Brian, thank you for being with us. We obviously been focusing a good bit on medical education, and we are going to hear later from the medical college directly, but we are looking at ways, everyone remembers that 65% of the Georgia licensed doctors who never had any of their education here in Georgia. So we're looking to see how are we doing at recruiting graduates from other states, physicians that want to move here, whether quality of life or, like I said, spouse's job, work-life balance, and the practice opportunities here. Certainly Medicaid funding affects how strong the health systems and the practices are at being able to recruit top-level physicians to Georgia that train in other states. So what we want to look at is one particular item that comes up in when young physicians, we're talking about recruiting the next generation of physicians. I guess I put myself in the past one, but how are we going to recruit the next generation to care for us and our grandchildren? Non-compete clauses come up in a good bit of contract negotiations between physicians finishing their residencies or their fellowships, whether in Georgia or outside of Georgia. So we want want to hear from some folks who see some value in that, and who might see some changes that we made. I know we had and NCSL brought us some information on the number of states that absolutely prohibit non-compete clauses, which basically require you, if you leave this employer, you have to leave either 25 or 35 or 50 miles for 1 or 2 or 3 or more years that you have to leave the area. Some states that have changed that feel like the patient-physician relationship should override the business side of those contracts. So that's what I hope we'll hear from today. And I think we're going to start with Mary Lee Gober and Dr. Silver, whichever one wants to go first.
Great.
Oh, y'all together?
I just thank you.
Well, thank you for being here, sir.
Dr. Newton, for having us here. I'm going to introduce myself and have my associate here introduce herself. And I'm going to give you a sharing feeling, an opportunity to hear about this non-compete in contracts for physicians. My name is Dr. William Silver, Medical College of Georgia graduate, ready to be here at Augusta University. I'm a past president of the Medical Association of Atlanta, past president of the Medical Association of Georgia, and on the board of the Georgia Association for Patient Care, for protection. And we're going to present to you today an opportunity for you to share with us what we would like for you to do for the state of Georgia and for the doctors in Georgia. And I might have my associate introduce herself, and then I'll go back and forth.
Yeah. So I'm Mary Lee Gober. I'm also an MCG grad, a very proud School of Nursing, College of Nursing grad, many decades ago. And I'm here today as a multi-generational Georgian who cares about medicine, continuity of care, and patient safety. As an RN, I worked labor and delivery, and when I was actively practicing law, I was primarily involved in litigation. I also managed my husband's OB practice for the last 15 years of his practice before he retired. I now serve on several boards that focus on public health, access to care, and patient safety. Most importantly, however, I am a patient, and my husband, children, and grandchildren are patients. Most likely, all of you are patients too. We asked to speak to you today because there's an issue that is plaguing healthcare that only you, as members of the Georgia General Assembly, have the ability to cure. And this issue is holding our physicians hostage, and it's hoisting them out of their communities, and it's daily impacting patient care. And so we're here today to talk to you about the non-compete provisions that are in most of our physician employment contracts. And at this point, Dr. Silver will do the presentation, and I'll follow up with some information from individual physicians.
Basically, there are three things that we're concerned about today, and that's number of physicians, access to patient care, and cost. And what we would like to present to you today is one of these objects that we feel if we could remove, would help with increasing physicians coming into Georgia, keeping them from going out of Georgia, giving more access to you and me and Mary Lee as a patient, and decrease the cost. And I'm going to share with you what a non-compete clause in a doctor's contract can do. In case you're maybe not familiar with it, it could mean that a doctor could be in a situation practicing and wants to change that position. And suddenly now for 2 years, he may have to move 20 miles, 25 miles away from his current position, which might even mean that they would be restricted covenant from the organization he belonged to that could be all over the state, and they may have to even leave the state. So I'm going to share with you how that affects physicians and see what your opinions are about this. The presentation obviously is to you. As I mentioned to you, this is really here for all the patients, but the Georgia Association of Patient Protection was the one that really got this started. The majority of the physicians are employees, and I don't know whether you'll know this or not, but they are employees. They're employees. About 80% in Georgia work for a hospital or for a private equity-owned corporation. We only have about 18% physicians who are practicing alone. So this makes a major difference in terms they're working under a contract situation. Now, what effect would a non-compete clause in a contract mean to a physician? I want to share some of these things that may not be clear to you. But first of all, it literally traps the physician in their current employment situation. They are really destined not to move because of this possible non-compete clause. It impedes their professional autonomy and independent decisions, making poor patient care, which restricts treatment options if they're restricted to these contracts. It impedes independent decisions for optimal specialists to be called in. Their contract where they are doesn't allow for this. And it impedes the vocalization of patient safety issues. So this can contribute to physician stress and burnout, which adds to early retirement, obviously removing another doctor from our community. Now, what's the effect of non-compete physicians after they're employed? They decide they're going to leave. And here it is. You've got a situation here where a patient, the relationship with a patient is suddenly severed. They can't see that patient anymore because they're not allowed to practice in that area. It disrupts patient continuity of care. Patients going to now not have that doctor. They're going to have to find someone else to start over the whole program. And it removes patients' choice for their care. It can leave patients, particularly in rural areas, with settings without adequate medical care. Now, the AMA is obviously the largest medical organization. In their ethics and their programs, they feel that physicians should not enter into covenants that unreasonably restrict the right of a physician to practice medicine for a specified period of time or in a specified geographic area on termination of a contractual relationship. Competition is something all of us would like to be involved in, but in medical competition, you want it based on availability of time, costs that you're going to have for the patient, the services you're going to give to the patient, not whether or not you belong to a particular organization. Now, an interesting thing, and I really didn't know this until just recently, the American Bar Association does not allow a lawyer to participate in a partnership or employment agreement that restricts the right of a lawyer to practice after termination of the relationship. I don't know whether any of you are attorneys on the committee, but anyway, this is something that I just found out all attorneys know this. And I, as a physician, just recently found this out when Marilyn and I are working with the Georgia Association for Patient Protection. So this is something that we need to look at very, very carefully to help bring doctors into the community. Now, this was just part of the rule. It was by the Georgia Bar Association stating the same type of thing. Now, The Georgia General Assembly has the authority to void non-compete clauses in physicians' contracts as being against public policy. And that's the reason we are presenting to you today at this really illustrious committee. There are 20 states throughout the United States that eliminated non-compete contracts for physicians. And you could imagine if a young fellow coming down and has a choice of paying off his debt from his education, he's going to be likely to want to take a contract. Suddenly he looks down and he says, well, maybe if this doesn't work out, I'm restricted. I've moved my whole family here. Now I've got to move out of the state or move 25, 30 miles away. So it's something to look at, that we should be part of those 20 states that don't have the non-compete. We cannot afford to lose doctors to those states. Georgia already has a physician shortage, as we've talked about today, and it ranks 38th or 42nd for physicians per capita, and that was mentioned today in one of the reports. And another thing, the 50% of the physicians here in Georgia are over the age of 50. And the way attrition is going, that is another source of losing patients. So these are very important matters as we move along trying to get more doctors. Something you may not know, but Georgia is 49th in healthcare access and cost. This was a CBS program. We cannot afford to have anything that's relatively easy to address to keep doctors from coming into the state. Obviously, liability insurance is even a much bigger factor, but that's not something that's very easily solved. But the non-compete is something we can look at very carefully. We do not have enough doctors in Georgia, and non-compete is a deterrent, and it's getting more. We are allowing hospitals in the state to control the number of doctors in our community by imposing extremely strict non-compete contracts. Physicians and patients need your help. You are patients. I'm a physician, but I'm also a patient. Mary Lee is a patient. We're looking to you to help us and get our help. And what I'm going to do now is have Mary Lee share with you some of the stories that these non-compete programs have created. Mary Lee, I'm going to turn it over to you. Thank you very much for your attention.
And I'll just stress too that the attorney rule has been in place since the early 1970s. And as part of that rule, they indicate that an attorney needs to be able to make decisions for clients that are solely in the best interest of that client without any influence whatsoever. And the bar recognized that if an attorney is employed with a firm that has a non-compete hanging over that attorney's head, it will influence the decisions that that attorney is making for that client. And the same is true for medicine. Anytime you've got something hanging over your head and you are bound to a firm or bound to a practice, it's going to influence decisions that are being made. And it is happening here in Georgia with our patient care. It is influencing decisions that are being made. And those decisions, those physicians need to be able to make those decisions for patient care without any influence whatsoever. And then with regard to the non-competes issue themselves here in Georgia, the Georgia statute indicates that 2 years is presumptively reasonable. And so a lot of the non-competes are at 2 years. There are some that are even more than that if there's been an ownership interest. But not only
That they
is
have
it
to leave the area for 2 years, right? They have to leave whatever their geographic area is for 2 years.
Yes, so it's presumed reasonable for 2 years. The geographic area is not stated in the statute. It is whatever is determined to be reasonable. But then there's also another provision in that statute that allows the employer to add into that non-compete that you cannot go work for any of our competitors and across the entire state. So, for instance, if we have 4 major hospital systems in the state and the physician works for hospital system A, the non-compete clause could say, when you leave us for 2 years, you cannot go work for B or C in the entire state of Georgia. So it's not just a 25-mile or 30-mile or 40-mile radius. It can be across the entire state as well and really provide an impediment to physicians providing care. I want to direct your attention now to some of the letters that we've received from physicians about this matter.
Try to give us a quick summary on the letters, if you don't mind, too.
Yeah,
Thank you. So
very
we can have
quick
time for
summary.
questions.
So we have physicians who are sitting at home who cannot practice because they can't move because they've got children in school. They've got family roots here. They are waiting out their non-competes. We've got physicians who are having to live in another city while their children are in school in a different city and come home only on weekends to see their children. And then we've got patients who are not getting any care at all. We've got, in one area, we had cardiologists who left the area because they were bound by a non-compete, and for 2 years in your area, Dr. Hawkins, patients did not get cardiac care. It's horrible. And there's another surgeon who was in an area who had a non-compete and left. There is nobody in the state doing what this surgeon did, and there are patients who need that surgeon's services. So I really would appreciate, when your time permits, to please review these letters. They are powerful, and they tell the story better than we can tell it. So thank you so much for your time, and I'll be happy to take any questions.
Well, thank you very much. If a group was to say to you, is it an all or nothing, or when I know that AMA's mentioned the word unreasonable, there are some recruiting costs to health system. You mentioned 55% working for large health systems, even though other private equity-owned corporations. It may take 2 or 3 years for them to recoup their investment of moving you here, or your signing bonus after residency, or or introducing you to a community. Is it an all or nothing thing, that either the way it is now, or ban them completely, or would you think it'd be in the right direction if we could meet partially, so where maybe the first 2 or 3 years of practice you would sign a non-compete, so your employer who spent money getting you started could recoup their investment and keep investing in more doctors to recruit to Georgia? Is there room for a compromise?
Let me just quickly say, that would be great, but it should be listed prior to starting the contract. And it could be built in that they knew they were going to have to pay it back, but at least giving them the opportunity to practice to pay it back, as opposed to saying, fine, you can't practice in there, and we want that money back.
Chairman Powell.
Yeah, thank you. Yeah, I hear what you're saying. I somewhat agree, because healthcare is such a proposition that we have today. But I'm also a business person. I've always dealt with the idea about contracts. And to me, anytime that somebody signs away their rights for their future, that's kind of short-sighted on their part. But I guess my question, y'all, is this might be opening up a whole can of worms and indictment of the whole system that we have in Georgia and other places. What do you think the prime motivation is that would cause seemingly intelligent people to sign non-competes and such as that would restrict their futures?
I think that they're going to stop because these other 20 states are no longer having non-competes, and they're going to start choosing to go to these other states. And I anticipate more bills next session
I'm not
as
worried
well.
about the other
Yeah,
states.
their question-
What do you think the prime motivation is in Georgia for folks to sign these?
Yeah, the primary reason today, when I went into practice, I could open an office for almost my signature going down to the bank for very little money. It's a very expensive thing today to open up a private practice. So 80% of these go into contracts, but why do they do that? Now they're having major debts they have to cover. And it's a short-sighted thing on their part, there's no question about it. But the short-sightedness is they feel if they join this, they're going to be there forever, not knowing how the world changes. That is a short-sightedness, and hopefully with the publicity of talking about these non-competes, these people now can open their eyes before they get involved with something like that. And I think it's a great question, why would they do it? And obviously, I wouldn't do it, but as a matter of fact, I've talked to physicians who would not take it. I know a cardiologist in Atlanta right now who was offered to go into this program, and he turned it down. And he was in practice for a while, and he was not going to get involved with the non-compete that he had to sign.
So would some of this be maybe an indictment on this new day that we live in, corporate medicine?
I'm sorry.
A lot of this could just possibly be that this movement we've gone to of corporate medicine where you don't have private physicians running their own offices and it's all run from some corporate boardroom?
The private equity has really made an entrance into the state of Georgia, buying up practices.
Hospitals buying up. Yeah.
And most new physicians starting out as in a career, that adhesion contract has a non-compete in it. And the employers are not willing to negotiate it out. It's take it or leave it.
I know you mentioned in an earlier slide, I think that a lot of these physicians, new physicians that we're trying to recruit have significant debts, medical school debt, and that favorable, I think you mentioned the favorable loan repayment, student loan repayment terms if you work for a not-for-profit. And so those four systems, I think you mentioned A, B, C, and D, I think are often not-for-profit. So I'm assuming there's a certain amount of desperation. If you need a job and you want to be in Georgia, you might sign it, even though you don't. Obviously, we don't know about the ones who choose to go to Greenville instead of Georgia or some other state that doesn't have them. But thank you for being here.
Yep, thank you very much for having us.
Thank you for your work on this. Oh, I'm sorry, I apologize. Hang on just a second. Chairman Taylor.
Thank you. Just a quick
attorney.
follow-up. What happens if the physicians group or the hospital has made an investment? One of the things we've talked about, is there some way to incorporate those into it? I am very concerned about the corporate practices that have popped up, and that is a little more difficult. But they're making investments on this employee, paying off student loans. I've seen this happen with nursing, midwiferys, things like this, where they're tied. But again, somebody has made an investment to help them pay off their loans, set them up in the practice. How do they recruit that?
Yeah, so in some of the states that have passed this legislation, if the system helped provide for the education, there is an educational payback. And in some situations, there really isn't much in the way of recruitment costs. The physician shows up, says, I want a job in this city, and there's really, other than the orientation and training on the EMR system, there's not a lot of cost to the hospital system or the private equity group.
Well, thank you. Thank you for presenting. Thank you for your work on behalf of patients. And we do want to hear from some of those who do some of the recruiting, some of those health systems I mentioned. Obviously, it's a lot larger organization than that. The Georgia Hospital Association, Anna Adams, if you can come on up and tell us how this helps Georgia patients, and then maybe if there is any, my second question, which was, is there room for some compromise that might help him protect both and patients and the health systems who hire them?
Thank you, Mr. Chairman.
Dr. Silver, I'll start by saying we agree with a lot of the things that you said, and we have a lot of similar goals in providing access to care for all Georgians, ensuring that we have the correct number of physicians in our state. And so we are all working toward making sure that our physicians feel valued and have a place to work in Georgia. That said, I wanted to talk a little bit about just non-competes in general and highlight the point that non-competes are not something that is unique to healthcare. It's also not something that is unique to physicians. Many of our administrative staff at our hospitals also have non-competes. And the main purpose of these is to preserve and protect that investment that's being made in order to recruit a physician, especially for those physicians that are specialty providers or in rural areas or underserved areas of the state. I want to start by just talking about what it looks like when a hospital begins to recruit a physician to their area. There are extensive costs involved with relocating a physician, potentially repaying student loans, relocating a family. All of these things cost money, right? And so when you think about hiring a physician and bringing somebody into your community, you want to make sure you're protecting that investment that you've made. And so often non-competes are considering that type of investment when they're incentivizing providers to stay. Additionally, when you have a specialty practice, especially in a rural area, the threat of having another facility come in and take those providers away eliminates an entire program, which then eliminates an entire service line and access to that service for that community. So that's one of the things that hospitals are considering when they talk about non-competes. One of the things that, Mary Lee, that you talked about earlier that I think is a really important point to make is the reasonableness of these non-compete clauses. So the Federal Trade Commission back in 2024 under the Biden administration did a complete ban on non-competes and then later came back and did have to rescind that. However, they have been sending out letters to providers and other entities to say, your non-competes are egregious. They are not reasonable. And that comes down to the number of years that you may have to wait before you practice in an area, comes down to the mileage that may be considered in your non-compete. And so all of those things which are unreasonable, we would agree, are not really things that we want to see our physicians have to deal with. That said, you talked about loan repayment, loan forgiveness. I would argue that the state of Georgia, in our loan repayment, loan forgiveness, having to work that certain period of time is in and of itself sort of a non-compete. And so the state of Georgia is even incentivizing and trying to protect those investments. Some of the other items that I want to talk about today are what happens when a physician does decide to leave. Often, hospitals will negotiate with these providers and will waive those non-compete requirements. It's also a recruiting tool for other entities who may want to take that physician or that physician wants to work for that other organization where they pay back any of those loan repayments or provider setup fees, et cetera. And so that's just part of that negotiation back and forth with recruiting that new physician. The hospital that initially hired them may have had to do the same thing for the physician that they brought from another location. So that's just business, kind of economies of scale. Hospitals always encourage our providers when they are looking at their physician contract to seek counsel and to work through some of those things that they may have concerns about. So if the question is mileage for where you might need to practice next, we can negotiate on that. If the question is the length of time that you would need to practice before we implement a non-compete clause, also negotiable. No non-compete is a one-size-fits-all, and it really depends on the training and education and experience of each of these physicians. And if a hospital truly wants to recruit that physician, they're going to be flexible in getting them there. We don't want to create a situation where they're coming in and already feeling hostile. Non-competes also include sometimes, we talked about mileage for practice areas, we talked about years of service a little bit, but physical practice investment. So sometimes when physicians come into a hospital setting and they're going to be a primary care provider, for example, the hospital system may pay for upfront costs to create their office building space brick and mortar, to get them an electronic medical record system, et cetera, et cetera. And so as you're paying for those things, you want to incentivize the provider to stay and protect, again, that investment. So this is really just about protecting that investment, making sure we have those providers available. I'm happy to answer any questions that you all have. I know that it was brought up earlier, hospitals buying physician practices. I can tell you right now that I hear from my members regularly that physicians are coming to hospitals and asking to be purchased. A lot of that is because, especially this newer generation of medical school graduates, they don't want to have to deal with the insurance companies and going through all of the paperwork just to get paid for a service. And so they would rather come in and do their job and practice medicine and let the hospital entity cover all of the kind of back office stuff, because it's gotten so difficult and challenging even to just get paid. So we are happy to do that in the situation where it provides us access to additional caregivers in our area. Happy to answer any questions, Mr. Chairman.
Thank you for being here. Any questions from the committee? You mentioned that an investment, which can be significant from whoever's employing the physician or practicing with, would a certain number of years be maybe a reasonable middle ground on after 3 or 4 years, the hospital's gotten their initial investment back, but if the physician, and I would say she or he, since 52% are female, she or he wants to stay in the area but wants to maybe work for another employer or a different, could be a federally qualified health clinic or some other office that they want to work at that they think can better meet their patients' needs. Could that be a middle ground on non-competes that don't just last the entirety of your employment, but after the upfront investment is recouped, whatever that, like I say, 2, 3, 4 years, whatever it might be? Is that something that the health systems might consider if it was the policy in Georgia?
I mean, I think that is a reasonable consideration, but
Not as strong as the attorney policy, but.
Sure. I think every situation is unique. And while providers are negotiating their contract with the hospital, I would encourage them to bring that up as a part of that negotiation. So if it's about repayment of investment dollars, or if it's about length of time, whatever that unique situation is, can be considered and included as they're negotiating with the hospital or other provider.
Well, thank you. Thank you for, Chairman Taylor.
Thank you, Mr. Chairman. I will say several years ago, when it became much more common for the hospitals to buy practices, it was a concern, but I have seen in our rural communities, if they did not step up, we wouldn't be able to get physicians. So it has made a difference in many rural communities where that has happened. So thank you.
Mm-hmm. That reminded me of a point. We have also heard from physicians who appreciate non-competes, because when they come into an area and the market is small, the non-competes of surrounding physicians sort of protect their ability to have a marketable and reasonable number of patients so that they can make ends meet. So it's not necessarily about keeping the physician there, it's about protecting the ones where they already are as well.
Well, thank you for your work and for your organization and the hospitals you represent. Thank you for being here today.
Thank you, I appreciate you.
We're going to transition just a little bit before we go to lunch for a lunch break. Our host today, the Medical College of Georgia, obviously, I think it was mentioned earlier, over 300 new medical students every year that are being produced now for close to 198 years, I believe. I want to first welcome Dr. Dean Hess of the Medical College of Georgia. I think we'll get some information on this, the things when it comes to our topic of retaining and recruiting the next generation of Georgia physicians. I think he and his team are certainly on the forefront of continuing the legacy of the Medical College of Georgia. Some other great health systems, including Emory, Morehouse, Mercer, PCOM, so many others are stepping up for graduate medical education. But appreciate you being here and appreciate you maybe even answering some of the earlier questions you guys might have heard, that because of your knowledge of the match program and GME and medical education, feel free to throw in and answer any of the earlier questions that we might have had.
Happy to. We have the first principle of leadership is to hire people smarter than you. So we have Natasha Savage, who's going to answer all things GME related. Natasha grew up in Richmond County, went to UGA, MCG. But this is important. She left to go to Stanford for fellowship. I'm going to come back to that point. But she came back, and she's GME. And she just got back from a GME program she's working with in Brunswick. Next, you go to Kelly Braun. They're going to be speaking briefly. Kelly is a resident of Liberty County, and UGA, MCG, OBGYN in here and never left, right? And she was our admissions dean, but since August 1st, she's our vice dean for academic affairs. So she covers all things medical school and pipeline programs. And then lastly, Catherine Martin, resident of Allendale County, South Carolina, but right across the border. She tells me that's the worst economic county in South Carolina and educationally the most backward, but look how far you've come. And Catherine has helped oversees all of our rural campuses and has a PhD in public health, and that's enough. But the important thing, the message, everything this is relationships, and she's a great relationship person, knows everybody, because that's what you got to do with rural campuses. So I'm going to try to go through this. I'm amazed that we would never make our medical students go through 3.5 hours of talks like you have. I mean, this is incredible, right? We would get dinged on wellness and everything. We have a revolt, so I'm very impressed. I don't know what your secret is. You know, when I hear about GME funding, I get a migraine, and I got to go walk my dog. And they did a great job, but it's very complicated. So this is an important slide, a point I want to make, which is different than Florida and Ohio and North Carolina, states with larger or about similar populations, very important. And there's only 2 academic medical centers in Georgia, Wellstar MCG and Emory. And the only place you train endocrinologists, hem-onc doctors, specialists is in academic medical centers. So we have a similar population in Ohio and North Carolina. Ohio has 5, North Carolina has 4. That puts us at a big disadvantage in developing specialized fellowships. And it's something that's really going to be hard to overcome. But we are an academic medical center, and Emory is. And academic medical centers are safety net hospitals. They do a lot of research. Most of the FDA-approved drugs are developed at academic medical centers. So they're really a national resource. It's just that we're the envy of the world because of academic medical centers. Now, here's our campus, as I think Mark Newton said. We are the 3rd largest medical school as of last Friday in the country by first-year class, 304 students a year. You're always welcome to come back and visit us. The medical school is downtown about a mile, but we're always happy to, as we go to the campuses, we'll give you ideas of who to come and see. So very, very large and very old. We're the 13th oldest medical school, right? So remember about us, we're an old medical school, great tradition, we're the large medical school, and we've got 9 regional campuses, some of the most in the country. I think only Indiana has more. So 9 regional campuses. So we're all over the state. Look, wherever you're from, we're nearby. So that's our campus map. Our campus deans divide up the state. Exactly how they do that is a secret, but they do it. And those dots, those white dots, where we have medical students training now, and it's not even complete. So you're right now in the main campus. You're in what we call the Middle East. All right, we have Southeast, Southwest, Northwest, and Northeast. And our campuses really go back to 2005. So here's one campus, Albany. And Albany is our oldest campus, started in about 2005. Whenever we have a campus, we have deans there. So Doug Patton is a dean. He's a surgeon that practiced in Cordele. And Kush Desai is a practicing physician who works at Phoebe Putney, and he's the assistant dean. And so they're in the Southwest campus, and they have what's called the LIC, Longitudinal Integrated Clerkship, which just means you follow patients through the whole clerkship. You don't just do internal medicine and surgery. You may follow a pregnant lady all through her pregnancy. So it's not unique to Georgia, but it's the first campus that did it in Georgia was in Rome. And so we have students at all these campuses. Now, a lot of the students come from this area, but not all. And there's a basic principle we have to remember. Where you train is where you're likely to practice. That's why we have students in Albany, right? If they never go to Albany, they're probably never going to practice there. So this is the principle of regional campuses. And this has been shown in past studies, and we have a lot of evidence here in Georgia. This is how it works. Now, you may take a student that grew up in Marietta and send them to Albany, and they practice at Albany. So they're not all from Albany. People from Atlanta, maybe they're tired of the traffic. Maybe they're tired of things. Maybe they like to do other things, in South Georgia. So we've had cases of that. And then, this is Darlene Taylor territory. Darlene was instrumental in getting this campus started. In fact, she was the legislator of the year I should have put your picture in, but I'm pressed for time. But it's important, it's Edward Williams, you have to work with the CEO. So this is Darcy Craven, the CEO, very, very supportive. This is Savannah McGowan. So she's Savannah and Thomas, always mixes me up. And she's the coordinator, she's great. And then we have Greg Patterson, who's an MCG graduate. But the key guy, well, they're all key, is Santos up there. He's not even an MCG graduate. Raul Santos up there is a nephrologist who has kind of taken the lead on our campus. So this started in January. This is really recent, and we have 6 students down there, and we're going to grow that number. And you know, the hospital was so supportive of medical education that they bought a part of Thomas University, which is a mile away. So we already have space down there. It's a beautiful, Archibald is a 4-hospital system. So our students rotate, not just in Thomasville, but in areas around there. And then you go up to Savannah. This is different. Savannah is a 4-year campus. I showed you 2-year campuses. So this campus is only in its 3rd year. It started at 40 students, 50 students a year. We have a campus dean there, Elizabeth Gray, and we'll get to the GME part. And we work very closely with Georgia Southern, but particularly St. Joe's Candler. And so Natasha will talk a little bit about, with help from a lot of you in the room, Butch Parrish and Darlene and others, we developed a residency positions at St. Joe's Candler. This was what we call a naive hospital. So when we started the position with funding from the state, thank you, they can now get CMS dollars, right? They can bring down CMS dollars, and it will fund this. We thought we were going to start with 30. We're now up to 104, right? Has it grown since then? Every time I talk to Natasha, the number grows. And Natasha is the DIO, so she's running the program. A DIO is a designated institutional official. There will be no post-test on this, but just DIO, you hear these crazy names. And she does that for St. Joe's Candler, and now is doing it for Brunswick. She's the DIO, it seems like.
And that CMS money is from Medicare, not Medicaid.
Yeah,
that we were
Medicare and
talking
some
about.
Medicaid.
This is the
Yeah.
Medicare program that by being a naive hospital,
Right.
you were able to get. That's
Right. And that's why, you know, you want to start naive. The trouble is, this is a very important point. Not every hospital is residency capable. The staff has, I think you touched on this, the medical staff has to be supportive, and if they're not, it won't work. And it won't be competitive, all right? You gotta have competitive programs, and St. Joe's Candler, I think, will be. So this is the campus down there. I'm gonna quickly go through it. Here is Brunswick, where Natasha was, what, yesterday? Yeah, so just tell us what you did yesterday.
Yeah, so as already stated, I'm the DIO at Brunswick, and really what that means is I'm overseeing all the program there. Right now they have internal medicine. I'm making sure that the program as well as the institution is meeting compliance requirements. That way we maintain compliance. In order to retain compliance, that allows us to continue to receive CMS funding. Without accreditation, you can't get CMS funding. I met with the 2nd-year residents to make sure they were happy, getting the education they needed, and also had access to resources we have at the Medical College of Georgia as well.
So this is important because we like to work with residents where we have regional campuses, because we believe in the UME, that's the undergraduate, graduate continuum, right? We want our students to enter those programs, so we want them to be exposed to it. And if you have good residents, the residents are really good teachers, that's important for UME. So you have to look at it as a continuum. And I'm telling you, if you develop these in rural areas, not with a medical school, they're not probably gonna work. And I think you have to be really cautious about putting programs on hospitals that really aren't ready for them. Because they're not, they will never be competitive. But I think these will be good programs.
When you say competitive, you mean competing for the best graduates of U.S. medical?
Right, yes.
Okay.
Otherwise, you will have all foreign medical graduates. Every one of them. And that's, you know, for some foreign medical graduates are great. Some of them won the Nobel Prize, but it's risky, right? It's very risky. Okay, so up in Rome, there's Paul Brock. He's a surgeon. This campus, we're in the process of, I'm going up there Friday to work on some expansion. They have 12 students. We work with Advent Health and Atrium Floyd Medical Center, and we're starting to talk, we're working with Barry a little bit, and so they are the birthplace of Launcho Integrated Clerkship. So this campus is growing and moving well, and they have a lot of people that come back to Rome. There's a good evidence. They go to good residencies, and this is important. They don't always go to residencies in Georgia, but they go to residencies throughout the country, but they come back. Because Paul Brock is very persuasive. He's a surgeon. People go there and they want to do, you know, some of our other specialties get upset. They want to do pediatrics, they want to do internal medicine. 3 months later, they want to be surgeons. like all of them. Not all of them, but a good portion of them. So very, very good, very, very strong campus. And then here's up in Dalton. You know, we guard our southern border, right, Darlene? We guard Thomasville, Florida, and we guard our Tennessee border. And here we are up in Dalton, and there's Jeff Myers, the CEO. We always have to have a good relationship with the CEO, right? And Jeff is really supportive, and that's Dixon Freeman, who's our dean up there, who is an expert. If you ever get to sport, I'll give you a prize. He's in curling. Curling. Can you believe that, curling? He's a curler. And the other thing about him, he's just finished second in the Rome Dancing for the Stars competition. So we have very illustrious deans. But the Dalton campus is growing, and we're going to continue to expand up there. So that's our northwest border. And then here, Devin, right at Wellstar. You're on the board there, and we started a campus there. We've actually been working with them. Louis Lovett is the campus associate dean. He's been with Wellstar a long time. Asha Unan is a hospital. She's been there a long time. And I show here Ahmed, and Ahmed's an interesting story. So Ahmed was born in Kennestone Hospital. And when we do our match, that's when they match to residencies. I happen to be standing next to him. We were talking, and he opened up his envelope, and guess where he's going to do his residency? Johns Hopkins. Now, pretty good. Now, he's not staying in Georgia, but he's going to Johns Hopkins, which I think is really good, but he wants to come back. So this is where you want to put the people at the best places you can put them at. And then here, we really have, I think, the best, somebody told me the other day, is we have the best academic affairs team we've ever had. And here's Kelly, who has been our admissions dean for how many years? 10 years. Her nickname is Kirby Smart because she recruits so well. She's a big Georgia fan. But and then here, I can't go through all the people, but I said it's a big class. You're always welcome to come. If you want to come and visit our campus downtown, contact Ashton, Luke, or Margie, and they'll set it up. And I'm going to let, somebody was talking about this as pipeline program. So this is a pipeline program that Kelly Braun has developed. Why don't you talk about it?
Yeah, sure. You want me to do it from here? Okay. Is everybody can see me okay? I don't want to double the microphone, so I'll stay here. Sorry.
The microphone might be better.
That one? Okay. All right. Talk very briefly. So Dean Hess mentioned that I'm from Liberty County, so I graduated from the second public high school. I was the second graduating class from the second high school. Title I high school, only 60% of my school actually even went off to college. So we realize very much with our statewide impact, as you compare counties, applicants are the same. So MCG is 100% committed from an undergraduate to medical school to graduate education to impacting our statewide impact in addressing the physician need. If you look at our counties, they're not apples and apples. The AAMC released data last year that says 50% of matriculants to medical school only come from 50 universities across the nation. And so it's really the haves and haves not. So where you live significantly impacts not only your health outcomes, but also your educational opportunities and educational access and opportunities to be prepared for medical school. So we take geographic location in consideration at MCG. It's part of our selection criteria for matriculating students. This past year, a third of our class came from underserved counties within the state, and we hope to continue to increase that number. Students who commit to serving or doing their clinical rotations on our Northwest or Southwest campus, we actually give them admissions consideration because they are committing on the front end to serving those populations. And the final one that I'll highlight, we're in our second year. We talked about that AAMC data. If you're not from a large institution, your resources are less. So we developed what's called the Assurance in Medicine program, where we support rising junior undergraduate students from regional institutions within the state to give them MCAT support, professional identity formation, clinical opportunities to help them successfully matriculate to MCG. We're in our second year. We're already matriculating 3 of those students to our class. One of those came from the College of Coastal Georgia, which we have only in the last decade matriculated 3 students from. So we're continuing. This is fully funded with the support of Dean Hess and President Keene, and we hope to continue to expand that throughout the state.
Just comment, some people wonder, do we have enough good applicants to medical school? Do you want to comment on that? since you've been in the admissions team for 10 years?
So we have a lot of qualified applicants, but the majority of those applicants don't come from the counties that need them the most. And that's really where these pathways have come from, is that we can help provide additional support and consideration. When we developed the AIM program, we looked back at 5 years of historic admissions data to see where those applicants came from those different institutions and what their preparedness looked like. So this is to help address that educational inequity.
Can I ask a quick question, Kelly, on that? The linkage to the Northwest or Southwest, for example, is that, it doesn't mean they had to have been born or lived there.
Correct.
It's that they could, if that's something they've looked at and they know it's something that gives you attention, if you will, in the admission process, and but they can make a commitment even if they weren't from there.
Yes, sir. But that is a separate admissions application, and the committee reads through every line of that, and they have to be fully committed to that area to actually be given that preference.
Thank you.
So a few years ago, actually right there in the pandemic, we didn't know the pandemic was coming, we redid our whole curriculum. And so our curriculum allows you to graduate from medical school in 3 years. It saves a year. And we went to actually Centene, Peach State Health, and they gave us over $5 million, which the state matched, thank you. And then we continue to get a match. And now we have an endowment of well over $50 million. And what happens here is basically a scholarship for service. So after the first year, and Catherine will talk about a little bit more about this in a minute, she'll talk about some of the students. We select them, and then they graduate in 3 years, and they have to practice in a health provider service area deficient, right? I didn't say that right. Health service professional shortage area, HISPA, you know? That GME funding got me all off. But they have to practice in HISPA, so we work on that. So this is an area where we get people to go to rural areas. And we have all these other programs. You can get a dual degree, get a master's of public health. So our curriculum is very, very innovative. And I'm going to let Catherine talk about these students. We just had a pinning. Just talk about our program, because Catherine oversees these students and where they go. And right.
Thank you. Thank you for your time today and your commitment and your contributions to our medical school, and particularly for these students. They have just, when they come into medical school, they are ready to go in the varying capacities of disciplines. And sometimes they know where they want to go, and sometimes they don't. Sometimes they find their way while they are in medical school. But those who do know that they would like to be in primary care have an opportunity to be what we call a 3+ student, or a Peach State Scholar, where they can actually finish medical school in 3 years and go directly into a residency program in primary care. This gives them the opportunity to reduce their cost for tuition by 1 year. Additionally, if they follow through and do exactly what we ask them to do, which is to go into a residency program in Georgia and then serve 2 years in Georgia in a medically underserved area, then they receive 2 years of scholarship. And you do the math on that, you end up paying 1 year of medical school tuition. That's the deal. The second part that's most important is the fact that you can actually see them coming into medical school, and then 6 years later, they are practicing. And to me, that's something that is important, because we can live that long and see that return on the investment sooner rather than later. We have started out with 6 years ago, we had the 6-year pinning ceremony Friday, and we pinned 15 students. But we started the program 6 years ago. That means those are just coming out from residency, and we had 5 that are going into practice this year. We celebrated them, and they are in Union County, Donaldsonville, McDuffie County, Washington County, and Tifton. So that tells you where they're going, and they are satisfied, they're happy where they're going, and we'll be graduating 8 more next year from residency and hope to expand the program further. Financially, we have the capacity for 25 students per year, And that's a significant number that could go into one of the disciplines that has been selected, which is pediatrics, emergency medicine, family medicine, internal medicine, psychiatry, obstetrics and gynecology, and surgery. Stay tuned for more. How'd I do?
That's great. She's ready for questions at the end. Another area we want to talk about are the FQHCs. The FQHCs, I always tell, medical students and doctors know nothing about this, and they're probably the greatest resource we have. And the good news is they have bipartisan support, and everybody likes them. They have good quality metrics. And so we have affiliation units with 60% of the FQHCs in Georgia. And this is twofold. They want our students to be eventually, they want to hire them. They need physicians. That's one of their biggest needs. They actually say they have enough nurse practitioners. They're short of medical assistants and doctors. So we get our students in there, they get exposed to it, and then our students get training. So the FQHCs are key. We're working on a residency program with a group of 3 of them. So this is very, very important. And this is a destination. If we're going to put student doctors and doctors eventually out in rural areas, a lot of these areas are physician deserts. They're not going to survive unless they're with other physicians. So the FQHCs are a great destination for these physicians because they already have an infrastructure set up. They just need more doctors. So this is a huge resource, and we're highly supportive of them. So I'm going to let Natasha cover this, if she doesn't mind, because she lives and breathes this every day.
Hey, everybody. So as already mentioned, I'm the DIO at the Medical College of Georgia, and I'm also the DIO at Southeast Georgia Health System in Brunswick, Georgia. So I do GME every day, as already stated. So the Medical College of Georgia is the second largest producer of graduate medical education, meaning our residents and fellows in the state of Georgia. Emory's #1, we're #2. When you combine Emory and the Medical College of Georgia, that's about 50% of all your residents and fellows in the state. Recently, we increased from 50 ACGME accredited programs to 56, and I'm actively working or have submitted applications for 5 more programs, so very soon we'll have 61 programs here at the Medical College of Georgia.
And that's 61 different specialties, if you will, right? Like, what are some of the smaller fellowship?
That's exactly right. So, truth be told, we are 60 different specialties because we have 2 internal medicine programs, but other than that, everything is unique. So we cover the gamut of everything. We have hem-onc, endocrinology, cardiology, pulmonology. We're going to have pediatric ENT. We have pediatric hospital medicine. We have pediatric cardiology, and then all the big ones you know. We've got pediatrics, family medicine, internal medicine, psychiatry, OB, pathology, etc. So very diverse. This past year, we welcomed our largest class ever, so we onboarded 228 new residents and fellows in the last week of June, so that's 228 more doctors working in the state of Georgia. Right now, we have our biggest class we've ever had, so all of our residents and fellows combined, we have almost 650 residents and fellows, so this is huge for us. And we have a significant support from the state and then also through federal funding as well, and also through WellStar that's allowed us to realize this growth. So let's see, statewide GME leadership. So it's very important to me as a Georgia native, as already stated, I've lived in Richmond County almost all my life. I was born a couple minutes from here. So Georgia is very important to me, and the healthcare of all Georgians is very important to me. And I realize that we can't make everything happen in Augusta alone. We have to partner with our rural communities, our other hospitals, et cetera, to make sure they're also successful. So we do that by many ways. Different DIOs will contact me, asking questions, et cetera. I support them, anything that they have. We also offer rotations here in Augusta for different hospitals and different programs. As already stated, I now serve as the DIO in Brunswick, so I oversee their internal medicine program there, which they have 2 classes, a second-year and a first-year class, and when they're fully grown, they'll have about 39 residents in training there. Archbald was already mentioned, but is very well known. We have co-branding with them as well, and a lot of their residents come here and do fellowship programs. As a matter of fact, one of their recent internal medicine residents is now doing GI training, and she's committed to go back to her home hospital to provide care to those patients in that community. We also recently supported a FQHC as Dr. Hess already mentioned, it can be very challenging to develop residency programs in rural communities. So for instance, if you want to start a family medicine program, it can be challenging because family medicine residents have to have exposure to a newborn nursery. They have to have exposure to a pediatric ER. They've got to have exposure to an ICU, et cetera. So when we partner with different places, we offer these opportunities that they may not be able to do in their rural community or their home. So like we said, this FQHC, we recently supported them to allow them to do a portion of their training here in Augusta. And as already stated, St. Joseph Candler in Savannah was a naive hospital, and we recently submitted an application and received accreditation for internal medicine. Our first residents for that program will walk through the door July 1 of 2027, and I'm actively working on an application for family medicine, and they will walk through the door July 1 of 2028. So again, we're expanding GME in the state of Georgia. That's through partnership with St. Joseph Candler, where we'll have over 100 residents and fellows in training there. And we'll see them starting in July of 2027. And we also intend to submit an application for cardiology as well as general surgery. And then this right here is just some growth that's been done here in the Augusta area. This has been supported through WellStar. It's also been supported through federal funds such as the Consolidated Appropriation Act. So you can see since I've been DIO here, we've had significant growth in our programs. You'll see a lot of these are very subspecialized specialties. So for instance, interventional pulmonology or neurocritical care. Fellowship programs like that, it's really hard to have anywhere other than an academic medical center. So MCG and Emory are uniquely able to support fellowships. So if you kind of Google where all are pathology residencies in the state of Georgia, it's just going to be us and Emory, that kind of thing. So essentially we have unique resources that allow us to do subspecialty training. And then that's it for me, and I'm going to turn it over to Dr. Hess.
Just comment on one of the reasons we could grow residencies here. Talk about the rural hospital designation.
Oh, yeah, definitely. So very recently, WellStar MCG Health applied for rural reclassification in regards to CMS funding. So essentially, once they were rural reclassified, what that did, it allowed us to start new fellowship and residency programs that were capable of receiving CMS funds, which is substantially better than a naive hospital because naive hospitals have 5 years to build a cap. Whereas with rural reclassification, for every single one of the programs I start, I get 5 years per that program. So if I decide 10 years from now to develop another program, I still can build a cap. I get 5 years for that program alone. So literally 10 new fellowship and residency programs are being started or have been started at MCG due to WellStar MCG Health's rural reclassification.
Does that mean you classified Augusta as rural, or does it, or got it into a designation? It's obviously not metro, but.
Yeah, basically got it into a designation. It met certain criteria to be considered rural for CMS, underserved patient populations, et cetera, so.
It's impressive.
Which provides a lot of funding. Like I said, 10 residency and fellowship programs, including vascular surgery, pediatric hospital medicine, et cetera. A large number of the programs you saw here that are like July 2027, et cetera, these are all programs I've started after rural reclassification that allows CMS funding. Despite the fact our cap was set in the 90s, we now are allowed to have more programs for CMS funding because of that.
Chairman Hawkins, did you have a question for the team or anyone in particular on the team?
Yeah, well, clarification,
Because it's
anybody
impressive.
is fine. You know, we've been dealing with the national match and how we were losing our medical students going out of state, and that's been a real concern, especially Chairman Parrish. And those of us been traveling the state like a circus for the last 5 or 6 years. But am I understanding you right, that with your Peach State Scholar, and when you start up these programs, you don't have to go through a national, you can do a direct match with your students?
They go through the NRMP, so the matching program, but we have specialized spots for our 3+ program. So in my office, I make sure our 3+ students, our Peach State students, have unique codes that only they are going to be able to use.
That is great. I like that.
I do too.
Okay, yeah. All right.
Can I ask Dean Hess a question, and maybe or is this your ideas for the future? Because one of the questions that young man that was born at Kennestone, that I guess was going back there for his residency, and you told him he's going to train at that little place up the road called Johns Hopkins, and hopefully come back. I see your medical school scholarship. Tell me about the difference between whether he should stay at a smaller, newer program in Georgia, or should he go to an established one with a track record, and then we just got to figure out how to make sure when he's ready to really practice and take care of people, he comes back here.
Yeah, I think if you go to Johns, you should go to Johns Hopkins, right? It's the best residency program in internal medicine in the country. So this, just like Natasha went to Stanford, right? I don't think we want our students all to stay in Georgia. We want them to go to the best places. We just want them to return, right? And don't forget, most of our students, we take 95% in state. They went to high school in Georgia, usually Metro Atlanta, honestly. They went to UGA or Georgia Tech or AU or Kennesaw State. They went to MCG, and unlike Kelly Braun, they do want to leave eventually, right? And so our students match at great places. If they go to Stanford or Johns Hopkins or Vanderbilt, that's good because they bring things back that we don't teach. And there's more opportunity. Like if you want to be a urologist, you have a urologist, right? You have Emory and us. Those are your only choices. There are so many more programs throughout the country. So it's much more economical, and it's much better for the state, much better for our students to say, go to the best residency you get into. Just come back. Pay their tuition. We have the lowest tuition almost in the country.
It's not either or, it's both and, though, right?
It's both and.
Grow the
It's both and.
residencies.
Yeah,
the
that's
ones
what I'm getting to,
we're good at,
Yeah.
and the ones.
But yeah, it's all three of these you have to do. But if you have this, then you'll get those students, let them go, and then bring them back, pay $140,000, which is a lot less expense than developing residencies. Now, you have to develop some residencies, but I would rather do that than develop residencies in hospitals that are not capable of really supporting residencies. And that's kind of what we're getting into. We're running out of spots. We're running out of spots. The other thing is expand the Peach State Scholars Program. Let me get to this because it is threefold. Right now, they can only do certain specialties. So they can do internal medicine, pediatrics, emergency medicine, psychiatry, surgery, OBGYN, but they can't do anesthesiology, which is super short, and we have locum tenens all over the state. They can't do neurology, they can't do a lot of other things. We would like to expand the Peach State Scholars Program to all specialties. And then selective state funding for GME above the cap. The greatest thing about the Rural Designation Program is you didn't have to spend any state money for it. You know, it was basically a loophole in the regulation that allowed us to do that. So we got to keep looking for those and be smart and making sure we develop residencies in hospitals that can sustain them and get good residents. I'd much rather have our students go to the best place in the country but come back. So I think all three of those have to work. It's not either or, it's all three.
Representative Mitchell, did you have a question?
Interesting. What's the rationale behind limiting specialties?
It started with primary care, and then that got
question.
expanded.
I think that the emphasis was on primary care shortages, and so the Georgia Board for Healthcare Workforce, this is their primary care specialties, but there's been insufficient recognition of the shortage of specialists. Have any of you tried to get an endocrinology appointment, neurology appointment, gastroenterology appointment? It's impossible. Because we have shortages everywhere. And you know, as Natasha will tell you, just being down in Brunswick, the residents in these internal medicine programs, they want to do one of those specialties. And we don't have them in Georgia. We don't have enough cardiology slots, GI slots, right, hem-onc slots. So they're going to leave anyway to do fellowships. So we just got to recognize that. But that's the reason. But we want to address the specialty shortage. And you know, you need anesthesiology is a huge shortage. Neurology is a huge shortage.
I do see what you mean about the support that the medical college can bring to these residencies, that if they were trying to do it de novo in a city that had no backup like this, and I appreciate y'all doing that. Representative Seabaum.
Yeah, thank you. And thank you all for your presentation. Your love for your school is infectious, and we appreciate your presentation today. And I really want to tell you how much I appreciate the 3-year primary care program that you have in place, and that those students are actually staying in rural Georgia. How long do they have to stay in that primary care practice before they could move on to a specialty? Because I would imagine after maybe 5-6 years, they might want to
It's 2 years. It's the number of years they get a scholarship for. Now, in the future, we'd like to actually select them when they come into medical school. So if they got 3 years, it's a year-for-year scholarship for service.
So they're being offered that during their first year, that this is an option to get out of tuition your second 2 years of, and if you'll agree to the post. Chairman Parrish.
Thank you. Thanks for the presentation and some good information there. I got a couple of comments for you and then a couple of questions to Dr. Hess, to you or the team, whoever wants to answer them. But what I want to know is, the bottom line is, how do we get more Georgia medical school graduates to do residency training in Georgia? That's the bottom line of what I want to know. But then I want to also ask you, you mentioned to us about the Peach State program, and I think that's an excellent way because they go directly into that match, so we know that they're going to be there. But that program, I don't think is for everybody. Not everybody is the right match for, or the right fit for that program. But what can we do to do that? And then you mentioned about really the only 2 places in the state where you can do your fellowship or your specialty training is MCG and Emory, I think is what I heard. So what can we do? Do we need to have more residency programs? Do we need to have more fellowships so that we can do this? Y'all are all at your caps, I'm guessing. Or if you started another residency program like with CHOG, Children's Hospital, pediatricians have got to come to the big hospitals to do their training. There was a proposal out there that they do 2 years of training in your hospital and then do 2 years of their 3rd and 4th year of training out in a more rural area with the backup of their training in the initial hospital. Would that have to increase the cap, or is that a new program where, Natasha, they would be funded from CMS, or what?
Yeah, these are called rural track programs, and essentially ACGME helps support them as well. And just like you said, you do 50% of your training somewhere, say in Augusta, and then 50% in the rural area. They work best in primary care programs, like you said, pediatrics, family, et cetera. The challenge with those is to identify candidates that are willing to spend 50% of their time here in Augusta and then 50% of their time in rural areas, because a lot of these residents are coming in with families. And so it can be very challenging, you know, as a mom or a dad, to kind of split your time between 2 locations. And why can't they do all of the training in rural Georgia? Well, all of these programs have ACGME compliance requirements, and they typically require exposure to certain things. So for instance, if you want to do pediatrics, you got to have pediatrics to cardiology, to heme-onc, to endocrinology, to GI, and you may not have those specialists in rural Georgia. So that's why they divide it between, say, Augusta and a rural location. But again, the hardest thing with those is identifying candidates that are willing to split their training between 2 different homes, particularly because residents are having more families and things nowadays. So that's the challenge. There is funding for it. There's substantial funding for it. It's just finding the right candidates for that. So, and then, I don't know if you want to add any comment.
No, I'll make an additional comment. Can you hear me okay? You're saying, how do we get more of our students to stay in the state of Georgia? Some of it's a capacity problem. So for instance, I'm an OBGYN. We only have 6 slots. It's an incredibly popular specialty for MCG students. 26 to 30 of our students will declare OBGYN. 2 of our slots are already committed to our Peach State Scholars, so that leaves only 4 for the rest, and so there's not even enough OBGYN positions within the state of Georgia to even support the additional 22 to 24 that would have to match. So incentive might be part of that to get them to come back. Yeah.
So is the answer part of this, we need more residency slots, but we need more fellowships also, or is one more necessary than the other, or what?
I think that's all important, but you know, students, like if you're going to orthopedics or dermatology, you have a list of the top programs, which is kind of consistent. It's not published, but they want to go to the best program they can go to. You know, if they've done everything in Georgia, if they can go to Harvard, they're going to go to Harvard. If they go to, you know, University of Pennsylvania, they're going to go there. They're just going to go to where the programs have the best reputation. And I don't think that's a bad thing, and I'm not sure we can ever, you know, we can create more positions, but some of that is good. You know, as was mentioned, we're not, you know, Georgia ranks, they said 11th. I always like a better number. I got 17th in the AAMC in the country and students who come back to Georgia. So we're not terrible, we're top 20 there. But I'm saying, I'm not sure that is the road. I mean, we can create a few more positions, but our students are gonna go to the best programs. They're gonna go to the Cleveland Clinics, they're gonna go to Stanford. And they're very well paired. Our school has an excellent reputation. And once they start going to Hopkins, they say, let's take another MCG student. Our students are very clinically well trained. So I'm, I don't want to be counter to a lot of things here, but honestly, I think you encourage them to go and then bring them back. Work to bring them back. And as I said, it's threefold. Selectively more GME slots, but do them in hospitals prepared to take them. And we have a capacity issue. We can't have an endless number. Can we have more GI fellows? We've already stretched.
No, so with everything, there's requirements. So for instance, if you want to have this particular specialty, you have to have this many cases of this. And if you don't have that many cases, they're not going to let you grow that much. So you have to document that and submit all that data before they're going to let you grow. So a lot of our programs, not all, but a lot of our programs are at capacity. And capacity could be different things. It could be the number of faculty that are there to teach. It could be the number of desks there are to sit at. It could be the number of surgical cases. It could be the diversity of the patients, et cetera. So a lot, as Dr. Hess has already said it, a lot of this can be helped or solved by encouraging our medical students to go and then come back. And you don't want them to just train in Georgia because they're training what they already know. If you send them somewhere else, they're going to learn something we wouldn't have taught them here, and they're going to bring it back and help us with that. So same thing with my training at Stanford. There was not a lot of expertise in benign hematology as far as the pathology department. I went out, learned expertise in coagulation and hemoglobinopathies, and I brought that back to my department. And I knew that my department needed that at Augusta, so I went with that interest in mind to educate myself in that field by experts, international experts, to bring it back to my home and to my community, essentially. And I think that's what Dr. Hess is really advocating for. And as everything in life, one approach is not going to fix everything. We need multi-pronged approach. And so I think definitely encouraging to go to the best of the best, but come back home, as well as growing selective GME spots, as well as increasing Peach State Scholar to all specialties, pathology, anesthesiology, et cetera.
Thank you for that. One last question, Chairman Taylor.
Thank you. Chairman Parrish covered a lot of what I was going to discuss, but I have one thing that kind of jumped out at me. How much exposure do our medical students get to public health? This is an area I see that we need to grow in, and after COVID, that's an area that I've been concerned. How much exposure do they get? Thank you.
Thank you. If I were queen for the day, I would have a mechanism whereby students who are going into specialties that address the critical disease states of Georgians. And when I say that, you know this already, heart disease, hypertension, stroke, diabetes, those areas, that would be where I would place my numbers if I were queen for the day. I work for the dean. Let's see what he's got to say.
I don't disagree with my expert.
There is a combined degree of MD and MPH that's offered now, right? That's one of those extra things that you offer.
Yeah, we have a school of public health now. I saw Teresa Waters, she was here, she left. So how many MPH students do we have a year? 20?
Yes.
We have about 20 a year getting combined degrees in 4 years. So a lot of them leave with MPHs. So yeah, that's available. We have good training in public health.
Thank you.
Well, on behalf of the committee, I want to thank you all for your presentation, for your work, most importantly, but also for what you've been able to, I believe, very succinctly and good depth present to us. We have a lot to digest. And speaking of digestion, we're going to take a lunch break. Oh, Representative Jones, did you have a question? I apologize.
That's okay. Thank you so much for the acknowledgement. I think I'm looking more for adding capacity, and I thank you for your presentation and all the information that you provided thus far. I really love the Peach State program that you have. What is the penalty if the student does not do what they said they were going to do as it relates to the commitment? And on top of that, can the student be released from the commitment? Do they have to pay back? I'm just curious. Thank you.
I would appreciate if you would repeat the questions. I think there's two there.
It is definitely two. The first question is, how do you enforce the commitment that's made by the student when they decide they're gonna come back and be in the more rural area, like the student that's at John Hopkins now he says he's gonna come back.
Okay.
And then the second thing is, if that student that's at John Hopkins, let's say he gets a better commitment from somewhere else, can he pay back to school? What are those things to release him from that commitment?
When the students come into the Peach State program, they sign a contract that to help them understand the significance of this commitment to us financially and otherwise. So for us to accept them, they sign the contract. If they fail to follow that, if they go somewhere else, then they have a commitment to return the money to payment. As of this week, we had our first one to step away from the Peach State program, and we'll be working through that process to pay the money back. Was that an answer for both questions? Okay, thank you.
All right, once again, thank you very much. And we have a break coming. I know as an emergency physician, I care a lot about the patients who are brought in by ambulance. Those are some of the most challenging. That's going to be our afternoon session to deal with EMS, the emergency medical services, the importance of them, the challenges and the opportunities. So thank you all. Thanks once again for hosting us, MCG, and we'll take a break.
You always take a good
We'll get started in 3 minutes. We are making it a little warmer in here. All right, well, welcome back, everyone. We'll go ahead and get started with the second portion of our meeting. It's been a productive morning hearing about ways we can deal with some of the physician workforce challenges in Georgia and for the next generation. This next area we're going to be talking about, obviously, as I mentioned, is an area near and dear to my emergency physician heart, which is caring for patients who have an emergency, but they're not at a hospital yet. And there's a whole lot more than just transporting them to a hospital. There's a lot more involved in pre-hospital care that is incredibly life-saving, life-changing, injury-saving, and those little portable ICUs that go out and basically take care of our loved ones and our friends and family are a crucial part of the health care that Georgians receive. The number one leading cause of death under the age of 45 is trauma. And so certainly a lot of those are when EMS is involved, but it's certainly involved in strokes and heart attacks and appendicitis and 1,000 other things. So we are going to look at some challenges and some opportunities. And to start with, I think we're going to get a little bit of a national overview. So I'll have to remember in particular myself when I have state-specific questions. Those may be coming a little later, but Anissa, if you can come on up from the National Conference of State Legislatures to try to give us an overview on what emergency medical services and what might be going on across the nation, and maybe things for us to consider. But please introduce yourself and your organization and proceed.
Thank you, Chairman Newton, and thank you, members of the study committee. I'm Anissa Korzanowski, a policy associate with the health program at the National Conference of State Legislatures. How do you work this? I got it. Yep. As you heard from Kelsey this morning, NCSL is bipartisan. We serve legislators and legislative staff from all 50 states, DC, and the territories. NCSL does not take any positions for or against state policy, so anything that you hear today is just for informational purposes. Any resources that we share are for that. So I'm going to be walking through 5 things: the national landscape of EMS and why EMS finances look the way they do, how states govern EMS, the workforce picture, some funding mechanisms that other states are using, and finally where EMS is showing up in the Rural Health Transformation Program plans, including Georgia's.
Excuse me just a second. We do have a couple of members who've had legislation related to this, and I do want to make sure that, and some that are in the business as well, I want to make sure they know that I really hope you guys will, whoever's involved in that will ask the questions that we need answers to help educate the rest of us who may not have studied it as much as you all have. But thank you. Go ahead.
Yes. All right, well, I'll go ahead and start with the national picture because what we're hearing in Georgia is not unique to Georgia. We hear the same core issues from legislators from nearly every state. Across states, EMS is expected to be available like a public safety service, so fire or law enforcement, but they are paid like healthcare. So payment is received typically after transport has been happened. My next few slides will touch on 4 challenges we've seen nationwide: access to care, the cost of readiness, workforce shortages, and rural services. So access to care is one challenge we hear about most. If you call 911 in a health crisis, will somebody answer? Will an ambulance be able to reach me? How long will that take? And so researchers at the University of Southern Maine mapped what they called ambulance deserts, or areas with limited or no access to ambulance services. So the map on the screen shows the share of the population living in one by county. And then you'll see on the table on the right has a few measures for Georgia and its surrounding states. Just over 2/3 of Georgia counties contain an ambulance desert, and Georgia has fewer ambulance stations per 100,000 people than Florida or South Carolina, but more than Alabama, North Carolina, and Tennessee. So several challenges affect access to care. The first is money, specifically how the money arrives. When you fund a fire department or a sheriff's office, you are paying for availability. Nobody expects a fire station to generate revenue proportional to the numbers of fires it puts out. Ambulance services, again, mostly get paid only when they transport a patient to a hospital. So a rural crew can sit at a station all day and generate almost no revenue. But the cost of keeping the truck and that crew ready is nearly the same whether there are 2 calls or 12. In 2024, the average Medicare reimbursement for an ambulance transport was about $1,100, and you'll see the average cost to the agency was about $2,600. So that gap is the cost of readiness: round-the-clock staffing, vehicles and transportation, training and administration, and the capacity to handle higher call volumes or provide mutual aid to a neighboring county, for example. Now we'll talk about workforce, which is the second factor. Turnover in EMS is significant. The national average sits around 23%. So that's close to 1 in 4 EMS clinicians leaving the profession any given year. So for an agency, that's a cost. Recruiting, training, onboarding over and over again. When clinicians are asked why they leave, 4 reasons come up consistently. Work-life balance, the shifts are long, and the work is hard. Compensation, typically EMS clinicians can make more money inside the healthcare and outside of it. So health and safety is also another factor, which covers workplace violence, mental health, and burnout. And then there's also been stated a lack of growth opportunities, specifically in leadership. And nearly all of this lands harder in rural, frontier, and remote communities. Nationally, about 4.3 million Americans live more than 25 minutes from an ambulance service. 4 out of 5 rural counties contain at least one of those areas. In Georgia, 53 rural counties have no hospitals. Now that's a hospital statistic, but it becomes an EMS number because the local ambulances absorb the distance. In 2022, NHTSA, which is the federal EMS office, did an assessment of Georgia's system and discovered a related point. Agencies are reluctant to send their only ambulance and crew on a long transport because it leaves their service area uncovered. So rural areas typically lean more on volunteers, but volunteerism is declining, which leaves a hard question. How does an agency staff up when it does not have the revenue to hire? So 4 pressures show up again and again in rural systems: funding, staffing, non-emergency call volumes, and operating costs. Now governance. Who is responsible for making sure people can get an ambulance statewide? This covers where the state EMS office sits, what authority it has, and what role boards or regional structure play. So federal law does not require that EMS exists anywhere. It does not set minimum response times or coverage standards, and it does not pay for the cost of being available. There is, as I mentioned, a federal EMS office. It sits at NHTSA, which is the National Highway and Traffic Safety Administration. It provides technical assistance and national standards, but it offers no regulatory authority over how services are delivered. So 4 questions land on states. Is EMS a required service? What agency regulates it and how? Who is accountable when coverage is unavailable? And how is the cost being available paid for? Unlike most public safety functions, there is no single federal framework here. So responsibility often ends up split across state, regional, and local entities. So EMS offices generally sit in one of 3 places: public health, which is the largest group; public safety, which is smaller but a growing group; or a standalone authority, which is the smallest group. Georgia's Office of EMS and Trauma sits in the Department of Public Health. Now there is variety in each of those categories too. So under the public health umbrella, some report directly to department leadership, while others are housed within a division, bureau, or section that sits 1 or more layers. Woo. Sorry about that. Below the department head. So New York actually recently moved its EMS office from a bureau to a division within the same agency. So it raised its organizational status without changing where it's housed. On the public safety side, Utah moved its Bureau of EMS to the Department of Public Safety in 2023. And Idaho did something similar in 2025, moving their EMS bureau into the military division. It is worth noting that Utah's legislature, when they did the reorganization, it came packaged with funding and an essential service designation at the same time. And then on the standalone side, Maryland has an independent state agency governed by a state EMS board with dedicated operations funds. Kansas has a standalone board of EMS that is also the licensing agency. And the thing I would offer here is that placement alone does not tell you how strong the EMS function is. Reporting level, dedicated funding, staffing authority, and broad powers are all matter. So the more useful question may not be which column is best, it may be who has the authority, who pays, and who is responsible for the service residents expect. All right, now we'll take a look at some EMS boards. When you look at a board, what it's actually allowed to do, there are 3 broad tiers. First is advisory. The board recommends to the agency, but the agency keeps the rulemaking and licensing. Georgia is closer to this end with regional EMS advisory councils and medical direction structures supporting the state office. Then you have second, rulemaking approval. The agency drafts, but the board has to approve before adoption. So California's Commission on EMS works this way. It reviews and approves regulations and standards developed by the EMS authority, and it hears appeals on the local EMS system plans. And then third, we have the full regulatory authority, where the board is the licensing agency. The Kansas Board of EMS adopts regulation, certifies providers and services, and something to note here is that it is required that there are 4 legislators who sit on this board, 2 senators and 2 representatives, and they're each named by their leadership. All right, now workforce. I'll walk through how states are approaching this in 3 areas: licensure and certification, scope of practice, and recruitment and retention. So I'd like to start workforce with licensure because it is the front door into EMS. States make a few decisions here. What level of regulation fits this occupation? Certification by a third party like the National Registry, state certification or state licensure. What levels of licensure should exist within the state? And I did not put on this slide because Georgia already participates, but the states also work on a license portability across state lines through the EMS Compact, meaning that an EMS clinician who is licensed in Georgia can also work in participating states in the EMS Compact. So once someone is licensed, the next question is, what are they allowed to do? So scope of practice is what an EMS clinician is legally allowed to do under their license or certification in that state. Most states start with the national EMS scope model and then differ on how much flexibility they build in. Some tie closely to the national model, some give more authority to the agency or its medical director, and some spell it out in state statute. In Georgia, scope is approved and finalized by the medical director of the EMS agency. This matters because it shapes how quickly a system can adapt to new models of care and how much oversight the legislature keeps in place. I included pre-hospital blood transfusion because it's a clean example of scope and payment showing up together in real life. So Georgia providers are already doing this. Metro Atlanta Ambulance and South Georgia Medical Center are 2 of them. So innovation is happening. Scaling it takes more than clinical interest, though. It takes scope, logistics, oversight, and a way to pay for it. Historically, EMS has been treated as a transportation service. You call, they come, they take you to the hospital. States are increasingly asking whether some calls can be handled another way through community paramedicine. That might mean treating someone at home without transporting them, taking them somewhere other than an emergency department, or scheduled follow-up through mobile integrated health. Scope and payment both shape whether the programs get off the ground. Clinicians need the authority to provide the service, and providers need to get paid when the call does not end in a hospital transport. Georgia is already funding a treat versus transport pilot through the Great Health, and I'll come back to that at the end. And then on to recruitment. States are looking at different pathways into the profession, growth within it, and pulling from across other fields. The National Registry used to require applicants to be 18 for EMT certification. That ended in 2020, and age requirements largely fell back to state statute or administrative code. Many of the states listed here have lowered the age of EMR or EMT certification to 16, so high school students could enter earlier. States are also building career ladders inside of EMS. Maine and West Virginia both created programs to help EMTs become paramedics. And some states are also looking at equivalent positions in related fields, such as military medical personnel. Georgia allows military medical personnel to operate provisionally for 12 years. 12 months, not years. Compensation is one of the reasons, reasons that clinicians leave. So states use incentives to lower the cost of joining and staying. Three approaches come up most often: scholarships, tax relief, and direct awards or stipends tied to training or service. So Kentucky uses scholarships, Maryland offers property tax assistance, Maine and Tennessee use service awards or training pay supplements. And then several states have extended benefits commonly associated with other first responders to EMS clinicians. That includes PTSD-related workers' compensation, line of duty benefits, retirement eligibility, and access to public employee benefits or insurance programs. So retention is not only about pay, though. It's whether clinicians can stay healthy and safe enough to remain in the field. Recent data suggest about 1/3 of EMS clinicians report suicidal ideation. That's roughly 7 times the rate in the general population. And another half report high levels of burnout and emotional exhaustion. State policy in this area tends to focus on workplace violence, peer support, confidentiality protections, so allowing clinicians to feel that they will not have any punitive damage for reporting they're having struggles, and then broader well-being supports. All right, that brings me to funding. So one place states start is whether EMS is defined as an essential service in statute. At least 19 states in the District of Columbia do that explicitly, and Georgia is one of them. So defining EMS as essential can open the door to funding because it establishes it as a service government must provide. But the designation on its own does not always answer that question that follows. What level of service? What level of government? City, county, or state? And how it gets paid for over time. A couple comparisons. Alabama declared EMS as an essential public service in 2022, and Georgia defined ambulance services as essential this year. North Carolina, for example, does not use the word essential, but it does require every county to make sure EMS is provided to its residents. So there are 4 main tools show up in state law: dedicated state funds, smaller dedicated fees, Medicaid supplemental payments or rate changes, and coverage for non-transport or alternative response models. So here are 2 examples of dedicated state funds built on different design choices. So Florida's Emergency Medical Trust Fund uses a defined allocation formula. So you have 45% is divided among counties based on what they contribute, 40% goes to matching grants for local agencies, 15% covers capital equipment, personnel, education, and then any unused portion goes to expanding rural grants. Nebraska chose a different design choice. Its EMS Operations Fund is not locked into a detailed formula. It's a flexible fund that can take in several types of revenue, and it's paired with annual reporting back to the legislature. So smaller dedicated fees are rarely the main source of funding, but they can create a steady stream of training, equipment, or statewide EMS programs. Nevada dedicates an EMS license fee to EMS training. Alabama allows local vehicle registration options in some counties, subject to voter approval. And Iowa has an EMS specialty plate, and those fees are reinvested in EMS statewide. So this is where scope and payment meets. If a clinician, scope of practice and payment meet. If a clinician can treat someone at home or take them somewhere other than an emergency department, does anyone pay for that? Mississippi requires coverage when ambulance services treat or assess a patient, whether they transport them to an alternative destination or provide care without transport. Pennsylvania took a measure first approach. It required a study of how unpaid non-transport calls affect provider finances, and then the findings will be reported back to the Senate. All right, and then I want to close with the Rural Health Transformation Program because it's one place that EMS is showing up in current state planning, including Georgia's. So at least 6 states reference transportation in their applications, and at least 5 proposed initiatives specifically around transportations for aging populations, and several proposed new service lines in regional hubs, technology, investments, and mobile clinics. Here's Georgia alongside its neighbors. So these are EMS-specific initiatives, each state outlined on its website. Georgia's plan includes telehealth and EMS units, treat versus transport, reducing wait times to preserve availability, expanded capabilities, and scholarships to recruit and train EMS professionals. Neighboring states have proposed teleconsult support for EMS, so that's maybe connecting them with an emergency physician or a behavioral health specialist, community paramedicine, treatment in place, post-discharge support, and paramedic-initiated medication-assisted treatment, and workforce retention commitments. So on the right, you'll see some Rural Health Transformation Program-related bills from 2025 and 2026. So Alaska had one on EMS clinicians, South Dakota one on EMS funding task force, and Missouri on appropriations. So there's 3 things I want to leave you with. First, a lot of what looks like an operational problem in EMS starts as a financial one. EMS is paid for transport. What communities need from it is readiness. Those are not the same thing. Second, when states change governance or workforce policy, that label matters less than the details. Who has the authority, who pays, and who is responsible when coverage is strained. And third, no size fits all. States have a range of tools here: funding, workforce, governance, and they may be used in different combinations. So with that, I have a couple NCSL resources if it's helpful. They are hyperlinked on the digital copies for you all. And we do maintain a legislative database on enacted EMS laws from 2021 and onward. And we also track states defining EMS as essential if that is something that people are interested in. And my contact information is on the screen, and I'm happy to take any questions.
And again, I'm Kelsey George, also with NCSL. Anissa and I co-cover EMS, so I'm here to support on any questions as well.
Any questions from the committee this time? Representative Seba.
Hey, thank you for your presentation. It's great information. I don't know that I agree with 100% of it, but on your average Medicare call, is that across all states?
Yeah. Yes.
Because California pays a lot more than Georgia does, so that's probably double what we get paid per transport, I would think. And then what was my other question here?
While you're looking that up, I have a question about that particular slide. I know with a lot of our hospital or other health center charges, what Medicare pays, insurance might pay 200 or 300% of that, maybe even up to sometimes hospital charges. Hospital CEOs have told us that sometimes their charges, their charge master is 5 to 8 times whatever Medicare allows. Do you see that do you not see that kind of spread in EMS payments? I mean, are there carriers that pay $3,000, and is that the $1,100 was Medicare, not an average necessarily?
Mm-hmm. Yeah, from what I've seen is a lot of states are doing surprise billing legislation. So capping surprise billing. So it's basic or balanced billing. So what that is basically capping what a ambulance service provider can charge, and it's usually matching with that Medicare rate. And then they can't go after the patient for more of that.
Hopefully somebody's going to talk about that with the surprise billing in Georgia, because I believe we just passed something on it, but whether it's alternative dispute resolution or whatever. Representative Seba.
Yeah, I think we're going to hear more about that, so I won't get into it, but it's basically a floor of what insurance companies agree to pay, and it's 300. I think it was 300% of Medicare rate. So but I think they'll talk more about that.
And I know other states also are requiring providers to send a report of how much they are charging and how much their fees are, how much it is for them to operate. So to legislators, I know that's something that's been popping up in recent bills.
I think I'm going to wait and hear what our other presenters have to say, and then
We'll get a lot filled in with the next Georgia-specific individuals. Go ahead, Chairman Leverett.
Thank you, Mr. Chairman. Thank you. Also, I'll echo Devin's comments. Thank you for the presentation. It's a lot of information. I appreciate it. It's presented well. With respect to state governance, you kind of characterize three type of models: the advisory, the rulemaking, and the full authority. I guess advisory, where there is some kind of state EMS body, department, some kind of state devotion of resources to it, where they simply recommend regulations, but they don't promulgate them or enact them, and they don't take any other kind of action with respect to licensing or investigating complaints. And that's, I guess that's what you characterize ours as that, because we have advisory councils, but yet the state office of EMS is within the Department of Public Health, and I guess that's where the actual authority, they're the ones who actually issue the licenses and can make the rules as an agency.
Correct. In Georgia, you have 10 different regions, I believe, and they each have their own advisory councils. And so those regions make up that specific area. So they are then reporting back to the state office saying, this is things that we're worried about, this is where we need money, things of that nature. And then the state office then gets to dictate what they do with that information.
Can I ask a question? If they're advisory, but they control whether you get a license or not, are they still just advisory? If they can issue advice, and if you don't follow it, you don't get a license. Does that still fit into just the advisory category, or is that
I don't think the
rulemaking?
councils issue licensing. I think
Okay,
the
maybe I
state
missed that.
office
Okay,
does
sorry.
that, I believe.
Yeah.
The commissioner does that. Isn't that correct?
That's correct.
And is there one of these models that sort of predominates in your view from your research? I mean, it looks like the full authority tends to be the least common, where you've got a board, and the other two seems to predominate. And I don't know of those two which is more common, if you know.
Yeah, I don't have that information on the top of my head, but from what I've seen, it's usually the advisory councils that are then going back to an agency. It's not typical that you will have the power being given to like an EMS board.
So what we have is the one that predominates amongst the states, the Georgia model is.
Yes, and the one piece that I would add to that is it varies across health occupations. For EMS, it is largely concentrated in a state agency like Georgia, and then advisory boards inform that. For other health occupations like physicians, for example, it may be concentrated in a medical board authority that has the licensure, disciplinary, and other pieces allowed. There are some states that do all licensing within an agency structure, like Utah, but other states it depends on the occupation you're looking at, and EMS is largely within agencies.
Okay, thank you. And just one or two more questions, Mr. Chairman, I'm done.
Go ahead.
I probably could just ask my neighbor here this one, but the community paramedicine, is that basically providing some kind of treatment in what all my EMS buddies call the truck, or is it involve taking somebody somewhere other than a hospital, or what does that include exactly?
So community paramedicine is still relatively new in that term, and it does vary which state you're talking about. So some it is specific to maybe like a scheduled follow-up call, like after an overdose or after outpatient surgery. And so it just depends on what you're looking at, but it's typically pre-hospital care, and it's not tied to transportation. It could be tied to that alternative transportation, so to like a primary care physician or to like a behavioral health clinic. And what I've seen when that does happen is that usually EMS will then partner with maybe the primary care physician or with a different healthcare provider to make that call. They're not really, saying this person is best here. They'll kind of work as a team in tandem.
Okay.
And the other addition that I would make there is that every state defines community paramedicine differently, or they may not define it at all, or they may use the term mobile integrated health for a full umbrella or part of that. So those are components of community paramedicine that we've seen across states, but not necessarily how every state, if you see a statute that says community paramedicine, they may only be talking about treatment in place, treatment in the back of a truck, or they may also be talking about alternative destinations or telehealth visits or other components as well.
Follow up and things like that. And is that sort of get into scope of practice with respect to EMS and paramedics and all those professionals?
Yes, and again, that also depends on state and who has the authority to define scope of practice. So in states where medical directors in those agencies are defining scope of practice, or they give more authority to the executive agencies or boards to determine that, there's more flexibility in being able to say, yes, that's within the scope of practice. National organizations will say that that is within the training and education of community paramedics nationally and should be included in that. There are other states that provide separate certification completely for paramedics in order to be able to provide community paramedicine. So that depends on the state. If scope of practice is defined in statute instead of that flexibility for the agency, it obviously takes legislative action to add that additional service, whether that's treatment in place, alternative destinations, follow-up visits, and pre-hospital blood also operates in that same space.
Okay. And one final question. On the state initiatives, you had listed 3 items there for Georgia: installing telehealth, reduced wait time. Are those initiatives that well, we'll have some folks from the agency here, but are those agency initiatives? Are those initiatives of the industry? Are those, what's the source of those?
Is that on the Rural Health Transformation Program page?
Yes.
Yes, so those are initiatives that were outlined in Georgia's state application to CMS for the Rural Health Transformation Program. Okay. And so if those are identified in the application, those aren't necessarily things that can be changed at this point, given that CMS has approved budgets and narratives and all of that for the RHTP allocations. But those are some of the things regarding EMS that came up in Georgia's application.
So is the Rural Health Transformation Program, is that a federal program which states participate in?
Yes, that was created under HR 1. That's the $50 billion that was distributed across all 50 states. And each state submitted an application. There were certain scoring factors based on certain state legislation or state legislative actions that states had taken, and based on the priorities in their application and whether that aligned with MAHA priorities, Make America Healthy Again priorities, CMS priorities, and some of the explicit goals that were outlined and use of funds that were outlined in HR 1 for that fund.
So this was an application to a federal program to obtain federal funding to initiate, to
yes.
implement those.
And state legislatures across the country have varying involvement in those programs. Some state legislators are very, very involved from the very beginning of the application development. Some state legislatures are now in the appropriation phase trying to figure out what initiatives were included, where that falls in the process. So there's a wide variety on what that looks like from state to state.
Thank you, Mr. Chairman, I'm done.
I will also note on the Rural Health Transformation Program funds, they do need to be used or you have to pay them back to CMS. And I think the timeline right now is October of this year to pay for the first year application. So yeah, use it or lose it.
In the renewal years, just curious, are you required to stay with the same program for 4 or 5 years, or can it be adjusted after the first year?
To my knowledge, they can't be adjusted after the first year. It is what initiatives were outlined in the application. There are, basically in CMS's outline for RHTP, there are different stages of implementation that states outlined in their applications. So stage 1 would be developing a program, getting baseline data, whatever that may be. And then stage 5 is full rollout. What does sustainability look like after that 5-year program? For most states, that's what it looks like.
Representative Jones.
Thank you so much. In your presentation, you were talking about rate disparity between pay and actual readiness. And you also stated that private providers would like maybe more of a rate floor and a payer accommodation, where you have others that may want something like operating subsidy and such. Is this more of an insurance reimbursement thing that you're looking for that to have a change in? who do you want to be responsible for making some of these changes outside of petitioning the state for the things that we would have to do? But who else would be in this chain to make some of these things happen as it relates to paying for one or the other?
Mhm. I think it just begs the question of how ready do you want your EMS system to be? So you want to have somebody there when you call 911, you want somebody there to be there, but if they're only getting paid for the services that they're providing, they're not being paid for that cost of readiness. So where that funding comes from is up to the states. So they can create their own fees, their own funding mechanism to cover that cost, or maybe pass that on to the insurance, but it's something that has to be addressed.
Are there any communities in other states that are using the insurance pathway to do that?
I'm not familiar with any examples off the top of my head that insurance is paying the cost of the difference. I think it comes down to whether your state defines it as an essential service that the government must ensure is provided, and that's where some of the state responsibility for that funding comes in. I will say, when we point out those gaps, it's purely for informational purposes. We are not telling you, yes, please cover this gap in this particular way, or we're not advocating for or against any particular position on how to do that. Just noting that there is a gap between what is traditionally reimbursed, using Medicare as an example, and then what the traditional cost, or the actual cost of readiness and having someone 24/7 on site who can reasonably respond to your call in a time frame. So just want to clarify that we are not making recommendations, just providing you with some options. But I'm happy to follow up with additional information on states leveraging insurance, private insurance, to address some of that.
Chairman Taylor.
Thank
Did you have a question?
Yeah, I do. Just a quick question. Are you seeing any growth in the use of our EMS services to address, I know it's an issue I hear from our ER where we have the frequent flyers, people that show up in the ER, and if they may be homebound, they may be elderly, they may have some kind of mental illness, where they're utilizing those services to address that issue?
Yeah, I think states are leveraging their EMS system via telehealth or maybe that community paramedicine piece. So to prevent people from occupying the hospital beds, if you catch them beforehand, if you provide them with preventative care beforehand, then you won't need to have them using 911.
I know we've seen our health department doing that with expectant mothers, and it's been very successful. I just wonder if this is something we can model and use to help our ERs. Thank you.
I will add that community paramedicine, one of the primary outcomes that we see when states or regions have implemented this is lower ED utilization rates. So making sure that it's not overcrowded, or those high utilizers, having mobile outreach programs that are either staffed by EMS or staffed by community responders, social workers, whatever it may be, to meet the needs of folks in the community so that they're not constantly using ambulance services to get to an ED and then overutilizing ED services. And the other piece on expected mothers, we've also seen home visiting programs, which are largely funded through HRSA and Title IX and some other programs like that. But EMS definitely does play a role in that space as well. And we're seeing some states, there's one that I'm blanking off the top of my head, but one of them has written in obstetrics training for EMS clinicians under their Rural Health Transformation Program application, specifically with the goal of that in-home outreach for expecting mothers.
I think it would be better care for patients, but also more cost-effective. So I'm glad some are trying that. Thank you.
Representative Seabaugh, last question.
Yeah, just for your information and the good of the group, in 2024, Georgia passed some PTSD legislation. It's not a workers' comp benefit, but it's more of a supplemental benefit for all of our first responders. We noticed the statistics in suicide among all first responders was significantly increasing, especially after COVID. So we do have a supplemental benefit in place to help first responders suffering with PTSD. So it's not a workers' comp product, but it's a supplemental benefit, and I think it's going to pay big dividends for Georgia.
Well, thank you for your presentation to regarding the region as well as the national trends and your non-advocacy manner. Thank you for reporting those to us. We are going to get now Thank you. Appreciate y'all being here. We are going to hear from our Department of Public Health and kind of bring it back closer, a little closer to home. Megan Andrews, if you can just come on up and give us kind of an overview for where EMS and public health live today. And thank you for being here.
Hey everyone, thank you for having me. For those of you that don't know me, my name is Megan Andrews. I'm the Assistant Commissioner for Policy at the Georgia Department of Public Health. And I'm going to give you all a very high level overview of the EMS system in Georgia. I also have our director of our office here, Michael Johnson, who will come up and help me answer questions if there's anything I can't answer. So first, this is the statutory reference that established the EMS system in Georgia, as well as a citation to our rules and regulations, and then our office's mission, which is to reduce death and disability, providing regulation, guidance, and leadership over the EMS system in Georgia. I was asked to give a brief overview of the history of EMS as far as governance and where it's been located. So in the early 1970s, federal law passed that provided grants to states to establish regional EMS systems across the country. At the time, that's when EMS transitioned from just a transport service to providing medical care pre-hospital. In the late 1970s, that's when the Georgia statutes were established, creating the EMS system in Georgia. And when it was initially created, it was housed within the Department of Human Resources under the Division of Physical Health. This was the super health agency at the time that covered all health issues. In 2009, under House Bill 228, the Department of Human Resources was dissolved and broke out some of those health agencies. At the time, the Division of Public Health moved under the Department of Community Health. In 2011, under House Bill 214, DPH became a standalone agency and broke out from under DCH, and EMS followed the Department of Public Health or Division of Public Health through all of those transitions. This is the org chart for our office and goes through our staffing. So Michael Johnson's our director. He's over here and will be helping me answer questions. But you can see, as she mentioned, the regional EMS advisory councils, they have staff assigned to them down at the end of the org chart. We also have data staff that do intensive data analysis. We have a lot of data within this program, and you should have pretty thick reports in your packet that was produced by our office with some of this data. We also have licensing staff that oversee licensing of EMS personnel, and then also our systems of care that certify hospitals for the various levels of care.
Is the licensing for the ambulance service or for the paramedics and EMTs?
Both.
Both?
Both, yes.
Okay.
I have a slide that will go over our duties and responsibilities that'll break that out for you. So as far as budget, this is our budget and fund sources broken out. I do want to note that in the state funds portion, there was $1.25 million in funds that were disregarded by the governor that are still technically sitting on our books, but are unable to be spent down. So it is actually lower than what you're seeing here. And then this is our expenditures within the office. You can see our personnel costs are at the top, as well as regular operating expenses, our IT costs, which is computers, phones, things of that nature, and then our contractual services, which includes GEMSYS, that's our patient care IT system to gather data on patient care provided in the field, pre-hospital, our licensing software, our education and training software, our patient registry, which is outcome data from hospitals related to their levels of care, as well as our biospatial software are all in that contractual services line. This is the slide I was talking about, Chairman Newton, with the breakdown of everything that our office does. So we issue EMS agency licenses, so these go to the companies that provide EMS services, and you can see them listed there. We also have begun licensing and inspecting emergency organ transport vehicles. That was a new duty assigned to our team a couple years ago under a Senate bill. We also inspect the EMS vehicles. We provide EMS provider licenses. So these go to the individual personnel, the paramedics, the EMTs. And so we also oversee their disciplinary action. If there's an issue, they get hearings and things of that nature. And then we also oversee zoning, which I think is a little bit unique and different than other licensing boards. So I'll go over zoning a little bit more, but essentially the state is divided into response zones, and DPH is responsible for ensuring that there is an ambulance responding to 911 calls within each of those response zones. It's essentially a competitive procurement process. You can think like DOAS when vendors bid on contracts. It's the same thing. EMS agencies will bid to provide the service within the zone. That is reviewed by the regional EMS advisory councils, and recommendations are made to the commissioner, who is then the stopgap if there were any issues in that quote-unquote procurement process. And ultimately, she makes a final decision about who is awarded a zone. So I think that's important to keep in mind, that that is an important function of our agency. In addition, we oversee the hospital specialty designation process, which is on that far column there. So the trauma designations, burn center, stroke center, cardiac center, and pediatric readiness center, all of those designations are overseen by the Office of EMS. We ensure the hospitals are in compliance with all of the requirements to call themselves a level 1 trauma center. So we do their initial certification and then ensure at renewals they're still in compliance with those requirements. So as I mentioned, DPH is responsible for ensuring we have a 911 provider in every zone in the state. There's 159 counties, but 175 emergency response zones. Most counties have one zone, but there are 10 counties that have more than one zone. Multiple zones in a single county can be due to population, geography, or this term, in the best interest of the public welfare. That's a statutory term and really the bedrock of what the decisions are made on. There are 2 counties that share one zone, and they have 2 designated zone providers. So both the provider and then the zone itself, that geographic area, is determined through the zoning process. So when a zone is opened and this competitive procurement is going on and folks bid on covering the zone, there may be a need identified to split the zone or combine a zone that has been split. That's all decided locally at that regional level. So the EMS Advisory Council, this is a state level advisory council. I know NCSL mentioned the regional ones, but we also have a state level one. It's established through our rules and regulations. They provide recommendations to our office on matters related to the EMS system. They serve as a forum for EMS stakeholders to collaborate and come up with recommendations on what's going to best serve this citizens of Georgia. At the bottom here is a list of who is on the MSAC. It includes industry representatives, geographic distribution to ensure we cover metro and rural areas, and they make those recommendations to the commissioner. They also review our rules and regulations, although they're not the ones promulgating them. They do help inform our decisions. The next one is the Medical Directors Advisory Council. They're also established in our regulations, and they advise DPH specifically on the medical direction issues of EMS. So this is the patient care, scope of practice policies, things like that. And then, so that committee is comprised of physicians with expertise in EMS medical direction and pre-hospital care. Next is the Regional EMS Advisory Councils. This is the group that NCSL mentioned. We have 10 regions in the state. They're indicated over here on this map. They evaluate and recommend changes to the zoning plan for that region. which is dictates how emergency calls are distributed, and they serve as the local coordinating entity for DPH with duties to recommend who should cover zones. So when you're looking at the statute, when you see local coordinating entity, that is who has been designated as that, are these councils. They are also established in regulations, and they establish a forum for local concerns to be heard related to EMS. They review key performance measure data. Like I said, our patient care system collects a lot of data and information, which is then in turn provided to these regional councils to measure performance with each zone provider. They make the recommendations to the commissioner for the 911 zone provider, and they are beginning to conduct quarterly review of those key performance measures to monitor for challenges and identify if there's room for improvement. So who sits on these REMSACs is what we call them. Here's a list of the members from our regulations. It includes medical, as well as county board of commissioner appointees, folks in EMS education. You can see it includes a broad array of individuals that serve to advise at the local level. So I talked a little bit about the zoning process. When a zone opens, DPH puts out notice to all licensed ground ambulance services with the dates for the zoning process. We also put out statistical information about things like call volume, the payer mix, how many of these folks are typically uninsured, and then we begin accepting zone proposal applications.
What might result in a RIMSAC vote to open a zone? Is it just somebody's leaving, or is there every 5 years, or is there the county's upset? What?
Yes, it can open for a variety of reasons. Typically, it's the existing zone provider is leaving the zone, but there also have been scenarios where the zone provider is not meeting the expectations and providing the level of service that's needed, and has been put on like a remediation plan. They typically have 6 months or so to improve, and then the zone can open in that situation too.
So it's the regional EMS advisory council that could vote to do that or not vote to do that for a decade or more?
Yeah, there's not a timeline of like a regular reprocurement.
Thank you.
Yes. So then zone proposals are submitted to the REMSAC for consideration. They review them, vote, and score on them. And one of the important things, since we were talking about reimbursement, that is included in here is if there's a need for a county subsidy. In some of the counties that have a payer mix with a lot of uninsured patients and a higher volume, the EMS agency may require a subsidy from the county in order to provide the service. If that's the case, that's hammered out through this zoning process, isn't included in the proposals that are submitted. So the REMSAC reviews the recommendations and then sends that recommendation to the commissioner. The DPH commissioner makes the final decision on who is awarded the zone after reviewing the decision of the regional council. Let's see, I think I covered all of this actually. Yep. And that is everything I was planning to cover, but I'm sure there's a lot of questions. I'm happy to answer them.
I don't see any questions right now. We might want to keep our presentations going. If you'll be around, we might have some.
I'll be here,
sorry.
but it looks like Chairman
Representative Seabaugh.
Thank you, Megan, for the presentation. I was looking on the org chart. How many law enforcement investigators do y'all have for doing investigations?
We do not have investigators. Our staff have to do the investigations for license issues.
And who does that? The regional coordinators?
The regional directors.
Okay. Do they have any kind of training for that?
Michael can come up here.
Just come on up.
Come on. Join the party. Yeah.
Just repeat the question if you don't mind.
So if it's related, thank you for having me, related to an EMS provider or an agency, our regional directors will do the investigations. If it has to do with anything educational, our regional training coordinators will do that. So we have one in each region. As far as training, we have had CLEAR training, which is the Council on Licensure Enforcement. We're in there with barbers and tattoo artists. When they go do inspections or something like that, we're getting trained just like they are. So there's no law enforcement type training.
Okay. Would that be beneficial to the department?
It would be very beneficial, yes.
Okay, thank you.
I was asking a question. Do air ambulances, do they fall at all under this, or licensing of the paramedics? How about the equipment, or is that all FAA or?
Yeah, they're on that list back there of all of the EMS agency types we license. They are listed as one of the agency types we license, and we license all of the providers, right, that serve on there.
Not the nurses or physicians,
but the EMTs.
Not the nurses or the physicians, right? Okay, that fly on those. Yes, Chairman Hawkins.
Yeah, I'm hearing that some of our rural counties and smaller counties, surrounding counties, have an issue where they contract with an ambulance service, for the EMTs, runs to the hospital and all that type of thing. But then when you have transfers from like nursing homes or patients from their physician's office back to their extended care living, those companies are not really contracted to do that. So if they do it out of the goodness of their heart. They're not getting paid for it. Is there some way that we can fix that situation? Because that seems to be coming up more and more. You have any ideas about that?
If the patient is insured, they can certainly bill for the transport. But I think you're talking about cases where there's an uninsured patient.
Right.
The same thing applies to 911 calls. If a EMS agency, the 911 responding agency, transports an uninsured patient, it's the same situation. They don't get to apply to us to get some sort of reimbursement for providing indigent care. They have to essentially eat the cost.
So if I'm hearing that the ambulance's contract service is contracted with that county, if I hear that they're not transporting those patients, like non-emergent, they're breaking their contract, or that's not in their contract? I'm hearing it's not in their contract.
Yeah, that's ultimately between the county as the contracting entity and that EMS agency. If that's a service that they want to be provided, then it needs to be negotiated between those entities at the local level. That's not something, our responsibility and duty is to the 911 response for those emergency calls and ensuring coverage for that. But like I said, the subsidies, it's technically a contract between the EMS agency and the county government, typically, sometimes the city.
Right. So that would be up to the local entity to have that in the contract and provide payment for that service.
Yes, absolutely.
Makes sense.
Representative Seabaugh.
Sorry, I got one more. Under the hospital specialty designations, public health you don't regulate hospitals, correct?
No, we do not.
Who does? DCH?
The Department of Community Health.
So would it make sense for them to designate the specialty designations to the hospitals that they regulate? How did that get up under public health is what I'm
I
asking.
don't have the history there. Do you know the?
I don't have the.
Okay.
I don't know how that came about either.
Okay. I can do some more research and ask some of our experts on how that ended up under public health. I don't think there's been any issues or challenges we have within that program. We have a good relationship with the hospitals as well as the ones that we designate. So we can certainly dig into that a little bit more if you'd like, though.
Okay, yeah, I was just wondering. And then also, when some of these ambulance services in some of the more rural counties, they may run 1 or 2 calls a week, but they have to provide an ambulance for 24 hours, 7 days a week. And 1 or 2 calls, some may be paid, some may not. It's not going to pay for that. Is there any state grant funding through rural health to help pay for those ambulances to operate? or does that all fall on local government?
Yeah, to fund their readiness costs. There's
Mhm.
not any source of funds within our office that funds that. I can't speak to other agencies. I'd have to ask around, but there's not any mechanism for us to reimburse that readiness cost.
Has there been any talk about readiness funding and maybe how we get there for some of these ambulance deserts we have in South Georgia?
Yeah, I mean, I think as NCSL pointed out, this is something that is being discussed in other states and is sometimes funded in other states. I think it's a worthwhile point to continue discussion on. Obviously, it would require funding, whether from the state or feds or however that may come.
That's why we're here. Thank you.
Yes, you're welcome.
Chairman Leverett.
Thank you, Mr. Chairman. Thank you for this presentation. It was very informative. I had just one or two kind of follow-ups to some topics Representative Seabaugh touched on. The hospital specialty designations, that is done by the department, but is it done through the EMS office?
Yes, it sits under our team. On our org chart, we had some dedicated staff that do the designation, but they also have the resources from the Office of EMS. So that's a responsibility that sits within that team.
And do those designations at time influence or determine where someone may need to be transported to by an EMS vehicle?
Yes, absolutely.
I wonder if that may be the source of how it ended up with the EMS office, because it's impactful to the service that
It's
EMS
entirely
provides.
possible that that was why they thought it should sit with us.
On those, and that's just speculation on my part. I wasn't around, so I don't know. While I was around, I just wasn't paying attention at the time. With respect to zoning decisions, which I guess tends to be the thing that probably develops the most controversy of the things that you do, it sounds like the regional advisory councils make recommendations directly to the department, and then the department implements or makes the zoning decision or awards the
Yes,
zoning.
directly to the commissioner.
Okay.
Yeah.
So the state advisory council isn't involved in the zoning process?
No.
Okay. And it sounds like the zones have developed through somewhat of an organic process. I'm sure initially there were some zones set up, but as you then get, well, I guess it's effectively a bid to provide service in that zone, a provider may say, well, I can only cover this portion of it.
Right.
And do they sometimes in their proposal propose the subsidy from the local government as well?
Yes, if they require a subsidy, they'll include that in their proposal, so the local government also knows what they're getting into. And there's sometimes EMS agencies that'll submit like a joint application. If there's a city that wants to carve itself out and there's a private EMS provider that wants to provide services to the rest of the county, they may team up on an application to cover the entire zone.
Okay.
Yeah.
I think that was it, Mr. Chairman. Thank you. Thank you so much.
Well, thank you for your valuable information. Kind of gives us a good a starting point on understanding what the current process is, how we got here to a degree, and I appreciate it. I look forward to having additional questions as we go along, if you don't mind.
Yeah, we will be here.
But thank you. Thank you for being here. Now we're going to go on to Chad Black next. And I know we're a little behind on time, but we do have a hard stop at 3 o'clock while this room transitions. But thank you for being here with the Georgia Emergency Medical Services Association. Your chairman. Thank you for being here, sir.
Thank you, Mr. Chairman and the committee. Before I start, I know we're here to discuss our issues and things we need, but what I want to start with is we got a lot of EMS personnel here in the room today, and thank some of the speakers and everybody for being here, but I think we don't focus on the great work that EMS does in our communities every day. We omit and we jump on the problems, but they do great work in all 159 counties every day. And right quick before I start, Anissa, you did a great job. She teed it up, so mine's going to go faster than it would because she covered a lot of that, and that's great. But a couple of your questions, you talked about zoning. One of the things they look at in zoning, or the things they look at, is three things. If somebody decides to give the zone up, but if not, if there's a problem, it's efficiency, economy, and best interest of public welfare. Those are three things. If one of those are not being met, Michael, correct me if I'm wrong, then the council can look at opening up the zone and investigate that. So hopefully that answers your questions, the things they look for, economy, efficiency, and best interest of public welfare. Chairman Hawkins, you asked about the transports. You were talking more, I believe, about the Medicaid issue, and the state has one company that handles all the Medicaid. And there are problems. I was talking, Anna, where are you sitting there? We were talking with the GHA earlier. She's getting a lot of calls. What is happening there is you've got one vendor that gets the money from the state. They give them, Josh, correct me if I'm wrong, do you know the number on that? Josh, what's the number on that? Is it $100 million they get for Medicaid a year or something? Whatever they don't use is where the profit is. So what happens is they'll contract with a provider, usually not the 911 zone provider. Well, because in these, pardon?
Usually not the
Usually
911?
not the zone.
Okay,
These are
so
for
it's
non-emergency
another,
transfers,
okay.
things
Go
like
ahead.
that, discharges.
Non-emergent transports, yes.
So
non-911.
what happens in these rural areas, and I'll use one example, is in South Georgia. They're a hospital-based 911 service. They have a provider that's a private that is the vendor through that broker. But at 8 o'clock at night, they shut the doors because there's not a lot of volume. Well, a transfer comes in that's coming to Augusta or Savannah. That hospital needs that bed open, and they'll tell their 911 zone provider, because they're hospital-based, you've got to do this call. But as Chairman Hawkins said, because they're not in contract with that vendor, because their rates are abysmal, you can't, how they do it, I don't know. They don't have to pay that truck for doing that call, nor do they pay their vendor because they didn't do it, so they get to keep that money. That's the way it works. They don't have to pay anything, but the patient still gets transported. That EMS provider is out and gets absolutely zero for that because they don't have a contract with them. It's hard to make sense, I know, but that is the way it works in Georgia.
Did I understand correctly that the state EMS commissions or whatever, they don't have any oversight over that right now? Is that correct?
You're talking about the State EMS Association?
No, the Department of Public Health. They're
No,
only
that's
doing
under
911,
DCH.
I believe.
Any control over the Medicaid and all, that falls under DCH. Yeah, but that's what you're talking about, Chairman. You had talked to me, and I know Chairman Parrish on the end had some issues with that, and in his county is where I'm talking about. They'll take that 911 truck because they want the hospital bed open, and they'll do the call, but they don't get paid for that. Correct, Mr. Chairman? Yeah, so we need a simple change to be, and Anna, do you want to say anything on that? I know. And mine's going to go quick. Like I said, Anissa, she teed it up, so
A simple change in healthcare? That could be amazing. Never heard of one of those.
Thank you. So what we're seeing with Medicaid patients who need non-emergency medical transport is they're making contact with the vendor, and the patient is sitting in a waiting list until an ambulance is available. And after a certain amount of time, they sort of fall off the list, and we have to restart the process. And so it would be ideal if we could have a maximum number of hours that the patient is waiting, and then outside of that, we go to an additional or a different ambulance service, maybe the local ambulance service, and they get a payment for that. So the vendor has to do it within a certain time period. Otherwise, someone else is going to get paid to do it.
Okay, we'll have to discuss whether that requires a state law or is that something you could do in a contract like we've talked about earlier in the day in other healthcare situations.
I know Chairman Parrish got an email and was shared with Chairman Hawkins. I believe we could do a simple rule change, is my understanding. Is that correct, Chairman? Possibly just do a wording rule change that if that vendor is not able to provide that, whether they're on a call or they've shut down at 8 o'clock, 7, whatever, whoever takes that call, whether it's the 911 zone provider or another, gets a payment of, maybe it's 325% of Medicare allowable that we did for the out-of-network insurance. Okay. But they get something versus nothing.
Certainly glad to look at all options as we come down the road, but thank you. Appreciate it. I didn't know.
Thank you.
But thank you.
And again, Anissa teed it up great, but you know, we have the hospitals in our communities do a great job. There's not a hospital in every community, and we've got what we call safety net hospitals, and they're very much needed to provide for those communities and services. But I truly think EMS is the true safety net. It's in every community. It's how a lot of the patients get to the hospital, and we actually take the equipment out to the patient and do a lot that the hospitals do at the scene. We go, all of us has been to the doctor now, you go and they'll give you a sheet that says, here's what your insurance is going to pay for this, and here's your responsibility, we'll take your credit card now. EMS, we don't do it while at biopsy. We're the only healthcare that we respond and transport without knowing if we're going to get paid or not. And it's difficult. We don't know what we're going to get paid. Thank you for what you did for the out-of-network insurance this past year. That's a huge, huge leap forward that's going to help us tremendously come the first of the year, and that will do away with the out-of-network that Anissa was talking about. There will be no balance billing. Whatever insurance pays, that 325% of Medicare allowable is what we will take. So that's going to help not only us as the services, but your constituents and the people that depend on that. But, you know, a lot of times we're the only healthcare provider out there going on the scene and treating these patients. And everybody looks at EMS as transportation. We're not just transportation. We bring the care directly to you. But as Anissa pointed out, we're not even paid for what it costs for the preparedness and readiness, and we're not paid when we do the transport. You saw the numbers. How many businesses would stay in business if it cost them $2,600 to operate, but they're only getting $1,400 in return? And then that's made up going back to the taxpayers with an additional tax increases to fund that service for their area. This is just an estimated, and she talked about this, to keep an ambulance. Now it's a little bit lower, higher, depending on where you are and what kind of trucks you buy. But the low estimate's about $1.3 million per truck, 3 paramedics and 3 EMTs to operate 24/7. High about right at 1.44 million. That's the readiness cost, whether it runs a call or not. And you see all the numbers broke out. And again, this is averages. That's really nationwide. But all of this is done before we collect any revenue, and we only collect revenue through transport. So, and again, Anissa laid that out great. This is kind of the workforce. She talked about it. We'll jump through it, and of course, we'll take questions. But your average, and this is national, your average EMT years planning range is about 3 to 5 for a paramedic, 5 to 7, and you see the percentages of that. But some EMS services, and if you get a small one about every 3 years, is having a complete turnover. That means they've got complete new staff. That takes away, you know, tenure, that takes away experience. There's a lot of things that come with that. And again, you know, I've got up here, it's not simply losing employees. We're losing that experience, that institutional knowledge, our future leaders in this. We've got to find a way to retain them and keep the pipeline open to get more trained and put them into the service. We kind of look at the areas we solve as urban, suburban, and rural communities where some of these challenges are different in these. You, of course, got a lot higher call volumes in the urban systems, but still we have the same workforce challenges. And a lot of people say, you know, we hear from hospitals and we don't have enough ambulances. We have enough ambulances. We don't have enough people to put on them to run the calls. That is our problem in many of these areas. And I'm not going to go through this. You've had this presentation, but again, these are issues we face. Some are the same, but at the end of the day, we're all facing the same challenges. Anissa talked about the Rural Health Transformation Funds. We have, through the Georgia Ambulance Providers Association and GEMSA, we applied, and she talked about the EMT and paramedic training. We'll receive over the next 5 years $37 million, and it'll be a earn while you learn. Our goal is 1,350 new EMTs and paramedics, with 1,000 of those being EMTs and AMTs. 350 paramedics with a 75% pass rate that hopefully we'll be able to put out over the next 5 years, 1,000 plus new EMTs and medics in the field. Now, this, again, earn while you learn. It will pay, Terrence, correct me if I'm wrong, for the EMT, AMT, $19,000 of their salary, paramedic, $28,000. So it'll help these rural services to cover the cost of not only their school and education, but their salary while they're in school. Once they get out, they will have to work in one of the 123 rural counties the federal government has established for 5 years. So, you know, we're still working through how we're going to monitor that, how we're going to, if somebody leaves one service, they've got to go to another one. What our hopes are is we can find some sustained funding that once this is over, to continue this program after the 5 years of the Rural Health Transformation Funds, to continue that pipeline for these ambulance services so we can put EMTs and paramedics in to offset the cost. So she talked about that. That's what we're doing here. We're also doing the telemedicine for the rural areas as well. And that works in with community paramedicine type things too. you know, we talk about recruitment, but if we don't retain people, the recruitment's not going to do any good. It's the same workforce problem that everyone has. And I will point out, while we talk about COVID and it exacerbated all of from the doctors to the nurses and everyone else, 20 years ago, next year, Jeff Mullis, the prior senator, did a workforce study on EMS. And 20 years ago predicted we're going to have a workforce shortage. And here we are 20 years later still talking about the same problem. So this has been way before COVID. This has been going on now as of next year, 20 years that we've been addressing this. COVID just exacerbated it and made it worse as it did a lot. So and we're very close partners with the hospitals, but even before COVID, when the nursing shortage started happening, hospitals, and I don't blame them, they got smart. They said, we can hire the good paramedics. We can put them in our hospitals in the cath labs, stroke labs, working in trauma. Well, if you're 24/48 on a schedule, you're working 2,880 hours a year. If you just go to 40 hours, or some of these 36, you're working 800 plus hours less, making more money, and you're off weekends a lot, and you're home with your family. Who would not work 800 hours less a year to make more money? And we can't compete with that. It's taken away from the EMS workforce. But I don't blame the hospitals. They can supplement some of their nursing shortages by doing that. So that's another challenge that we face. Again, we talked about readiness. Again, she did a great job. This just kind of breaks down the areas. And again, it was brought up, I think, Representative Seabaugh, you know, it doesn't matter if that ambulance is running 1 or 2 calls or 10, the readiness cost is still the same. It's still cost to have that truck sitting there, whether it's running a cost or not. And we've got to have sustained funding for our 911 providers for that readiness cost. This chart just kind of shows you, somebody was asking, I believe you were talking about the pay mix. This is our main payers: Medicare, Medicaid, commercial insurance, and private pay. The blue kind of shows what it costs to run those calls. And you may say, why is it more to run a Medicare than a Medicaid patient? It shouldn't be, but it's not costing more to run that call per se, but Medicare are more elderly, they require more care, more things done, so it costs the service more to provide that. Medicaid, of course, can be elderly, but it also can be young, and you're transporting, not doing as much, so the cost of to take care of that patient. You see self-pay a little bit higher. The issue is that, which will go away at the end of this year with balance billing. When you got self-pay, there's a lot of bills go out that cost administrative cost, you know, postage, things like that. And then you turn it over to collections, which is another cost. Now, with the balance billing that you did, that will go away. The collections starting January 1, so that's a good thing. But that's why those costs are a little bit higher. But you see the red, what it costs and what we're getting. It doesn't add up. So again, that's put back on the taxpayers for a subsidy, as Aaron and some of the others talked about, or Megan and some of the others talked about, sorry. This is just, Terrence is going to, after me, talk about the reimbursement. This is, again, thank you. It helped greatly on the out-of-network insurance. It will when it starts, but it's still, even with those wins, it does not cover the cost of readiness, and it doesn't cover the cost of running the call. We're still lagging behind. We've got to make great strides to catch them and at least just break even. I'm sure you've heard about the wall times, and this comes from the hospital capacity. Again, the Medicaid issue, if they can't get a patient out, there's not an open bed. If that patient's in the ER, needs to be admitted, and there's no bed, then that's taking up the ER bed. Ambulances are waiting, and if they're on the wall, the 911 calls doesn't stop because that ambulance is not available. So that is something through the patient offload time study or task force that still, I think Anna's on and some others in this room maybe, they've done great work on that. And it shows where the problems are in the state with hospitals and you know, their capacity, people's coming in. I think it was brought up, you know, people going to the ER that shouldn't. That's hard to control, but it affects, it's a domino effect on EMS. And when our trucks are sitting there waiting to offload that patient, they can't run another call. And that's a big problem with keeping people. A lot of our personnel are not wanting to work and wait. You know, where I worked for, they told me we had a hospital last week, a truck had to sit at a hospital 8 hours before they could offload a patient. 8 hours. It's not uncommon. One of the things I threw in here, I wanted to really show the study. We started in Georgia giving pre-hospital blood. I've been doing this 44 years. I've not seen anything that has made a difference in patient outcomes than giving blood pre-hospital to trauma patients. It's the most life-saving change I've seen in my career and making a difference. We've been doing it 4 years now, roughly. I think 4 or 5 years. And I'm just using Grady, for example, and I will tell you, Grady has done a phenomenal job as all the services, but to give whole blood, which is what Grady's doing, is about an average, not counting what it costs to get set up to do it, but just to give it is about $1,000. Now, we can bill ALS2, which is the highest charge, but that's still, we're losing money when we give blood. We're saving lives, but we're losing even more money. One thing I'll point out, and this unless Grady's changed in the last month, when Grady started their program, they did a 3-year study. So blunt and penetrating trauma. If a patient had a systolic blood pressure of 70 or less, and systolic's that top number of the blood pressure, the patient had a 25% survival rate. Since Grady's been given blood pre-hospital, you see what their survival rate is at 80%. I laugh, and I was telling some earlier, Atlanta police chief and the mayor's been on TV twice in the last year and a half saying how murders are down in the city of Atlanta. But yet Grady's assaults, penetrating trauma, gunshot, and those calls are up, aggravated assault. I just looked online, Atlanta PD, or Atlanta showing a 46% increase in aggravated assaults this year. So if aggravated assaults are up, but the homicides are down, what do you think's causing that? They need to say thank you to Grady because they're saving more lives. That's exactly what's causing it. Is Grady EMS is giving that blood and saving more patients. We would love to see sustained funding statewide to help services in 911 start the blood programs. And then if they give the blood, not looking to make money, but if it costs them $1,000 and they're only able to, that ALS2 charge, they're getting $500 for that. We'd love to see something to where we can even make up that difference so it's not on the taxpayer dollars subsidy that they've got to pay more. At least break even so they can do this because it is life. And it's not just trauma. They can give it for GI bleeds and medical stuff. In Region 2, where we started the pilot, we had 2 or 3 postpartum bleeds that those ladies would have died if they had not gotten the blood. So it's not just trauma. It can go for a lot of other things. But I just wanted to throw that in there to show you this is things that are going on in the state that's just tremendous. And then just kind of the agenda for sustaining EMS is things we, Megan talked about, Anissa talked about, supporting the rural health transformation funds after those run out. If we can find sustained funding to put these people through school and help pay some of the salaries in the rural areas especially, it would be a tremendous benefit. We need a permanent statewide EMS workforce and readiness funding mechanism. I think Representative Seaball talked about that and the cost. We've got to still improve Medicaid and commercial insurance reimbursement. Again, a huge step with what you did for us this past year that starts. And then we've still got a few insurance companies, one that's paying the patient versus paying EMS. And when they pay the patient, do you think they're turning around and paying that to the EMS? It's not happening in a lot of cases. Again, funding readiness and preparedness, not just the transportation. Again, the pre-hospital blood, everything we've talked about, compensation, we've just got to find a way for these 911 zone providers to be able to sustain and not lose money and put this on the back of the taxpayers. And then again, continue to work in with the issue with the wall times in the hospitals. And with that, I'll wrap it up for any questions.
Thank you. I don't see any questions right now, Chad. Thank you. Thank you for that.
One thing I wanted to add, I'd sent some slides, I didn't add it in, but our specialties of care that the Office of EMS and Trauma oversees, and that's stroke, burn, cardiac, pediatric, that's got to have sustained funding too. I think it's 187 specialty centers in Georgia, Michael, am I right, that they oversee for their designation and the things they do, and we've got to have sustained funding for that. And I'm not going to get granular on it, but just keeping in mind those, we need full-time epidemiologist on the EMS side and for hospital working for us doing things. The databases, the data's there. We just need the money in the state office to expand that and really identify pockets of where better care is needed and things like that. But our specialties of care has to be addressed in this as a component of EMS.
Thank you very much. Thank you to you and the paramedics you represent as well, and EMTs. Thank you, sir. Terrence Ramatar. You can come introduce yourself and your organization, Georgia Ambulance Providers Association. Thank you for being with us today.
Thank you, Chairman. Thank you, Committee, for having me. My name's Terrence Ramatar. I'm the current president of the Georgia Ambulance Providers Association. We work hand in hand with Chad's group and GEMSA. Our focus has been on ambulance transportation, reimbursement, financial sustainability for a number of years. And my other roles include I'm a board member of the American Ambulance Association, so I do some federal advocacy and policy work in this space. And then for my company, Global Medical Response, I'm the state government affairs director in 13 states, covering including Georgia, but all the way to Louisiana, up to DC, and down to Florida. So, but Georgia has a special place in my heart. So I did not want to cremate the dead horse, but I'm going to go through some of these slides that I think are relevant. I think there were some important themes that were presented by ladies from NCSL, which I'm grateful for. Thank you, because they sped up all of our presentations for you. So this one, all right. I'm going to take just 30 seconds to really emphasize what an advanced life support ambulance does. So over the past 40-something years, we've really advanced in the, Chairman, you mentioned these are mobile ICUs, and that's really what they've become. The best description I heard from an ER physician about what we do in the field is that an ALS ambulance can take care of any medical emergency just as much as the ER can do in the first 20 minutes of emergency. That includes intubation, some really advanced procedures, medications, a full ACLS, advanced cardiac life support, drug box. Very well equipped. We've advanced in cardiac arrest management. We've advanced in what we call STEMIs, which are these heart attacks that are recognized through 12-lead EKGs. We're able to communicate with ERs. We're able to get cath labs ready. We can do intubations in the field. A lot of the ground ambulance providers are doing what we call rapid sequence intubation. That's pretty much where we chemically make you unconscious so we can get an airway in you. Stroke assessments have come a long way. That's why the designations are really important in trauma and stroke, to know where those are, so we know where the closest facilities are that have capabilities to manage that. Respiratory failure, and then we went all the way down to blood. So in that time frame, we've really advanced as an industry. And a lot of these have been sort of, they're unfunded mandates, more so because the community just demands that care. And so not because someone paid for it. And so you'll see where I'm coming from here in a second. I think what's really important to distinguish is the same policies affect all of EMS, but you have two separate EMS systems, right? That have their own unique issues. So in an urban environments like your Atlantas, your DeKalbs, we see ambulances are tied up, high call volume, right? Inability to keep up. So there might be more ambulances there, but they can't keep up with the call volume. The uninsured population is very large, so your bad debt on that line item is a killer. Wage pressures in these metropolitan areas from hospitals, fire systems, prisons, all these folks that are now demanding paramedics. There was a comment about how COVID exacerbated this, but a lot of folks found that paramedics can do stuff in a brick and mortar environment a whole lot easier, and replaced some of what they were doing traditionally with maybe nurses, and expanding some of their scope of practice within a healthcare system or a healthcare operation. So we've now have increased competition for those paramedics and EMTs. Mutual aid and backup capacities in these areas are stretched thin. We're all busy, whether you're in, from South Fulton to North Fulton to DeKalb, and in these areas, it's just a continuous flow of calls. Rural areas, same policy, much different problems, right? So fewer ambulances to respond to. We talked about low volume in a lot of these areas that are driving some of the problems. So you don't have the ability to have these additional ambulances in rural areas. But some of my fire chiefs here will tell you that I don't know if it's the kind of the blue moon theory. When that first call comes, a second one's coming right after it. They don't come evenly, and so what happens is your second call doesn't have an ambulance with a acceptable response time. And so those are problems that we're trying to solve for. Volunteer attrition, we talked about before. Hospital closures are adding distance, and when I talk about hospital closures, is also we're now in the past couple of years really monitoring ambulances at hospitals and really trying not to overload hospitals because the patients are coming and they just can't build faster, right?
And then, in those areas, in rural areas, limited tax base for local EMS subsidies. We talked about zoning and opening that up. And so in more recent years, because of the reimbursement issue and because of the tax subsidy challenges, it's been hard pressed to open something up to find something better because the revenue in that county or in that city is the same revenue every other ambulance operator is operating with. So fewer calls, less revenue, but the same fixed costs. I'm sorry. So over the years, particularly you see since 2020, there's our EMS call volume against the reimbursement rate. We're going to talk about a little bit deeper into reimbursement here. On the Medicare side, we referenced the CMS cost collection study that was done, and that data was published last spring, so we were able to grab a hold of that. But it shows that even just on single Medicare responses, we're below 6% below zero on a margin, and low volume providers are even worse. And Medicaid's a whole separate discussion that we'll have here shortly. But you can see that how the call volume has significantly outpaced the ability to reimburse for those services. So here's the reimbursement problem. On this chart on the bottom, you'll see just our what we consider our four main payers. There's Medicare, Medicaid, commercial insurance, and self-pay. What the dark blue chart shows is the cost of those services. That is just the cost of getting to the scene. That is not the entire cost of the call. So just getting to the scene for a Medicare, and when we see overall, we'll see blended rates, but here it just breaks it down by payer. And then you'll see what that payer is paying on average, and this is a nationwide average. So on Medicare, you see that they're paying less than half. Medicaid, we talked about $750 is what the average is, and $290 is what the average is across the states. And we'll talk about commercial insurance, but one thing you've heard here is that payments based on transport, not the care delivered, right? So in some areas, 25 to 30% of the responses that they respond to do not end up in a transport. And there's rarely a payment mechanism to reimburse for the cost of that service. Medicare, I'll just give you a brief on Medicare. We did force at the federal level a CMS cost study to get into payment reform. And so CMS did a cost study starting in 2019. That data was now available last spring. MedPAC, which is a physician group for CMS that looks at rates, did evaluate this twice. They want some more cost studies and/or encourage us to drop legislation to update the fee schedule, and that's a work in progress as we speak. Medicaid rates traditionally in all these states are worse than Medicare. So if Medicare wasn't even covering the cost, Medicaid didn't do it any justice either. Treatment in place. I have to give Georgia credit. In the past couple of years, we've been working together as a group with Medicaid, and they've been doing some phenomenal stuff to really move the needle for us. Treatment in place here in Georgia by Medicaid, as of last year, now compensates EMS for any of those calls where they're not transported at $753.35. And why that number? So we worked really well with the commissioner and the current administration, and they said, bring us a cost study on how much it costs for you just to get to the scene. And so we hired a firm, did a cost study, and showed it costs $753 on average. And so they put forth policy to say, we will pay you that. We're still working to refine some of the policies and protocols and with which patients qualify for that rate and which doesn't. But that was a huge step in the right direction for Georgia, which I'm really proud of. And then, of course, the uninsured patients are rarely collectible. I sort of joke, there's a reason why they put the garbage can next to the mailbox when you get your bills, because I think that's where it goes for the uninsured. But we have a single-digit collection rate on self-pays that they're uninsured. Cost versus revenue, you can see that spread here, and you can see it in 2020. Here's an example, but you can see that our costs have really skyrocketed after 2020. Labor and benefits being the biggest one. I think these are just obvious things. For us in our industry, fuel was the unpleasant surprise over the past couple of years. So when fuel goes up from $2 to $4 and doubles in price, none of us get prepared for that, and it's very difficult. So there's nothing to compensate for that fuel, so we just eat it. Equipment and supplies went up like everybody else, and compliance administration. That's the one thing we always look at, whether it's Medicaid, Medicare. We talked about brokers and non-emergencies and prior authorization. I don't know if that came up early this morning, but trying to reduce the red tape because it's adding cost for things that may not be necessary. So under the old model, and this is where we're trying to head to, we're trying to modernize this system as an industry, right? The old model is you pay only if you get transported. We've become the first access to care for most Georgians in an emergency, right? And they define what the emergency is, we don't. As Chad said, when 911 call comes in, our state mandate is we must respond. We can't ask them what kind of insurance you have. We don't have the ability right now to really determine whether it's a true emergency or not. We do get calls from toothaches to heart attacks all day long. So it is a flat fee for transport. I talked about we don't get any payment for it. There's no incentive except for what Medicaid did in Georgia for on-scene care. So the system really just encourages, incentivizes folks to transport patients regardless of what their condition is to the most expensive place for the most unacute condition. So there's really no alignment in our system with patient outcomes, and this is where we're really trying to head for. So the modern model is trying to get payment for the care that delivered, not the transport. So we really want to look at that. The cost of a service, the cost of providing EMS service is not any different from the toothache to a cardiac arrest that we worked and called unseen. Okay, so you can dump the entire drug box and spend $3,000 on every medication, right? But the payment model is not different for the toothache either. Treatment and place authority, like I said, Medicaid's doing that. We would really like to see more payers come on board. I know there were a couple payers have done some pilots in the past. The payment hasn't really come close to incentivizing agencies to really work with patients on scene. Payment for alternative destinations. This is something we want to get to, where we can transport patients, and we may want to discuss this either in legislation or rulemaking, but getting some of the payers that we have control over to pay for alternative destinations. Those low acuity patients that can just go to an urgent care center or even a doctor's office where we did additional screening. Can we transport them there and take them out of the ER because we're clogging them up? Number of states are doing this. Behavioral health, getting behavioral health patients not to go to an ER, but maybe go to a mental health receiving facility directly and bypassing the ER. So we're really looking for a modernization effort here to really take the patients to the right place for the right care at the right time. Medicaid funding, Medicaid's been a big proponent for EMS in the state, and we'll continue to work with them. Non-emergency reimbursement, we'll talk about in a little bit. We talked about commercial reimbursement minimums. This is something Georgia fixed for us this past session. Thank you to all of you. But we now have legislation that protects EMS providers from low payments because they're out of network. So not every ambulance provider has the sophistication to go in network with health plans. And not every health plan can find the EMS provider. So we're now the 24th state in the nation to have legislation to protect the EMS provider from low payment, but also protect the patient from a balanced bill. We'll talk a little bit about that because it doesn't fix everything.
Does that require the insurer to pay that rate?
Yes.
Does that apply to ERISA plans and other federally?
It does not apply to ERISA plans.
Just state regulated plans.
State-regulated
Same
plans.
problem we always
Right.
have.
And the other exception is a state employee health plan. Because
they're not included either.
So that's not included in this legislation. I think there was a lot more discussion on the fiscal note to that and whether it was worth it, but we moved forward anyway. So effective January 1 of 2027, for an out-of-network patient in a non-ERISA plan will not get a balanced bill. They'll have to pay one of three rates. They either pay the lesser of the local contracted rate. If the local jurisdiction does not have a rate set, then there's a Medicare multiplier. In this state, it's 325% of the Medicare rate, which brings us very much closer to cost, or the bill charges, whichever is less. So there's three options. So we're really happy that that passed. It's still making its way through other states as well. I talked a little bit about the federal front. As far as Medicaid's concerned, we actually, there's a number of groups here, hospital groups, some of the private groups are utilizing the provider tax programs from the federal government to pay the tax to collect down the difference between the state Medicaid rate and the average commercial rate, and that's happening here in Georgia. The only issue here is that now we may be included in a broad brush approach by the federal government to reduce those payments back down. And so for us, they're saying we're going to reduce it down to the Medicare rate. And so what we're saying is, hold on, you haven't updated the Medicare rate in 26 years. So can we please do that first? And so that's the argument or debate that we're having on the Hill right now is, can we please get CMS to update the Medicare rates because they're woefully low, haven't been updated since they've been created. I know in Georgia here, a lot of the governmental providers are exploring intergovernmental transfers. Same theory, don't have to pay the tax, but it's that federal program as well. We're in favor of this. I understand that, what's going on the national level, but it does bring the cost, it does bring it closer to the cost. If they can only fix the Medicare rate, so Medicare for us in our industry is at least getting to our costs, and that's what we're working towards now. I talked about treatment in place. I want to talk about one thing. So we've done a lot of discussion in the emergency space about what we get paid for emergency, and there's been a little bit of discussion on the non-emergency side, but we're also now starting to see why things are backing up. So if you look at, we have adjusted, we have figured out ways to get supplemental funding back to the Medicaid rate. We've worked with Medicaid on the treat no transport. What we want to do now is continue to work on the non-emergency discharge, or like the hospital discharge programs. So if you look on this chart, what we get paid for basic life support for a hospital discharge if they're a Medicaid patient is $159. That's probably part of the reason why we can't get good throughput through the hospitals and the ambulances are backing up, is because it's almost, even when we're going through the broker systems and maybe there's a low volume area and you don't have a provider in that area after 8 o'clock, I think is what Chad said. Even if you did, the rate's still almost a disincentive to go get that patient. And so whether it's working with the broker for the local ambulance service to take them, even if they work with the broker to do that, the Medicaid rate's still $159. Essentially, I like to say that the providers end up subsidizing the Medicaid system to get the Medicaid beneficiary where they need to be. So that's something we want to continue to work on and make that available. I think that's going to provide big relief for the wall time issue that we continue to see, is because we just need to be able to get them out and be able to get our patients, emergency patients in, but through the back door. Talked about balanced billing legislation. Thank you very much. This past session, we really appreciate that. But again, to your point, it doesn't cover everything, right? So in some communities, this may be up to 50% of their commercial. In some areas, I'm hearing 17 to 20%. It's a big help, but it doesn't cover everything. So we are still working at the federal level on ERISA and definitions on whether that really is true, if those rates should or shouldn't affect ERISA plans. So that was really big for Georgia, and we appreciate that. A couple innovative things that are happening in the industry I wanted to share with you.
If you don't mind, see if we can speed up a little bit through these. Okay, thanks. Good.
Yep, last slide. So a couple things that we're doing. So we're actually there's a number of states that are intercepting 911 calls at the answering point. And so what we're doing now is expanding 911 in different areas. So DeKalb County, Georgia is actually doing this now. If you call 911 with a low acuity call and doesn't sound like you need an ambulance, it gets coded as a low acuity call, you get transferred to a nurse who will then spend additional time with that patient to figure out what's the problem, how long has it been going on, where's the appropriate place to take them, who's their insurance, maybe we can find a better alternative. Right now, this has taken about 15% of the call volume out. In addition to this, we talked a lot about treatment in place. It started as community paramedicine, where we were trying to reduce patients from repeat visits to ERs, but now it's turning into, can we just treat them on scene? And but now, how do we get paid for that? Behavioral health transports continue to be an opportunity for improvement in how we handle those patients, and we talked enough about workforce development. So I hope I didn't incinerate that dead horse, but I wanted to make sure that some of these key points were out. But we really want to get to a stable workforce, predictable funding, and really a patient-centered response. So I'll take any questions.
Well, thank you. I appreciate your presentation to the committee. We certainly have a lot to understand and better utilize. Thank you for that, doing that.
Thank you for the time.
Josh Robinson. And do recall, thank you for being here and from up the road a little bit. We are on a little bit of a tight time schedule if you
Yeah, no, you're fine.
don't mind.
I promise to be brief out of
Thank you, sir.
respect for the remaining speakers today. I don't have a presentation. I just have a statement to make. First, my name is Josh Robinson. I am the Director of Oglethorpe County EMS. We are a rural service operating over a 442 square mile county in the state of Georgia. I first want to begin by recognizing the vital work being done by the Georgia Department of Public Health, the Office of EMS and Trauma and Regional Systems, and the medical directors who work tirelessly to regulate care. My position today is not criticism of their commitment, rather it's an acknowledgement that the role of EMS in Georgia has fundamentally shifted, and yet our government structure remains anchored in the past. EMS is an essential service and component to our healthcare system, providing time-critical care, responding to disasters, serving as the front door of healthcare to those who don't have a way. And it's no longer just transport, but some abuse the system that way. But given this evolution, I believe that Georgia should establish a dedicated governing entity for EMS. EMS requires a governing entity whose primary mission is the strength of our profession, who we are currently facing structural challenges, workforce shortages, recruitment, substandard pay, rising cost, and reimbursement gaps. These are not temporary hurdles, they are long-term policy issues. And a dedicated entity would allow for better data-driven planning and reduced redundancy. This isn't merely about spending more, it's about spending smarter, ensuring our taxpayer dollars are utilized with maximum efficiency to maintain the health of the entire system. And beyond focused leadership, a dedicated entity solves a critical communication gap. EMS touches virtually every facet of public safety and healthcare, yet we often fall between organizational gaps. A dedicated entity would serve as the central authoritative voice for EMS policy before the General Assembly. It would bridge the gap between providers, hospitals, local governments, and patients, ensuring that those making policy are directly informed about the realities of care in the field. The challenges of metropolitan areas are very distinct from those of rural Georgia. While one community may have multiple resources, others struggle to maintain 24-hour service across vast geographic areas. A dedicated entity could establish statewide standards while simultaneously developing targeted, flexible strategies that respect these operational differences. And I challenge you to ride along with both our urban and rural services to witness these differences firsthand. The goal is simple. Every Georgian must have access to an appropriate level of emergency care regardless of their zip code. Finally, we need a structure that prioritizes a long-term vision over immediate crises. We should be asking where Georgia EMS needs to be 10 or 20 years from now, and then building infrastructure to reach that goal. This requires continuity and dedicated oversight that is not sidelined by competing responsibilities. And I want to be clear that this is not about adding layers of bureaucracy or discarding the immense expertise currently housed within the Department of Public Health. Rather, it's just about unbundling EMS to ensure it gets the focused stewardship that a service of this complexity requires. And I'm not suggesting that local agencies lose their operational independence. I'm suggesting that we create a governance model that recognizes EMS for the critical and essential statewide service that it has become. Creating this entity would provide us with what we urgently need: a clear mission, a clear voice, and a structure capable of planning for the future. Thank you.
Thank you for your comments and for your participation today. Thank you, sir.
Thank you.
Terry Cobb with Lawrence County. Come on up. Thank you for being here. Thank you. Please pass along to your team the same, both of you, if you will. Thank you for their work.
Mr. Chairman, I appreciate the opportunity to come and speak before the committee today. I had a couple of comments prepared. I didn't have a presentation, so I'll skip what my colleagues have really covered well, just mentioning that staffing and initial education is a huge problem for our industry. A lot of ambulance services in the state have taken on that responsibility of doing the education of the initial certification to help resolve our staffing out of necessity, not out of desire. Wall times in the ER is a challenge. I would welcome any opportunity to really make a meaningful reduction in the wall times, EMS services being held on the wall. So the one thing that I didn't hear a lot of detail on that I'll talk about just a minute, which I think falls up under the control of this group here, would be the Medicaid rates in the state of Georgia. The Medicaid rates, so we have 7 HCPCS codes that we bill up under. 4 of those haven't changed since 2002. So that's almost 2.5 decades of no increase in the reimbursement while our cost does go up. So, and as the colleagues ahead of me had made a very good point, that Medicare rates don't cover our cost. Medicaid rates are roughly half of what Medicare rates are. So my recommendation to the group would be to take a look at the Medicaid rates in Georgia and consider bringing them up to Medicare rates. And I'd also challenge to tie them going forward so that we didn't end up with a 24, 25-year deficit without an increase with it. So that's my point. That's what I'd like to bring to the group today.
Well, thank you for being here with us. My understanding, when it comes to the governance question, which was raised earlier, that body, I don't believe, even the current body nor the future one would set rates. Is that right? Or would be involved in Medicaid rates? That's a different, so you're asking a different avenue at this point, right? I understand.
So the Medicaid is paid by the DCH.
And this is emergent or non-emergent?
Emergent or non-emergency.
Okay,
So there's
different
only
levels.
7. There's only 7 HCPCS codes that we bill up under.
All right. Thank you, sir.
Yes, sir.
Thank you. And now if Sharon Schwartz can join us. Thank you for being here today and for the caregivers you represent.
Is it up? Thank you. Thank you very much. I am standing between everybody and the door, so I also will be quick. So I just want to echo everything my colleagues have said beforehand. As a private EMS agency, we are, and I'll go through our footprint in Georgia, but we are dedicated to the state of Georgia and continue to grow. Currently, in Georgia, we have over 2,000 employees that are different levels of providers, and we face all the same struggles that we've discussed. So I wanted to take some time today to talk about just example of one of the companies that's doing the good work and continuing the fight, and would be very appreciative of any support we could get. So Priority On Demand is a parent company for, let me just move forward to here, to 22 different brands nationwide. What they do is we come into an area and we take a really good operation that is family owned usually, and give it some capital backing, get it into a bigger organization, and then we're able to kind of bridge those gaps between funding and service. So within Georgia, which I operate, there are 4 brands that you've probably heard of, or if not, we are all over the state, all the way from Haralson County over to Chatham. So we are in a metro Atlanta area as well. 911 services, both rural and the metro area, but also that non-emergency service that they were just discussing earlier, is a very important component of this because we are taking the load off of the hospitals to then help that throughput. So we're at all different avenues within that spectrum. And one thing I did want to talk about since we are here in our backyard was in Augusta, we do have Central EMS is operating the 911 system. And one thing that was brought up was the community health initiatives and how we can work. Yeah, I'm going really fast. Could you catch up? Thank you. So we have what's called CHIP program in conjunction with the county and both the county and the city. We provide social workers out to like the frequent users of these hospital systems. So what we in the industry call frequent flyers, the ones that are calling 911 a lot of times because they just don't have a regular healthcare provider. And so what we do is we send out social workers to their homes, and they meet with them, sometimes providing Meals on Wheels resources, sometimes providing appointments to follow up medical appointments, or sometimes even just like vision, whatever it is. But they're also bringing blankets when it's cold. And that's stopping that recurrence from that 911 calling. And we have seen such success here that we are hoping to model this in our future growth as well. But I did want, if there's any questions about this in particular, I wanted to give some time to that. And one thing I think we've discussed today, but I want to reiterate, and again, because we are in such a big swath of Georgia, we do see every aspect of a patient. So when they are calling 911 and their life is at risk versus behavioral health transports, that is a very necessary thing that we do as well. We do event standbys. So when there are football games and somebody falls down, someone has to be there to answer that, right? So we're there as well. We do telehealth visits to provide that service in the comfort of a patient's own home to, again, hopefully prevent that unloading onto that ER and very expensive visits. And again, I want to reiterate the workforce development that we keep talking about today. This is critical. We can't move forward without help to develop this. Due to the shortages that they've all mentioned, we've all gotten creative in having our own programs, and we build someone that could come working from, let's say, a restaurant industry. They could come in the door, get trained, and be a paramedic and be out there running it all at our own cost. But that does benefit the community as a whole. And then just within the parent company, I did want to talk about, we see paramedics, EMTs, ambulances, but beyond that, what Priority offers is that full continuum of care. So some of the barriers that we faced is getting ambulances on time or at a rate that's not too crazy. So we actually, as a company, created our own manufacturing plant. So we build our own ambulances so we can get there quicker. We do have On-Demand Connect, which is a way to connect via online ordering from a hospital. So they don't have to sit on the phone and order ambulances. They can actually put it in there. It's really quick. And then again, we do have telehealth, which is our on-demand visit. And then, of course, our traditional ambulances that are out with the patients. And so again, this is all part of what we've discussed today. So that same dead horse, I will not continue to obliterate it. But this is what we all face within the industry. Emergency room diversion, we're, again, through all of these different aspects, we're trying to eliminate the number of patients that are entering the ER that don't need to be there, but also at the same time increasing the throughput out. So we reduce the number that are going in, but helping them get back out. We do meet the patients and do follow-up, like that social work visit to help that transition. We are in rural areas. Again, there's a huge gap in those areas. And so we want to make sure that we're providing either telehealth or alternative providers. And I'm going to go quickly to this part here. So what we're asking is just in line with everyone else here. If we could stabilize the funding that comes to EMS, we definitely can provide more of these services that the end user definitely needs. And then also for our workforce development to help sustain that. That was as fast as I could go.
No, you did well. Thank you for, and you're right, we did have some similarities between people looking at this from different eyeballs, but also seeing a lot of the same challenges, and they give us some potential opportunities that we can consider.
I sure hope so, yeah. I think we would all be very appreciative, and I think as the world is changing, we want to change with it and provide that care, so.
Well, thank you for the service your team does for us. We do have a question from
Quick question, Sharon. Thank
President
you.
Seabaugh.
Yeah, of course.
Thank you very much for the report. You operate in several other states. Are there anything that those states are doing workforce development wise that we need to be thinking about?
That's a really good question. My focus is Georgia, of course. I think as far as like from the licensure, we are currently going through the process of trying to accredit to get our own paramedic program, working with our technical schools. Some of that within the education world is looser, if that's the best word, in other states. So I think they're able to set up their own Earn While You Learn programs quicker. I do know from a reimbursement rate, there's been different creative ways that they've gotten some of the UPL payments or whatever, just to be able to feed those programs. But no, and I think, I don't remember if it was Terrence or Chad, but The constant focus we have is we train them up, we get them going, and then they leave to go to probably like a brick and mortar institute, whether it's a clinic or a hospital, because they're getting a higher, quality of life, higher pay. They're now trained, and so we're just this constant feeding ground, which I think we can embrace and be an important part of that continuum of a healthcare provider, but we do need to increase the funding to be able to provide that.
We heard earlier from the medical college about the pipeline of continuous physicians coming through the pipeline. And I think we need to work together with private EMS academies, with TCSG, with state office, to try to figure out how to get our pipeline of EMTs, because most paramedics that are going to a technical college already have a job. So they're not really looking for a job when they graduate, but EMTs are looking for a job when they graduate from one of our academies. So I hope that, and I say this for the committee's benefit, Mr. Chairman, but I hope we can really dig into workforce development, see how we can create a pipeline of EMS workers for the future, and maybe the state put a little bit of money behind trying to recruit more young students out of high school, maybe wanting to change careers into that EMS pipeline. Because it's very important, and it's a great entry into healthcare. We lose a lot of employees through continuing on to nursing or becoming doctors and those kind of things. So it's worthwhile. We have a lot of career academies in our high schools throughout Georgia now with EMS programs, and that's kind of starting the pipeline, but I hope we can continue to talk about that and maybe work with Georgia Workforce Development and TCSG and the state office to really enhance our pipeline of EMS workers. Because that's one of our biggest problems right now, I think, in my opinion.
And I definitely could not agree more. I think we're all embracing that, and the more help we could get to build that up, I think the better. Yeah.
Well, I do know as a physician who works with a lot of these former paramedics, I know you say you're losing them, which you are, to the EMS service, but I can tell you they make some wonderful nurses, and then many of them gone on and got a nurse practitioner or PA degree as well, and they're valuable parts of the team which we put together. So maybe we have to figure out maybe the entry level in several years of work and is a pathway, but it can be a good career pathway for those individuals. But I certainly see what we need to do for EMS. Thank you for being here today.
Thank you.
Thank you. Yeah. And to all those here with us today, we are wrapping this up. We will have our next study committee meeting in Macon, Georgia at Mercer University. That'll be on the 15th of September. Matter of fact, I know one of the things we want to talk about is that rural transformation grant program and how the funding of that works, how the appropriations are arranged, and also how a lot of them are, I know it's a 5-year timetable, even though only the first year, I believe, has been guaranteed, and we're all looking to see what's going to be sustainable at the end of that as well. So I know that's something we'll be able to look at in more depth. There's both the pipeline program I heard about today for EMS in rural areas, but I know we have the same needs in our urban and suburban areas. So thank you all for being here today. Thank you to Augusta University and the Medical College of Georgia for hosting us again. And with that, I believe we are adjourned. Thank you.